and when it is less than 0.89, 3 times increase in the risk of vessel-oriented cardiac endpoints. Here again, it is possible to have a pullback trace to look for the reasons for the reduction in the functional achievement. You will find that again, the focal lesions are significant in such a situation, which will lead you to correct those and ultimately get a better post-PCI physiology. The important aspect of a pullback or pullback analysis is to get a complete idea of the longitudinal vessel analysis. And that is an additional or rather more important point than getting an absolute value at the end of the procedure. So this is an important aspect of post-PCI physiology. It can be done by the pressure wire, as I have told you, either FFR or non-hyperemic pressure ratios like IFR or RFR also is available to identify the residual focal lesions. When you find that there is no distinct focal rise, rather there is a slow pressure drift, it indicates that diffuse disease. And there is no point in placing a stent for diffuse disease. You better treat the patients with medications. Now we can combine with imaging in these situations when you pull back, because you wanted to have more idea about the focal lesions, where exactly, either like stent under expansion or malapposition, plaque protrusion, thrombus within the stent, edge dissections, incorrect stent height. All these could be made out by an intravascular ultrasound or OCT when combined with this functional assessment. Now in that particular case of LED, we found that it was 0.77, the RFR was 0.91, but we thought of doing the PCI. PCI was done, and as I told you that the FFR remained to be 0.79. What is the pullback? You'll find that pullback shows a FFR gradient inside the stent of 0.79 to 0.88, and a stent boosting, I didn't do the imaging also, but stent boosting quickly showed that there is an under expansion in the proximal to mid portion of that stent, and then it was optimized and then repeated. And you find that the PDP is 0.96 and the post-PCI RFR is 0.97. These are excellent values, and the result, this is unlikely to have an event or rather very, very low event rates. Now this is another case, an LED lesion and a circulation. Circulation is tighter, more than 90% stenosis, so that has to be stented, no requirement of physiology. LED look, the RFR is 0.88, less than 0.89. FFR is 0.7, so certainly ischemic. PCA has to be done, PCA has been done. And then the pullback, post-PCA pullback, RFR is 0.93 and FFR is 0.87. Okay, this is okay, but we found that 0.90 is cut off for the FFR, so it is suboptimal, you can call. And RFR is again the optimal value is, although 0.89 is the ischemic optimal value, they put as 0.95 from the defined PCA trial. And then the pullback here really shows that the gradient is actually outside the stent, distal to stent. It is a slow separation of the curves showing that there is only slow increase detach. Although that adoption has not resulted in a significant event reduction, it was shown that when you combine imaging, the chances of doing procedures to optimize has definitely increased. Probably it will contribute to better result of the procedure. Now another interesting thing which has developed in physiology is simulation of PCI before actual PCI. We have this methodology available with IFR, QFR and CTFFR also. In IFR you have that angiocoregistration and syncvision software adoption. You will find that you can have the IFR gradient in the circumflex lesion, the length of the lesion can be made out, and the virtual stenting showed that the 0.83, which was the first pre-procedure, the first IFR, has been corrected to 1. So what we are going to do is going to have a good result at the end of the procedure. So this virtual PCI has been validated, and the IFR gradient registry showed that the pre-procedural value and the post-procedural value agree in a large proportion of cases. So this may also contribute to have a better idea of what you are going to get at the end of the procedure, so you can have modification of the procedure done before the actual PCI itself. Now, do we have really clinical data to support that this sort of approach is really beneficial in clinical practice? We have data for the FFR in a group of patients, and when they found that the optimization has been done, the post-PCI FFR has been shifted or increased from 0.78 to 0.87. This is significant improvement. And that 0.87 is associated with the reduction in death, the upper panel, and 0.85 is associated with the reduction in the TVR. Now, defined PCI, again, I told you that the IFR cutoff is 0.95, and it has been shown that after 1 year results by Patel had shown that the cardiac death, MI and TAVR, and cardiac death and MI hard endpoints all are reduced when you achieve a post-PCI IFR of 0.95 or more than 0.95. Target FFR is again a similar trial based on the FFR pullback, and again it was not a very positive trial, but again showed that FFR guided optimization strategy at least reduces the number of lesions with less than 0.80 or suboptimal PCI rate, the post-PCI physiology could be reduced by these optimizations. And defined GPS study we are looking forward to, because we don't have a randomized control trial of a large number. This is a randomized control trial where the physiology evaluation versus angiographic evaluation, and the trial is ongoing. We'll get that right. So I would summarize that suboptimal post-PCI physiology is quite common. We have to look for that. It is independently associated with future risk of MACE. However, the predictive value is modest. Longitudinal vessel analysis helps to identify the mechanism of low post-PCI physiological value. It's not the one number or 1 point. You have to do a pullback or a vessel analysis has to be done. And the clinical benefits of physiology-guided PCI optimization has been demonstrated in various trials, but we do want a large randomized trial, which one is looking forward to. And pre-PCI information from the so-called simulated PCI may help us to have a better strategy for getting a good post-PCI physiology. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Bahulian. Very fantastic talk. I think this is something that we are looking forward for, and more data to come out.
Right.
And I think everyone should follow the typical steps of pre-dilation, stenting, post-dilation, appropriate size, about 0.25 or 0.5 millimeters more than the stent that has been used, and then perform FFR or IFR and see what value that we get. I think this is an area where a lot of research is ongoing right now. Any comments, Dr. George?
Yeah, I think, optimization of PCI using IVUS, OCT and FFR is the thing which we have to start practicing more and more, because the outcomes do change, and we have seen that from the ultimate trial, and now with the FFR also we are expecting to have similar outcomes. The only thing is that sometimes in those complex situations, even putting a FFR wire upfront is also a very good idea. In situations where there are multiple lesions, you pre-dilate, you keep knowing the FFR at all stages, or the RFR. Basically, so instantaneous, these values are very useful, and then final pullback run is to be done in these patients.
Yeah.
And many times we have to do optimization if the FFR wire is there. So that is something which we have learned over a period of time.
Can we calculate residual functional syntax in multivessel multisegmental PCI? Residual syntax less than 8.
Residual syntax score.
Residual functional syntax.
Yeah. Functional syntax.
Residual functional syntax has not been validated the way in which I have told. In fact, even higher syntax score patients, as shown up in I think a FAME-3 trial, they have shown that the usage of physiology has been useful to get better post-PCI physiological values. Yeah. So as Praveen has pointed out, I will also agree that in certain situations of bifurcation lesions, you can keep the wire ahead and try to find out what is happening to the side branch, and then complete the procedure if the side branch physiology is negative.
Yeah, and also, now increasingly with the QFR software.
Yes,
I am not practicing that right now. Maybe Ramesh or Dr. Shiban Are you practicing the pre and post QFR, because then you don't have to put a wire also?
Yeah, we are just doing with FFR CT right now, but we're getting cath works and medicine to evaluation into our hospital.
I think post PCI FFR is more well established in LAD lesions actually.
Yes.
Still circumflex RCA data is lacking.
Yes.
Yeah, we are practicing that, but not routinely. Not routinely. When we have the suspect that there is some problem, of course we'll use FFR. Yeah.
Dr. Manoj.
Yeah, Professor Bailan, fantastic talk to listen and to upgrade our knowledge in this current scenario.
You are
My
not
question
audible,
is,
Manoj. Little louder.
Please speak loudly, Dr. Manoj.
yeah, my question is, when we optimize the PCI outcome with a stent, with all the parameters by the image guided, even after the image guided optimization, would you still consider a physiology-based assessment in that situation?
Well, I think that is again an area which is not definitely, we can't give a definite answer for that. I told you that we have post-PCA physiology done by the pullback tracings and the FFR React, and then on to that, the IVUS analysis has been done. And they found that in the case of IVUS usage in that particular situation, the number of times you have to optimize. Say, for example, to use a higher size balloon or a higher size pressure or an additional stent, these procedures were more when we used having IVUS. So I think that is an area which is to be investigated. Whether the post-PCI physiological guidance versus an image guidance or a combination. I think that is the next stage of the ongoing.
One short final question by Dr. Anil.
I think we should not forget that FFR is a continuous variable. And we should not run away from the fact that we recognize this. When the defined PCI results came, we were all alarmed that 25% of what we have done is inadequate.
Yeah.
But truly, we can define it better. And if you have a defined PCI-like result, then you probably do imaging and decide what you can do. If it is focal, you can relieve it. If it is diffuse, you have to leave it and rely on medical management.
I think that is what is Alan Jeremias is more forceful, and he is pursuing to get a 0.95 in each and every case, so that the human rate will be practically nil. That's what we'll get the results soon.
Yeah. Thank you, Dr. Bahulia. Next, we'll move on to Dr. Imad Shaiban. He'll be giving the talk on left main bifurcation. Any comments from the moderators? Actually, we need to keep you informed.
Good morning. Good morning to everybody. I'm going to go through the debate, simple or complex stenting for distal bifurcation, left main bifurcation. We have different scenarios, and we know that the key of success every time with any scenarios is a good clinical indication, to keep it simple as possible. Not always we can keep it simple. Plan your procedure according to the complexity of bifurcation lesion. Stepwise approach every time. Intravascular guidance is highly recommended both in simple and in complex. And of course, lesion preparation, stenting, optimization to get the best outcome. Then the clinical indication, I think we have so many scores to evaluate for any patient. But again, the first step is the good procedure. We start from a good, appropriate indication. Then coming to the bifurcation, the clinical relevance of side branch does matter. Because if you have a small side branch, then covering small amount of myocardium, it is not important to optimize, but keep it open. When you have a big and covering more than 10% of myocardium, then optimization and optimal result should be obtained in order to have to keep the good prognosis for the patient. Second, side branch size, of course, does matter, as well as the side branch angle does matter in deciding whether it is simple or complex. And the lesion length on side branch is also very important. You see from this meta-analysis that when you have a side branch disease extended for more 10 millimeters, then two stents, that means complex stenting, is doing significantly better than simple stenting, that means provisional stenting. It is an old problem, and you see that from the guidelines of 2011, the indication was provisional stenting is the default technique, but with complex bifurcation morphology, two stents will be preferred. Now, what is complex bifurcation lesion? It is not well defined. European Bifurcation Club is recommending to adopt the Medina classification for clinical use. We know that it is excellent classification to describe the type of bifurcation lesion, accordingly to only the involvement of main vessel and side branch, but it is not good to define the strategy for the treatment, because there is no information about the extension of disease, the angulation, calcification, and so on. So many characteristics which does matter in selection of strategy. And now, if you look on the recent consensus coming from the European Bifurcation Club, the European Bifurcation Club adding something more to the Medina in order to define the complexity, and this including the extension of disease of side branch as well as the morphology of the lesion. Now, how we select the appropriate approach? I think today we have something more, which is the definition criteria, defining what is complex and what is simple, based on two major criteria, on severity of lesion in main vessel and side branch, and the extension of disease of side branch, and 6 minor criteria. So when you have one major criteria with more than 2 minor criteria, the bifurcation lesion is defined complex, otherwise it's simple. And according to this definition, you see that if you are approaching simple bifurcation with simple stenting, this will be superior than complex stenting. But on the other hand, if you had approaching a complex bifurcation with 2 stents techniques, that means with complex stenting will be better than provisional than simple stenting in complex bifurcation. And this was also confirmed, including distal lift main, in definition 2 trial. So to summarize, when in bifurcation lesion, if the side branch is not relevant, just keep it open. If it is simple, defined by definition criteria, simple stenting is the default strategy. And if it is complex, accordingly to the definition criteria, the approach will be complex as default approach. And intravascular imaging, of course, are highly recommended. You see that both IVUS or OCT are now in class 2A for myocardial revascularization for European bifurcation, European Society of Cardiology. And of course, the lesion preparation, it's another important element. That means if you have to debulk where it's necessary to debulk, to have the maximum expansion of the stent without any deformation or any malapposition. And you'll agree with me that without intravascular imaging and debulking, you will never get results like this in situation with diffuse and severe calcification. Now, let's go to strategies. The mostly used are what you see here, simple bifurcation and provisional stenting, then complex stenting with crash, DK crash, mini crash or DK crash, T or TAP, and cool-out stenting. What is different from the past? I think all strategy of bifurcation lesion approaches have been improved because of we have different platform, different designs, more appropriate strut opening and thickness, more detailed data coming from bench testing and clinical practice, more use of intravascular imaging, improvement basic strategies, more criteria to define simple or complex bifurcation according to the anatomy and characteristic of patient as well, and more clinical data with improved outcome. And you can see clearly that we are not dealing with the old stent, but new stent, that means contemporary stent, can permit us to do things that have not been possible in the past. Now the simple is provisional stenting, and actually, just to very quickly, this can be done in 3 steps. The first is wiring apply dilatation, that means lesion preparation, then stenting main vessel, then pot with appropriate sizing of the balloon, and if you do not have any compromised side branch, the procedure is finished. That is why it is simple. And if you have something on side branch, you can correct that by recrossing and kissing balloon and repot, and all will be in place. And the complex DK crash, again, we have much more steps here, and we have to follow exactly the steps. And you can see again, just to show the stepwise approach in the complex things, starting with defining the procedure with intravascular imaging will help much more than angiography alone. And then lesion preparation are the first steps, stenting the side branch with a balloon in the main vessel, crushing the stent, the protruding stent in main vessel, that is the third step, and then rewiring again. And the fifth step is separate inflation first and kissing balloon, first kissing balloon inflation, and after that stent deployment in main vessel, pot rewiring again, side branch, and then separate inflation and second kissing balloon and final pot, and then the final angio and the final intravascular imaging in order to be sure that everything in place. Also with other approaches like TAP, like mini crash, like DK call-out, you can obtain following step by step, you can obtain optimal results as well. The main thing is to follow, to do your procedure stepwise, and to check by intravascular imaging that every step have been completed optimally. Now, which is the gold standard? I think we do not have any gold standard. You see here that from this meta-analysis comparing what we are using today in our practice to provisional stenting, showing that maybe that DK crash might have more advantages than the other approaches. However, if we look on this meta-analysis, again, comparing the same thing, and this is ranking system goes from 1 to 7, the best is 1 and the worst is 7, and you can see that every approach has his pros and contras. And from the most recent trials, that mean EBC main trial and DK crash 5, can see that there's a big difference in the outcome, but that is because these two trials cannot be compared, since the characteristics of patient included were completely different. In EBC main, the patient included are mostly with simple bifurcation lesion, while in DK Crush 5 were complex bifurcation. The outcome, the clinical outcome, I think it's clear to all of us. When you have say high syntax score, the surgery will go better. Otherwise, angioplasty will do a good job. So my conclusion is that key points for patient selection is as we have good clinical indication, the strategy make it simple, in simple bifurcation where upfront strategy is still provisional stenting. However, keep in mind that 20% of these patients will shift to two-stent strategy. Make it complex in complex bifurcation defined by disease extension and severity, and as well as by the anatomical characteristics of bifurcation lesion. Keep in mind that all two-stent strategies have their pros and cons. Optimal one is that well-performed and optimized, and of course require good experience, stepwise approach, planning the procedure accordingly to lesion characteristics and complexity, and lesion preparation, good stent expansion of the position, and final optimization. Finally, good operators should have experience in more than a two-stent strategy and be ready for plan B, which might be necessary during your procedure. Thank you very much for your attention.
Thank you. I want our moderators to make some comments. We have about maybe 2 minutes. Any comments?
Dr. Shiban, nice talk. I want just your opinion. While large circumflex artery, dominant circumflex, for provisional stenting from LMC to LED, whether you do a kissing balloon at the end to keep the struts open in circumflex?
You mean in provisional stenting?
Yeah.
Well, actually, if you do not have any compromise on side branch, I think it is not necessary. It's not mandatory, and this is also recognized by European Bifurcation Club today, which was recommending kissing balloon and final pot in every provisional stenting. I think sometimes going or crossing the stent, doing kissing, you might deform something that have been done optimally before, without kissing. So I would avoid where it is not necessary.
Even if you do a circumflex ostium, left main to circumflex, and large huge LED, type 3 or type 4, what's your status? Same?
I think the main thing is to be sure that you have access to main vessel, that means to circumflex. And that could be tried. You can take a balloon and cross the stent and see whether you have any impediment to cross. Otherwise, I mean, you can leave it without doing anything.
Yeah, before you say that the ostium is not involved, please make sure that you do imaging to be 100% sure that there is no disease in the ostium for your questions, whether dominant LAD, dominant circumflex, things like that. I think that is an important point, whether you need to attend that or not. Dr. Manoj, followed by Dr. Sharma from the audience.
Professor Master Shiban, it's wonderful to listening to you. My question is, we all know here that the angiographic assessment of any vessel has its own limitation. So after provisional stenting, would you just be happy with the flow angiographically to assess the major side branch like a circumflex, or would you consider in the absence of a side branch physiology to just leave the stent alone in the left main LAD?
So angiography alone will be, you are happy for the side branch assessment, or do you want something else?
I'm happy to leave it. I'm happy to leave it. If it's no compromise there, I'll happy to leave it.
DK Crush 6 looked at that, right? You are part of it. FFR versus angio-guided side branch assessment. There is no superiority of FFR-guided assessment of the side branch.
I mean, if you do not have any sign of ischemia, no chest pain, flow ischemia 3, that means you have a good flow and no necessary to touch anything.
Dr. Sharmaji.
Buongiorno, Professor Shiban. It is about the double crushing or other techniques. Is it really very important to cross with the distal strut, proximal strut? Because there is a lot of controversies.
That is another long-lasting discussion. I think all these things are coming from bench testing. I think there is a rationale in DK crush not to cross distally, because sometimes you have a gap between the stent and wall vessel on the osteomocyte branch, and you might cross abdominally. That means outside of the stent, and then when you are inflating your balloon, will cross the stent. So try to cross more proximally in DK crush. In any other procedure, and including provisional stenting, I think without checking with OCT and not with Hybiz, you will never be sure where you are crossing. So it is, let's say, it is a conceptual, good conceptually, because coming from bench testing, but we do not have any clinical or any clinical data supporting distal or proximal crossing.
Thank you. So Karina is the most important thing. Yeah.
Thank you. Thank you very much, Dr. Shaiban. Fantastic talk. We would like to invite Dr. Sanjog Kalra. So Dr. Sanjog Kalra specifically is going to talk about when and what type of device to be used in cardiogenic shock. You know that people believe that North Americans always put impeller for every patient. And I want to disprove that point. So Dr. Sanjog has been given this specific talk.
Thank you very much for the opportunity to address you on this last day of NIC. I like that Ramesh gave me this talk, because the real story is that I had the how do you manage pulmonary embolism more contemporarily before this talk, and I said, look man, I do this much work well, and that's not one of those things that I do. So I can tell you a little bit about the Canadian system and how we do things a little bit differently than we do in the US, where money is actually quite a bit tighter than it is in the United States. And so this is more of a rational physiologic approach. It's not a ton of data, it's instead more concepts. These are my disclosures. Consider two representative cases, right? We're going to bring shock into the cath lab. These are both mine. So this is what I call the sick but stable heart, 62-year-old non-STEMI and heart failure. He's got an open lima, closed vein graft, EF of 20%. So not overly terrible anatomy. And you can see that there's a very tight ramus here that is the probable cause of this guy's non-STEMI. So my plan here, despite the poor EF, because no, it doesn't make sense to put support devices into everybody, I was going to get in and get out. And of course, best laid plans, right? So the wire goes down, the patient starts becoming extremely ischemic, gets bradycardic, gets short of breath, starts complaining of chest discomfort, and we're in trouble. These were the pre-PCI hemodynamics. The heart rate was 100, the blood pressure was 95 on 70, so pulse pressure was borderline. The PA pressure was 60 on 24, mean 36. So this was already a decompensated scenario with a wedge pressure of 22. The cardiac index is 2.01. So clearly a low output state. Maybe not shock yet, strictly speaking, but a low output state at the beginning. Compare that to this case. This is the well heart, but the worrisome course. 58-year-old hypertrophic cardiomyopathy, has a recent successful ablation actually, and then comes in with some funny symptoms and decides to come in for another angiogram. And then of course, this is the first picture of the angiogram, because there's a giant clot that comes out of the sheath in the leg, and upon engagement into the left coronary system gets injected down the left coronary. So that guy's course is probably going to be different than the first guy's course. How do we talk about these two patients in the same way, and how do we use that conversation to try to target our tools to the right patient? Well, this is the new SCI shock classification. This was supposed to be a common language where we started talking about at-risk patients and how they differ from patients at the beginning of shock versus those who are in classic or deteriorating shock. And then most of us recognize the extremis patients where they're just circling the drain or going downhill quickly. But I ask you, if you look at the two cases that I just presented, they're both very sick patients, but where do they fit here? Who's a C, who's a D, who's an E, if they're in the throes of an acute decline? That's where we face the challenge about trying to target our devices, because in the super sick patient, it's pretty clear that they're going to need some sort of support, and they're going to need as much support as you can give them safely. For the not particularly sick patient, but who you know is declining in front of you, You need to pick something, but you don't want to overshoot the vasculature compromise that you're going to get with ECMO when a balloon pump will do. So how do you target these things? Well, it comes right down to the same goals that we put forward for any sort of shock therapy, right? Basic goals. Improve systemic perfusion, because patients come with a reserve in all of their organ systems, and for every hit they take, we lose viability, right? That's this whole concept around elevate, not escalate. Don't wait for organ systems to fail before you start to increase the amount of support you're providing. Instead, give the patient a net, give them as much support as they need, and then start retracting that support as their body demonstrates competency against the biological insult, and do so in the safest way possible. The second goal is rest the heart, right? Improve myocardial oxygen supply and demand. Try to reduce the amount of work that the heart has to do to fulfill goal number one, because any more work in an already injured setting means that you end up with a more injured heart in the end, not just the beginning. And this bears out, right? Because as we realize, as shock gets worse, people do worse. And there's a litany of papers now that show that the worse the sky stage is, the worse your outcome's going to be. And so the message that this all gives you is the sicker you get, the more likely your outcomes are going to be poor, and therefore the more work you have to do to pull a patient back from the brink to safety or to an envelope where they're going to be able to recover. And so we modify the basic goals of therapy from systemic perfusion and myocardial rest to add in one more component, which is get control fast. Early and rapid reversal of hemodynamic collapse so that we end up with more organ reserve left. So how does that then affect which device we choose? Well, this is where the practicality piece starts to come in, because we recognize that 30-day survival rates from 2 decades of cardiogenic shock trials tell us the same thing. All of your wins are here, right at the very beginning, because the longer you wait, the more organ systems you lose. So this is the hemodynamic support equation that Naveen Kapoor put out some time ago. And this is a really smart slide that I'm sure many of you have seen, many of you have used. But I think it's actually worthwhile considering each of the individual components so that we can try to tailor a support solution to what our patient needs. Let's consider our first guy, where the problem was largely a sick heart, a poor baseline already. So this guy had systemic perfusion and has lost it transiently. The LV in his case was already badly loaded versus the first guy where the LV may have a degree of reserve. He started with a normal EF in the second case, whereas the first case was very, very poor. And then coronary perfusion in the first case was subject to ischemic preconditioning. We just happened to be in an effectively only remaining segment vessel that resulted in that hemodynamic collapse, versus the second patient where almost all of the coronary perfusion was taken off completely. So as a result, if you're going to think about an individual where your priority is going to be to reverse the systemic perfusion insult, you're probably not going to worry about a device that's going to deal with your coronary perfusion optimally at the get-go, right? What you need to do is save the body. Versus for somebody where, like the first guy, your coronary perfusion is what you care about most because that's really what you've changed, then you may choose a different device. That might not be the guy you put on ECMO right away. You might think about something else, right? So how do you develop a protocol to try to help yourself work through these things? Well, we've heard about a lot of different protocols. Here's the one that we use at our site, right? It doesn't look all that straightforward because it isn't, right? You have a shock team concept where you have individuals that are involved in decision making very early that span a number of different areas of expertise, including heart failure, interventional cardiology, cardiac surgery, and intensive care. And all of these individuals bring their own knowledge to bear, bring their own interpretation of that mechanical circulatory support equation to try to give you an understanding of which way to go. And the reason that we need that shared decision-making model is this. There's a lot of questions that are open, right? We don't know a lot of stuff. Is it acute or is it chronic? Is this the decompensated heart failure patient with walk-in low output that decompensates further? Or is this the guy where I injected a bunch of clot into his left main? Is it happening at the start of a procedure? Is it an expected complication or is it a patient walking through the door? Is this a remodeled heart with an LV of 7 centimeters? Or is this an acutely decompensated heart where there's no preconditioning? Is it ischemic? Or is it valvular? Or is it underlying heart failure? And what's the shock phenotype? So this is now where we start to get into how to select a device. There are 4 key questions that you have to ask. Is it really shock? And if so, how bad is it? What is the baseline heart function, etiology, and shock type? This is going to the analysis of that mechanical support equation. What do you have, practically speaking, available to you? If you're in the cath lab, what do you have available in your lab? If you're in the ICU, how fast can you get to a place where you can implant a device? And what can the patient handle? So now we pull ourselves back to that sky shock classification and start to add a little bit of granularity. And that's this. Right, where we know that as sky shock stage progresses, you end up with worse outcomes. We know that these are sicker and sicker patients the higher and higher you go. Using a large contemporary data set out of multiple centers in the United States called the Cardiogenic Shock Working Group, this has been developed, where they took over 1,000 patients and they just analyzed all of the 2,200 data points for each of those patients to try to figure out how to parse this out. And what we recognize then is that your sort of sky stage C type of patient is the one that already has an important degree of organ compromise, right? Your lactates of 2 to 5 on one drug or one device. Versus D, where that's starting to progress into lactates of 5 to 10. Versus E, where it's lactates of over 10. And notice that B, C, and D all have about the same blood pressure. And that's why that's not a particularly useful concept. That's why we use things like cardiac output to conceptualize how bad shock is. Because blood pressure lies to you. The body's smart and it does a really nice job of compensating for vasodilatation or for poor cardiac output by vasoconstricting and maintaining output to the core. So this is just something to tell you about how heart failure might differ from acute MI, where as you progress in sky stage, everybody gets worse. But what we learn is that at your maximum sky stages, your acute MIs in C, D, and E have a much higher mortality than your heart failures. And this speaks to the importance of those compensatory measures. And what we understand is that when you have a hemometabolic shock state, where you've got a compromise in the body's systems, as well as a compromise in the heart function, your in-hospital mortality is so much worse. You have shock phenotype 1, which is just a heart problem. Moving forward to shock phenotype 2, which is a heart and kidney problem, right? That's your cardiorenal syndrome. Moving to phenotype 3, where now you have liver congestion, shock liver, etc. And so as you progress forward, you have to look at the different devices and see what problem they are capable of treating. Your balloon pump is good, and it's not a useless device, right? We have some people that respond very well to this device. It's fast. But downside is, in order to counterpulsate, you need pulsation. The Impella, it's moderate support, it's reasonably fast, but it does require a larger access. Versus ECMO, where it's a full support with an oxygenator. But in high BMI patients, you may not get enough support, and it requires prep time and the priming of a circuit. And then, of course, there's this. This was my very first axillary Impella case, because this is what this lady's groins looked like. So there's the practicality aspect as well. What can the patient handle? So just as I conclude, this is how these cases ended. I ended up putting an Impella in this patient because I needed more support than a balloon pump would give me. I felt real good because I managed to do a hit and run and get out. Unfortunately, he died later that day from ischemic gut. He went up to the ICU, but that hit in the cath lab, because his disease was everywhere, took out a piece of his gut, he had a watershed infarct, and he perfed his bowel and died. And so this speaks to the importance of not messing around and making sure that you plan. And that might be our most important support device, our brains, so that we predict the problems from happening before they end up happening. Versus, and this was, by the way, this was the case 2 after aspiration. We managed to get flow down the left main. This is the guy where he injected a bunch of clot. He got worse despite an Impella being in place, so he ended up on ECMO and then actually ended up doing well. So for me, this is my IABP population. Relatively early shock, relatively modest LV dysfunction, where you still have a ventricle that can counterpulsate. Then comes your workhorse device, where you start taking care of the majority of SCI C shock and SCI D shock in its early phase, because that's when the problem is still a heart problem, or at worst, a heart and kidney problem, where you don't really need an oxygenator and you don't need to unload the RV. Versus here, where now you've got RV compromise, you've got LV compromise, and you're going to need biventricular support, plus or minus an oxygenator. That's how I select these types of devices. And just as a last thought, there's a reason why IMPRESS and similar trials have failed, because cardiogenic shock is a very heterogeneous population. And so it's important for us to recognize that there are some patients that go beyond where a mechanical circulatory support device can fix them. Right? We don't have a device that fixes anoxic brain injury, which is how 50% of the patients died in some of these trials. And so it's important to recognize maybe it's time for a futility score. Something to be able to tell us that our time is going to be best spent with the patient's family, helping them understand that unfortunately their relative will pass away. So for the cath lab environment, this is sort of the way I think about these things. This is my rapid deployment device selection algorithm. IABP early shock, where I expect there to be a quick fix in place, versus VA ECMO, profound biventricular shock with hypoxemia, the RV down, or we're in multi-organ failure. That's that SCI phenotype shock 3, versus Impella, where that's your workhorse in AMI cardiogenic shock, deteriorating LV shock, or in individuals where you feel like you're going to get a fix, but the effect is going to last for a day. Thanks very much for your time and attention.
Thank you very much for a fantastic presentation. We do not have that much time for discussion.
Apologies
because we have some delay, and we'll go directly to the next presentation by Ramesh. He will present current management of pulmonary embolism. Please.
Can you bring up my slides, please? Yeah, so though we do not have any evidence yet for cardiogenic shock and devices, definitely this is what we are working towards. But my talk is on current management of pulmonary
also sit there. Ramesh, I will take Ramesh to sit there and request Dr. Akasaka to come to the stage, please. We will go to the live case first to the Samir Dani. So in the meantime, Dr. Jay Shah, Ankush Gupta, Akasaka, Suresh Kumar KP, Dani, Rakhav Sharma, Ali Shafiq, Rashmi Xavier, Stalin Roy, Guru Prasad Naik, please come to the stage. Madheshwaran, Paula Chandrasekhar, Rakendra Singh, Guru Chaitanya, Anupam Jaina. Please come to the stage and start the proceedings. Ramesh, go to Samir first, please. Samir is already there. Yeah. Samir and Luca Test are doing the case. Yeah. Samir, we are with you.
Good morning.
Good morning. Good morning. Good morning.
Ramesh here, and I'm with Dr. Akasaka and Pratap here as well.
Hi, this is me and Dr. Luca Testa. We have my cath lab staff, Shailesh working with me, and we have our cath lab chief technician, Mr. Valera, Dr. Danya, Dr. KP, and Dr. Jai Sangvi will present the case. Can you, Jai?
Yes. Good morning, everyone. We are doing a live case presentation from Apollo CVHF Hospital, Ahmedabad. Our chief operator are Dr. Luca Testa, Dr. Samir Dani, and I will be presenting a very small brief about the case, today's case. She is a 57-year-old female. She is a known case of, she has unstable angina since 1 year, known case of hypertension, hypothyroidism, with moderate LV dysfunction. Her angiography was done outside, which shows triple vessel disease. Then she was admitted to Apollo CBHF on 26th with the complaint of chest pain relating to shoulder and back associated with breathlessness on and off since last 1 year, which aggravated in last 4 months. Her CAG done outside, which shows triple vessel disease and advice for CABG versus multivessel PCI. On her ECG, there is a QS pattern in inferior leads.
I don't know why.
So her CAG report shows that left main is normal, LAD ostial to proximal shows 95% calcific lesion, mid also shows 95% lesion, OM1 shows 90% lesion, and RCA is 100% totally occluded from proximal segment and which is filling through left system. So we did primarily this patient, we did LAD and OM angioplasty. With multiple, with Sion wire and pilot 50, we crossed LAD. And with multiple use of balloon, we pre-dilated this segment very well. And then we put a stent of 2.75 by 48 at 9 or 10 atmosphere. And then we post-dilated with 2.75 by 8 and 3 by 8 at higher atmosphere at 14 and 16. Then we did a OM angioplasty. Yes. Then we did the OM plasty, which show where we put a stent of 3.5 by 28, and we post-dilated it with. So these are the angiographic result. There we can see that LAD 95% calcific proximal segment in mid OM. Also there is a 90% lesion, and we did a angioplasty of LAD first. The fourth picture shows the LAD end result. Here we can see that OM lesion and the post-procedure, the OM angioplasty. So right now we are doing a live case of RCA chronic total occlusion. This is the RCA vessel, which is good collaterals from left system, as we seen on the angiography before that it is filling up to the crux. So here we are planning for RCA to open.
Okay.
With we are planning that we can take a biradial approach for CTO lesion with a guiding catheter, microcatheter use, and we can use a wire of Fielder XT family, and we wanted to dilate this lesion as well with a long pre-dilatation balloon and cutting balloon. And our debate over here is whether to use a standard practice of drug-eluting stent or DCB we can use over here, as the lesion are long and calcific. So it's up to Dr. Samir Dani, sir.
Samir, can you hear us?
Yes, now we can hear you.
Yeah, thank you. So what was your strategy? What did you think about this one? I think let me ask first with our moderators or our chairpersons here. Dr. Akasaka.
Yeah. So RC total occlusion, they are applying right now?
Go ahead.
Yes. And already yes passed, right? Yeah.
Yes. Yeah, we passed occlusion with a Fielder XTA.
Right.
We thought that there was an antegrade channel and a short occlusion. We will show you from the beginning.
Right.
Okay, so let's go to the first view.
Sir, question. Hello.
Hi.
Sir, I wanted to ask one question. Why was a simple JR taken? Why not an AL? Because this we are taking it as a dedicated CTO, so probably a choice of AL might have been a better option.
Yeah, well, actually, if I can make this comment, I mean, we agree with you. I mean, actually, the first idea was to challenge this very relatively short occlusion in order to better understand what is the situation. I have to tell you that now we are facing some problems in crossing with the gears because the wire was relatively easy. Point is that now we don't have a lot of support. So it's a key for discussion is, I mean, definitely when you are taking, CTOs for the right, the very first thought in your mind should be to take an AO1. But we see, of course, we are here on a live case to discuss. Yeah. And definitely we increased our support using a guide extension, but it's not working very well. So definitely, yes, you made a good point. But anyway, please, Luca, Samir, show what we do.
So, Luca, this is a very good point. I think first one in the CTO session is the choice of guides that we address. Number two, you have dual injection here, and so you're going to talk to us about dual injection. I don't think anybody can say that there is a good retrograde channel here, right?
Go to number two, yeah. Please. Yeah, so the retrograde channel is not great. We felt that there is a competitive flow from some integrate channel. And there was, if you see this both simultaneous injections carefully, there is a short segment of complete occlusion, and there is a long channel of subtotal occlusion with some antegrade flow beyond the occlusion.
Right, there's a micro channel which is very good, antegrade.
So we decided to explore that, and as Dr. Luca pointed out, we had this GR in place, and we thought that it might be, comparatively easy to pass the wire, and it was not very difficult to pass the wire. Can we go to the next stage? This is the bullet in the epicranial view. Next. Next.
Wire.
Yeah, so this was Pine Cross with a Fielder XTA. Next.
So we also have Poonam Velagapudi with us as a chair here. Poonam, what do you think of your choices of the wires that you want to start with?
Well, if I can actually
even I can do this. I think it's a straightforward antegrade. I agree with the Fielder XT, and if this didn't work, probably I would have gone with a pilot and then advanced it to Gaia prop.
Yeah. Well, indeed, we asked for a Gaia 2, but it was not needed because at some point with some manipulation, the Fielder XTA managed to reach the distal segment. The point is that now we are in a different step, and we dilated with a 1.5, the proximal part up to the mid part, but it still is not possible to cross with the 1.5 balloon till the distal end in order to really, prepare the occluded segment. Nevertheless, we now have a Guidezilla down the vessel up to the mid segment, and we tried with a 2.0 in order to easily advance the Guidezilla, but also we tried to cross the occluded lesion. It was not possible. So we are making a step back, going back to 1.5, and see if we can prepare this lesion. Obviously, if it doesn't work, we need to change our gear. One of the things that we need to remember when dealing with CTOs is that if one strategy is not working, there's no way that it works just because of time. So you need to change something. In other words, I would say, now the wire is in place. Now I can show you what we have so far. Okay, that's the position that we achieved. It was very good and basically checked by the contralateral flow. But what I would like to show you now is that here we are. So we have the Judkins, we have the Guidezilla, we have the wire in place, and now, as I said, we are going to try with a 1.5 again to cross the mid-segment. It doesn't look very calcified, but definitely is clearly fibrotic, and it's behaving like a calcified lesion. So, in other words, it will take some preparation for us. Our idea is to create enough space to do the imaging, and then to discuss what to do next. Samir, what do you think?
I agree.
This is what we need to do.
Yes.
You didn't switch the wires, Luca?
Sorry?
Yes.
You didn't switch the wires yet?
Not yet. Not yet, because I could not reach the distal segment with a fine cross.
Okay.
So this is for, for our younger colleagues. Okay. I mean, this is absolutely crucial. Before exchanging the wire, you need to make sure first that your position is inside the lumen. Right. Second, that you can get that position, distal position, with a microcatheter. Because if I take this wire back, I will not be sure that I can cross again with a different wire. This wire is a taper wire, is very hydrophilic, is very lubricious, so it goes very well. So it is impossible to anticipate that I will have the same performance with another wire. So now the work that has to be done is to prepare the vessel to be crossed by the fine cross. And then we will exchange the wire and we will proceed with other steps of the CTO occlusion.
Okay.
You agree with that?
Yeah. Dr. Ajay Swami has a question from the audience.
Please.
Not a question, just a comment. Two things we could have done. He's got a very nice proximal branch. You could have anchored a balloon in that and crossed things. It's a very,
this
very
is another
big,
option.
long
This is another option. And well, I personally prefer, if it's possible, I personally prefer to increase the support of the system by using a guide extension, because I think it's probably safer, in particular in this case. Clearly, when you have such a proximal branch, you can anchor. Sure, it's an option. But to be honest, if you look at the position of the Guidezilla, of the guide extension, it looks, it looks okay. It looks okay. But definitely is the whole system has to be prepared in order to cross this lesion. But definitely, as you said, one option is to anchor. And that anchoring is okay.
And while Luca is going in with 1.5 balloon, I would just draw your attention to the fact that, the other guide, the catheter in lap system, stopped showing pressure, so it is probably thrombus. It's very important to keep track of such things.
I mean, do we really need a left side guide now, Samir?
Yeah, I know, but I'll have to take it out and flush it.
Right, the collaterals are not so great. I can't actually see anything that the left system is doing. Dr. Ajay Swami, one more comment, do you think?
Same thing I wanted to say. The next thing is that maybe you could use a tornus. You don't need to change anything. If you have a tornus, a 2.1 will
It's a
cross.
good point. This is a good point. We decided to go
basically,
with
Ramesh, it is actually a balloon uncrossable lesion. So balloon
Yeah, more or
uncrossable
less.
lesion is actually, there are ways. You have to change the microcatheter to either to a torqueable microcatheter. You can use even a Corsair Pro XS if it is not available. Or then you take a smaller balloon and dilate and create a path. Why you are
This is what we are doing is 1.5 at 20 atmospheres. And I'm not worried about blowing it up because it may happen. And if it does,
we don't know because you actually gone into subintimal and then intimal also is a possibility where the balloon uncrossable.
Yeah. Let's see if we deflate. Okay, that's lovely. As you've seen, I advanced a little bit the guide extension, which is what I was trying to do. Now, I'll do exactly the same technique to advance the balloon. Let's see if it goes now. It doesn't, really. Okay, so I think I need a new one because you see the position of the guide extension is more, let's say, it's better than before. So if you don't mind.
Luca, now do you think that the ambulance catheter would have been a much better choice than an JR?
Oh, yeah. Yes.
Now if
yes,
your retrospection, in retrospect, you can tell that it's amplats with a guideliner or
yes, but one of the main consideration that we did at the beginning is that this lady is a very small body size.
Yeah.
So
several ways to...
No, we are not Italians, basically.
Indians
are very tough coronaries,
Yeah, I agree. I totally agree with you.
Yeah,
and the point is that of course, we got time now to change it. But I have to say that we need 1 more centimeter to open, and then the procedure will be much easier. I would like to have a new a new 1.5, or even smaller if you have.
1.25, sir.
Do we have 1.25?
Yeah, I think several ways to skin a cat, but majority of the people would have, I mean, at least including myself, would have chosen an AL 0.75 guide. And as we talked about, first try to get the microcatheter. If you want to take a tip injection, you can do that to confirm.
I think so.
And then actually start dilating. Because if you're in a dissection, as Dr. Pratap Kumar was saying, now after the guide liner or guidezilla is going through the dissection flap and you're creating worse.
You know what? I mean, actually I use the Fielder XT. And
Right.
as you know, this technology is very, it's very soft to the tip. And what is more likely...
injection.
Yeah, what is likely is that we crossed through the macro channel, and then, considering that the retrograde check was absolutely fine, the tip of the wire was definitely in the true lumen, I'm kind of, persuaded that is okay. So I can really work hard with the guide extension.
Very good.
But definitely, give me 20 again.
Samir,
We're making some
come back to you
progress.
later. We'll go to the other lab.
Yep.
Okay.
Yeah.
Right. Switch it.
We'll connect with them,
Other
with
lab.
you later on. See you later.
Thank you.
Okay, this is 125, right?
Dr. Trehan, we are with you. Can you please?
Okay.
We are ready.
Hi, Dr. Trayan, Ramesh Dagubati.
Good morning,
here.
everybody.
Good morning.
Ramesh, how do you do? I was listening to you.
Yeah, very good. Thank you very much,
So,
sir.
we are at Maharaj Agrasen Hospital, and I have a team of doctors here. On the right side is Dr. Siddhant Trehan. On left of mine is Dr. Sudhanshu. I have a chief tech, Amit Sharma. He is one of the most dynamic technician here. He does the job of almost everything. He is a multi-purpose, I will say object rather than a person, because he works like an object as well. So let's have the case introduced by Dr. Sudhanshu on my left. Dr. Sudhanshu, please.
Good morning, everyone. We are presenting a 58-year-old male who presented with class 4 symptoms for past 2 weeks in form of angina and SOV. And he had a multivessel PCI done 6 months back. So the ECG and echo ECG was normal sinus rhythm, and echo also was a good LV function. No regional wall motion abnormalities. Next slide. On angiography, previously, this is the angiography 6 months back. It showed there was a lesion in distal LM, which was 70%, osteoproximal portion of LED, which was 80 to 90%, and osteoproximal portion of circumflex. Additionally, there was a ramus, which was osteoproximal total occlusion. It was a CTO, which was retrofilling from the OM. Next slide. So this is the epicranial view showing the lesion in osteoproximal portion of the LED. Next slide. Same lesion in distal LM, proximal LED and proximal circumflex with the next. So this is the right coronary artery showing the focal lesion in proximal RCA along with the osteoproximal RCA along with the ulcerated plaque in the distal RCA extending till the PLVB. The PD is not seen. Next slide. So first the stent was placed 3.5 into 38 into 40 mm, extending from LM to the circumflex. Next slide. So stent was deployed. Next slide. After that, a second stent was positioned in, via culot from LM to LED. This was 3.5 into 38 mm. Sirolimus. Next. Followed by pot in the LM. Next slide. Followed by FKBI. Next slide. And this was the final result on the left side, 6 months back. Next slide.
So this is all pre-live case?
Yes, sir.
Yes, thank you. Yeah.
Next slide. So TIMI3 flow completely opened up LED, LM and LCX. The RAMS was left on account of financial considerations. Next slide. So we did a IVS pullback at that time, but we were not able to grab the images. So we are unable to show those. Next slide.
So that was a kind of a decent result, at least angiographically, as far as left system is concerned. -1, relatively smallish early diagonal or ramus, and we initially thought to take on it, but since it would have resulted in trifurcation and there were a lot of financial constraints, so we thought, so we've done a good job in circumflex as well as LED, so we were satisfied as far as left system is concerned. That the last time. Please, RCA.
So coming to the RCA, proximal RCA there was a focal lesion, and distal RCA with the ulcerated plaque, and we are not able to see the PD. The PD was filling in from the left side, and we can see the ulcerated plaque and lesion going up till the PLVB ostium. Next slide.
Okay.
So then
we can stop there, and let's. So Dr. Trehan, I think people know that you're doing the live case. The room is still packed on Sunday morning. So we have with me Dr. Akasaka as the chair, Dr. Poonam Velagapudi from Nebraska as the chair, and Dr. Suresh also. And moderators are, as you heard of them, Dr. Rashmi Xavier, Dr. Stalin Roy, Dr. Surya Prasad Naik, and Dr. Chandrasekhar, Dr. Varghese, and Dr. Madhaveshwaran. So what would you want to do, Dr. Akasaka, first of all, and then Dr. Poonam?
Yes, there are two regions here, right? At the moment, the orifice and the distal bifurcation, right? From the main shaft to the distal branch. So initially I tried to dilate the both of the distal branch and then get a good lumen. I think try to put a stent from the main distal to the PD or I think PL is much bigger, so PL, and then they open the branch. And finally, the orifice lesion treatment is very difficult to identify, to put clearly in the place. That is, I also recommend to see the imaging to identify the landing zone, because there are some disease in the distal RCA. So after dilatation, balloon dilatation, try to do the imaging and then check the condition and finally decide. It is my recommendation.
Yeah, I think I would put a second wire down the PDA and then obviously dilate the proximal lesion first and then dilate the distal lesions and image, as you said. And then decide the stent strategy. It's probably going to be a bifurcation strategy if that PL is a big branch and a PDA, obviously, you want to stent into that.
I will use a balloon-based strategy first, and if it is not dilating, use a cutting balloon, because stenosis is focal.
How about you, sir?
Please.
Yeah, obviously, I think that two wires is a good strategy, because the PDA also looks a fairly big branch, and going from distal to proximal should be a better strategy. About stenting distal part, maybe we can debate about drug-eluting balloon versus stent. Proximal definitely stenting.
For the distal lesions, I would prefer DCB. Only if there is some complication, I would think of DES. Proximal, of course. Then depending on the thing, I would prefer a stenting with DES.
Go ahead.
I think the system is right. Probably it's they need to wire. Then maybe if an IVIS can help to see what is the status after balloon dilatation, then plan for a DB or a DS distally, and then proximally, yes, it should be a routine case.
Oh, very good point. How about others?
So my strategy would be to dilate, image, and decide the stenting or DCB based upon the size. But before that, I would like to look at the left check angio. I just want to see if there is a larger branch which is totally occluded or not.
Yes, so they said it's a collateral to the PDA. Can you show that one left picture if you have?
Can we show the left system, please? Previous slide. Back. Go back. Previous slides. Previous. Okay. Just show this. Rub this. Previous one.
Yeah, that's a big branch, huh?
So actually, there was a relatively biggish PD, which we're not seeing here, and all what we are seeing are the PLBs. And Dr. Siddhant was doing this case, and he was struggling to get into PD, which was filling collaterally. And halfway through, while I think his procedure was also a little longish, and then suddenly the RC occluded. Unfortunately, those images we are not able to get, and that was because of a thrombus. So we sucked out thrombus from everywhere, and finally we thought, forget about PD at least for this time, since it is a diffusely disease PD. And since we have done a good job in the left system, and if we are able to give feed to the PLBs, that should be okay for this patient. And that's what was done. Next, please. Next. Quick, next. So a stent was placed just at the bifurcation of the PLBs, almost straddling at the bifurcation. Next. A longish stent. Actually, most of you have probably missed there was a significant ulcerated lesion in the AV groove short of the crux before that nub of the PD. Next. And next. And we finally finish with a stent proximally. Next. So this is previous one. Actually, anyhow. Next. So that's what we got. So we were not able to really get the PDA. However, we were able to improve the flow in the PLB. We were not very happy. But given that he has had his vessel occluded because of a thrombus shot into the RCA, so we thought probably at this point in time, this is enough for this patient. So we stopped it, and patient was sent home with good revascularization of the left LAD circumflex and somewhat reasonable revascularization for the PLBs. PD left, and that smallish early diagonal oblique ramus was left, and the patient was doing fine. He did fine for about 3 months. And then he started to have recurrence of his symptoms, slowly progressing. And now, in the last week, next please, he became more or less class 4. And this is what it is. Can you see that?
Okay. Now we got the point. We are a little bit premature.
So this is almost 5 months down the line, and we have it. And he's nearly class 4. He's marked ST segment depression all over, ST elevation in the AVR. Next.
Dr. Trehan, you could have just said, shut up, Ramesh, we haven't done yet.
so next, please.
So this was a culotte, wasn't it?
This was a culo.
Okay. And now there's restenosis even of the...
Now everywhere. In fact, everywhere.
Everywhere.
And I'm sure you will ask what were the stents used. We had a sirolimus stents in the RCA and in the circumflex. And we have a Science expedition from LM to LAD. So almost all stents have failed. And as far as Silat is concerned, the stents look to be expanded as reasonably well. Sure, we should do some imaging, but I'm quite sure if you see a silhouette of a stent in more than a couple of views and you find those stents to be very large in some areas where narrowing is there, I think my angio interpretation will be that there is a growth which has come, and the growth coming in 3 or 6 months will be neo-intimal hyperplasia, and of course some people can argue even accelerated neothrombosis, which I think 3-4 months will be too early for an accelerated neothrombosis. But we'll like to see what is there in the...
So not a surgical candidate, Dr. Trehan, and compliance of drugs?
No, not at all willing for surgery. In fact, his angiogram was done outside, and so he was not at all willing for surgery. Next, please.
And compliant too, right?
So that is what was the imaging which showed that the stents well expanded, lot of tissue inside. Next. So we took on the RCA first. Next. This time we had a lot of struggle to enter PD, but we entered PD. Next. After making some room, but now nothing is progressing into the PD. This is a whisper wire which walked in, and I tried all kinds of tricks into this. Took my guide extension deep till the crux, took a guide almost to the crux also, and then tried to use 1 millimeter, 0.75 millimeter balloon. All balloon, nothing was going. At one point I was thinking, should I take a rotational atherectomy? But since the distal fill of the vessel was also not very good, so I thought rota may be a little too aggressive for this area, and also if I use a bar, I'll be using 125, which is rather notorious for getting stuck, and especially if you want to walk out of the stent that distally. So that will be a good recipe for my burr to get stalled. So I thought maybe I'd give some more attempts. So then I did post-dilatation in this area with 3.75 because the vessel was showing as 3.75 in an attempt to just widen up the cells if I get some room there to take my balloon. Next.
You didn't think of shock wave? Do they have shock wave?
Shock wave will not go inside, no balloon is going in. I have to get into PD. Next. So finally 1.25 Ray from Terumo went in and I did the task there, then upgraded to, in fact, if you look at the wire, I had to take the wire almost through the collateral into the LED to get the support. And mind it, this wire I changed because sometimes I find Whisper is not a good wire to give a support. It might be good to cross in these tiny channels, but it usually doesn't give you that kind of support. So after having it made some way into the PD, then I changed it to this Boston wire. This is choice floppy. Next. And made some way there and then did the task finally. And I realized that the PD was not a very good target for me and for surgeon. It was a diffusely disease artery. So finished with a dab into PD and rest of the area into the RC also. Next. So that's my result. No stent this time. Only balloons. Dab into PD and dab into the RCA. Next. So, and we believe that if, of course, PD, I didn't want to do an OCT in, and I also didn't have the machine yesterday with me. And on OCT, how do we decide is that if everything is homogeneous, maybe just use a DEB, and if it is non-homogeneous, use a stent, preferably a stent without a polymer, or you can change a drug with a stent. Next. And we know that DCBs are now evolving indications for at least stent failures, both in BMS and TREST. Next. Next, I think. And in DCB, we often like to use sequent please, which I think state of the art because of its carrier and because, and it has also been tested in various trials. Next. Sequent please, Neo. Next. So here we are. Can we show the angio?
So you felt sequent is better, the paclitaxel is better because
yeah,
it is
certainly paclitaxel is better, and out of the paclitaxel, if your delivery system has a vehicle which can deliver the drug better, then I think sequent please because of the technology is better than the others. And drug-eluting balloon, see, the stents will be covering the surface area about 15% of the vessel wall, whereas, and they will be delivering drug to the 15% area, whereas a drug-eluting balloon will be able to deliver the drug to the whole of the area. And if you have done cuts with a cutting balloons, then I think it becomes a much better position. Just putting a dab in the absence of a cutting balloon doesn't give you as good results as is a cutting balloon, making those areas raw and then dab on the top of that. Next. So today we thought, let's get into it. We got into a smaller guiding catheter just in case we don't injure the os. Next. Took a wire into the LED, took out that smaller guiding. Next. Then took a bigger guiding because sometimes the stent studs are outside and they can hinder with the, and if you're especially taking 7 or 8 French, which I'm likely to take in this case. So my practice is sometimes to take a lighter catheter, wire the vessel, and then advance a bigger guiding 7 or 8 French. Because once you are into the stent, then the things are easy. Next. So there we are trying to readjust, and we have readjusted the S. Guide is into the next. So wire the circumflex. Next. Make some rooms because it is good to pre-dilate these areas. Next. So we pre-dilated both circumflex and LED. Now which imaging will you like? Intravascular ultrasound or in stent failure and OCT?
Dr. Akasaka, OCT or IVUS?
Yeah. No, OCT gives us...
OCT, okay. Show us OCT, please.
Yeah. Okay. Because we can...
so this is OCT, please, on the screen. Yes. Right. Please start from the beginning. Okay, this is which vessel? The first one, you don't know. That's LED. Okay. So what we see is, I think we have Akasaka with us, so let's keep our mouths shut and have the best of the opinion.
Yes, a very homogeneous, high signal. That means that fibrous. So
fibrous, neointimal hyperplasia with fibrous plaque.
I think the DCB might be very useful. Finally.
Useful.
Yeah.
But there's also 25 millimeters, some under-expanded stent, and what's happening at 35, 38 millimeter? Is there a stent loss? There's no stent in that, right? That covering at 38 millimeters.
Go from circumflex. circumflex. So that is from circumflex. Just stop there.
Yeah, so that's what. So what's happening here?
Previous.
Here is some layered plug, right? So layered plug.
This is a real problem with the distal left main and ostial circumflex and LAD.
Yeah. Some stent can be identified just the upper side, right?
So I'm not sure that there is stent struts on the longitudinal and the bottoms of the screen. I'm not able to actually see any stent struts. But definitely, if there is a lot of neoatherosclerosis over here, isn't it?
Okay. Next. I think we stop here. Go with the angiogram. Next. Next. So that is after pre-dilatation. That was OCT. Next. 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 So then we took a cutting balloon into the circumflex. Next. Next. Now, mind it, that previous one. The cutting balloon is sitting in the circumflex, but mind it, your LAD is also closed. So you cannot keep a deb like this, because if you keep a deb here for some time, you're likely to close the other vessel. And deb will have to be kept at least for half a minute, 30 seconds. Next. So we advance the cutting balloon a little bit forward, and then there is a flow in the LAD. Next. Next. So we do the same task in the LAD. Next. So the wire had come out, so there was intertwining, so pulled out the wire. It was difficult in taking the cutting balloon into the LAD since it was already used into the circumflex, so profile had become less. We were using Wolverine. Next. 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 One more run of cutting balloon to circumflex previously. So now we are there. We'd like to take a haath sir ke niche rakho bhai. Now after cutting into both the divisions, so this is the shot which I am taking now. So I have some improvement, but not good enough. Leave it like this with a deb. Dr. Akasaka, what's your opinion?
Yeah, I think might be better to check by OCT again, depend on the contrast. But yeah, and if we have enough room and area, then finally I recommend to do the DCB, right?
Okay. Or I take a better shoot with angio. That might be a little better looking shot. How about this?
Yeah, I can identify some tissues at the just proximal side. Yeah, but it might be very difficult to get clearly. But try to do the cutting balloon again and.
Okay.
Yeah.
Cutters, please. Give me a cutter for the LAD. Cutting balloon. So actually we had done with a cutting balloon, I think 5-6 dilatation were done. Initially we were at 6 atmosphere, then we went up to 8, 10, 12. And beyond that we thought, well, we'll be sacrificing the cutting balloon, so probably there's no need to go beyond that. So
actually there is a new, Dr. Vijay, new version of cutting balloon people are bringing with 18 atmosphere we can go. That is actually the newer, proposal for the Boston Scientific.
Even the ox varieties we had done with, okay, go ahead. We used to go, I have used cutting balloon even at 20 atmosphere, sometime even
That's
22.
That's what I'm telling. Because actually if it is not, will you take a higher size cutting balloon or the same is okay with you?
I think the size is okay because I'm using 3.5. We want me to use 4 millimeter cutting balloon?
No, my question is after that, if you don't prepare well, your plan is to do a regulating balloon there, right?
Yeah, it makes sense. It makes sense in taking a bigger cutting balloon. We can take a bigger cutting balloon. In fact, give me 4 millimeter cutting balloon, please. Different, bigger for the both circumflex and LAD or for LAD bigger one?
Akasaka.
Yeah, LAD also.
Yeah.
Yeah.
And
LED
moreover,
also.
actually, when you do a cutting balloon, the principle is actually you have to keep for minimum 15 seconds, 12 to 15 seconds,
the LED
otherwise
wire
we
had
will not
come
get the
out.
real result. Because our plan is to do a DCB in both vessels. That is actually the challenge. When you do a DCB with a bifurcation, actually two kissing, you are going to take a 2 DCB at the same time, or what is the plan?
No, 1 DCB at a time. 1 DCB at a time, because give me a 4 millimeter cutting to the LED. Please educate us. Pratap, please continue.
No. My question is actually, you can keep both the DCB together. One DCB can be inflated for 30 seconds. Other can be kept without doing inflation. Then the other can.
No, then some surface area of the DCB will be.
No. My point is, after that, the final kissing can be done with the same DCB together for 10 seconds.
That's okay. That's perfectly okay. But I like to inflate a DCB one at a time so that my whole surface area of a DCB proximally is able to touch somewhere and deliver the drug, rather than 2 of the DCBs fighting with each other and touching those areas. This is a 4 millimeter cutter. Just a moment. Go ahead.
You can keep the DCB balloon just a little distally and then withdraw and then do that also.
But keeping a DCB there for some time without inflating, that means you're losing the drug there. In fact, that should be deflate.
We don't know that.
DCBs are the devices which have to be in the intravascular compartment only for a short time, inflate again, and not like this, you just keep it there and don't deploy it there.
Actually, Dr. Vijay Trahan, we have to go to the other lab for some time and then come back again. Can you just go to Samir and come back? Can we go and come back? Okay.
Yeah, sure.
Okay. Luca and Samir, we are with you. Please tell what happened after that. Samir.
Pratap,
please
can you hear me?
We can hear you. Please tell what happened after that.
Yeah. So I'll tell you. We had this difficulty in crossing the lesion, right? We had put in Guidezilla, and then we tried with 1.5 balloon. Twice we failed. And then we took a 1.2 balloon, which crossed. And then we dilated with 1.2 balloon, and then it was easy. Then we dilated with a 2O balloon, and then we dilated with a 3O balloon proximally. And this is where we are. Luca wanted to wire both the branches, and that is where we are. There is some dissection in trying to wire that other branch, created some dissection. Otherwise, we were through the true lumen. So that was not a problem. We made an injection through microcatheter also. Maybe I can show you all that.
Samir, in this situation, when you wanted to take the second wire, and the second wire is actually going to this subintimal part, the ideal one is to take a dual lumen catheter and take a wire.
Yeah. So we thought so, but the point is that as soon as I thought, I managed to cross. As usual, you know?
No. And, I'm just telling for the academic purpose. You can cross.
Yeah. So and I want to show you what the position that we got now. Okay, this is where we are. So we got 2 wires down, both in the true lumen. As you can see, there is some dissection, as Samir pointed out, which is obviously a consequence of what we've done. So we are not stressed about it. What we are trying to do now, if you agree with that, our strategy will be to do the IVUS, to see where we are, and basically to understand where is appropriate to put a stent, and where maybe we could just end up with a DCB. Samir, what do you think? It might be a good occasion for a hybrid approach.
Exactly. It's a fairly long and diffuse disease. And we do IVUS, and then we decide which parts to stent.
So why actually, Samir, what is the difficulty of taking the balloon down earlier? Because of the calcium, because of the severe fibrosis?
I don't think it was calcium, it was severe fibrosis.
Then we will be doing an imaging and we will understand that, right?
Exactly.
So your imaging plan is IVUS or OCT?
IVUS.
Okay. And to be honest, one thing, well, definitely you can do both, but I suggest, this is for our younger colleagues, when you got dissections, unclear path, well, let's go for IVUS. Because with OCT, you need to inject high pressure contrast, and you never know. It is rare, but in some cases, I have seen with my eyes that you enlarge the dissection, you may create an hematoma. And that's why, I mean, we agreed immediately to go with the Hybiz because it's, you know, it's reproducible. You can do it 10 times. It's just a matter of, you know, timing. And, you know, we'll do that with you live. But I have to say that we were very close to change our gears. I mean, in terms of guiding catheter, but it was not that needed, I have to tell you. But definitely was a source of discussion between us because we said, okay, shall we change it? Shall we insist? But ultimately, we made it. So, well, retrospectively, probably we would have saved, well, 5 minutes maybe with a different catheter.
Can you just have Dr. Partho will be on the stage, Partho, for the lightning talk. See, actually now we are planning to do an Hybiz. By the time Hybiz catheter goes down, when you just take the image, we will come back to you in 3 minutes.
Yeah, just go ahead. We go ahead.
Go behind.
Okay, you can show the Hybiz. You can show the Hybiz.
Yeah, so you can see the Hybiz now?
Yeah.
Okay.
Can you?
We are ready.
We can see, we can see.
Okay, you can start if you just take a picture to show.
No, we will see the Hybiz and then only we will go back.
Yeah, so you know where the Hybiz is, right?
Yeah,
It's
please.
beyond the bifurcation.
Okay.
We will give the mic to Akasaka to explain Hybiz. He is a OCT man. But we will give to Akasaka only.
Yeah, okay.
Please, Akasaka, tell.
Yeah, here is very close to the bifurcation, right? That's wire comes from the 3 o'clock. And there are dissection at the bifurcation region, right? So that's the reason why flow is a little bit delayed in the different vessel, right?
Yeah.
In the other branch.
Yeah.
Yeah. Indeed, this is very explicative and very teaching image. I mean, the wire in the other branch, I would not say inside branch because that's the PDA, but the wire in the other branch is basically coming in the true lumen proximally. As you can see, there are 2 wires, but then at the bifurcation, it's very close and probably in and out the dissection. So what is the point? The point is that in our mind, our strategy would be not to touch that segment. I mean, further than the bifurcation. Our idea, without the Hybiz, but we can discuss now. Our idea was to prepare the lesion, prepare the RCA up to the mid segment just before the bifurcation. And then we can discuss about what to do downstream. But definitely, I think that there's no reason to go beyond that bifurcation because there is collateral flow from the left. There is a distant flow,
totally luminal or this part is luminal? Can you just go back a little?
Yeah.
Okay, now we are still there. Okay, but I mean, the proximal part is not that interesting. So stop the recording. Stop the recording, please. Okay, the proximal part, you know, is we need to put a stent or do something.
Pratap, you want to replay and
No, I wanted to see that part was luminal or sub.
Yeah. Let's go back.
We can replay.
Let's do at the beginning of the Hybiz record.
Here comes the PD, right? The distal portion is very good.
Yes. Yeah. I mean, the bifurcation of the distal RCA is really proximal, as you can see, and it's not that visible, I have to tell you.
Here is
but we managed to understand once we crossed, and so.
Lumen area is 1, 2,
Our point is,
3, 4.
Akasaka, whether it is luminal or how much part is
4 millimeter, right?
There's all lot of dissection, lot of hematoma is there.
Yeah.
Lot of dissection. So far it is luminal.
Yeah.
Luminal. This
definitely luminal. We are going from proximal to distal, which is unusual because it's from the right to the left. But anyway, just keep going this direction. Keep going this direction. Okay, this is true. This is luminal. True, definitely true.
So far.
Yeah. Small branch there.
Yeah.
Still luminal?
Yes.
Still tight, by the way.
Luminal.
Yeah, still
luminal and tight.
Yes. Very tight. Some calcium, right?
Yeah. Not much, I have to say. I agree with Samir when we said it, more fibrotic than calcified, to be honest.
I agree.
I don't see big shadows,
this
you know.
Part, actually, I had a confusion, that part.
Yeah.
Actually, I could not see the media on the other side.
That looks like...
Here might be the false lumen, right?
This part, actually, I have it down. That is the same thing.
Yeah.
This was subintimal.
Yeah.
I think so.
that part. Actually, when you dilate that part with a larger balloon, it will be careful about it. That's only issue I was telling.
Yeah.
You know what is that area, which area it is?
Yeah, this is probably just before the bifurcation. But again,
no, this area is much above, very proximal. Yeah, it's very proximal.
Okay.
It's a very proximal area.
No, well, it's distal. This is the left.
No, because we are going from distal to proximal.
Ah, okay. That's
distal
good.
to proximal only. I think Luca was telling proximal to distal.
No.
Okay, it's fine.
Yeah.
So this is about, I think, correct me if I'm wrong, have you measured? It is about 30 millimeter from the ostium.
Correct. In that area,
this area which is doubtful.
Akasaka, that part is looking like a subintimal part.
Yeah.
Okay, so it should be about 20 millimeter from where we stopped.
That might be the original CTO.
This doubtful area. Right? Where we stop. So that part, that is a part where we.
So what is your plan, Samir? What is your plan now?
Okay, so I think that we should combine DES with DCB maybe. I would place stent in the at least proximal area, and then see how it looks, and then think about maybe DCB. I wouldn't like to unless I have to, put stent right up to the bifurcation. But you have to
prepare the lesion before putting the DCB. What type of preparation? Will you do a cutting balloon distally or not? That's what I'm asking.
Distally, no, but that area where there was very tight fibrotic lesion and there was a little bit of calcium, I would go in with a cutting balloon.
Okay. So just tell your plan, then we will come back to you. Partho, you can give, talk should be maximum 3-4 minutes. You can go to the lecture.
So we will go in with a cutting balloon in short areas.
We'll come back to you, Samir. We will come back to you in 2 minutes.
And then see.
We'll come back to you in 2 minutes. Partho, please.
Good morning. Thank you, sir. So it's a relatively rare. About 1.2% is the real-time incidence. Among them, anomalous coronary arteries that arises from the opposite sinus. These are the toughest one to deal with. Anomalous left coronary artery that arises from RCA with intramural segment, interarterial course. It is having highest chances of sudden cardiac death. So basically, it's challenging, time-consuming, good radiation exposure, contrast exposure, and it requires a lot of equipments too. Even more challenging is in the setting of primary PCI. So basically, these are the 4 types. Absent left trunk, very commonly encountered. Anomalous origin of RCA from left sinus. Third is anomalous origin of LCX from right sinus. And last is anomalous origin of left coronary from the right sinus. Whenever we encountered, usually the first step is rather than hunting the anomalous origin with a series of standard shaped selective diagnostic cath, better is to do a high quality deep aortic root angiogram in AP and lateral view and keep it as a reference point and then begin identification process with the most appropriate catheter shape. And when you have a high degree of suspicion, better to go directly with a CT coronary angiogram. So this is the most common one, easy to handle. Just take a half size smaller catheter. It will automatically engage into LCS, give a counterclockwise maneuver. The catheter tip will shift anteriorly and it will easily engage LED. These are the most toughest to deal with and more complicated ones. Most common one is when it is just in the RCS, just to the side of left coronary catheter with a pinpoint ostium and it traverses horizontally across the aorta. Usually it is usually we can engage it with a AL2. Rest Lea catheter, which is a modified AL2. Rest are when it is below or above. It is in the sinotubular junction. These are usually handled with AL2. Sometimes we require specialty catheter while doing PTCA, like right anomalous coronary artery opposite side launcher catheter. Then sometimes it is in the right sinus, but just at junction of right and left commissure. Usually they are also handled very well with Emplarzer. Sometimes when it is associated with tortuosity, we require special catheters like shear panics balanced. So this is here example where we encountered it with the help of Emplarzer left. It is arising just adjacent to the left coronary artery. This is like right anomalous catheter from launcher guide cath. This is helpful while doing the PTCA. So figure 1 is important. Basically, sometimes we have a non-selective engagement of this anomalous artery. What we can do, we can put a wire inside, then we can take a guide liner so that we can complete our procedures. These are like, this is a good example where we use the shear panax. Shear panax is having multiple curves, even its shaft is also bent. So when you are encountering anomalous RCA with tortuosity, it's a good option. It fits into the aorta very well. Now that was a theoretical approach. This is a more practical approach. When we are encountering such cases in the cath lab, if it arises just next to LM, use a simple JL. And if it is above the aorta or below, you can use an implanter. If all this procedure fails, one very good method is just engage with the help of a TIG or a diagnostic catheter, put a exchange length wire, then track a 6 French guide cath over the vessel wire. And if you have a specialty guide cath, it's very well. If you don't have, then also we have an option. We can modify our simple guide cath that we have in our lab. So this is the inverted Judkins method. What you do, you take a slightly undersized 6 French 3 through 3.5, loop the 0.035 wire upward in the left sinus, follow the guide cath with a clockwise twist, the catheter inverts and points anteriorly and will hook into the anomalous RCA. And this is how to modify the shape of guide cath. Either you do manually or you took a needle introducer, put it inside, bend it, dip 30 seconds for hot water, then put it in the cold water, then it will be a long lasting. This is very simple. That is anomalous L6 from right cusp. It can be simply engaged with the normal right catheter we have. Lastly, anomalous origin of LMCA from right sinus. It can be easily engaged with GR4, hockey stick, whatever catheter you have for the right sinus. Most important is these are the cases where they are mostly malignant, having an intra-arterial course, intramural segment, and they are associated with sudden cardiac death. Regarding PTCA, we can do with a simple right-sided catheter. Thank you for your attention.
Thank you, Partho. We go to the Dr. Vijay Trahan. Vijay Trahan?
Yeah, I'm there.
Please,
so we have done a DCB to the circumflex using a 3.5 into 15 millimeter sequent, please, Neo, which I think probably is the state-of-the-art regulating balloon with
what we are seeing now? What we are seeing now?
What I'm showing you is another one, which is a 4 millimeter into 20 millimeter DCB, which I'm going to take into the LED. Okay. Just focus it. This balloon is slightly different from the routine balloons because it has two compounds. It is something like a frostbitten balloon. And mind it, look at the profile. This profile is much bigger than a routine balloon. Correct, so it's a device. People call it a balloon, but it's a device. And this device, the time taken from your entry into the tuberosity and then to the site of lesion should be as short as possible, lest the drug can be lost. So we have taken out the balloon, which we took it into the circumflex so that we don't rub and fight with the balloon, which is already there in the circumflex, that DCB. And as was suggested by Dr. Pratap, just because of that concern, we thought we'll take them separately so that we don't lose out on. So now we have entered the tuberosity and somebody can note the time, and as little time will be better. Go ahead, please. So we have a DCB from LM to LED, timer is on. And he did not really tolerate so well as far as inflation to the circumflex is concerned.
Vessel is well opened up.
Vessel is well opened. Can we just show the hemodynamics? So his pressures are point of 140. It is dropped from 140 to 120, 110, 106. 25 seconds. It's at 25 seconds already over. The pressure is 100. There is so this use of these balloons are concerned in critical situations, whether it is a single surviving vessel or a left main or whatever. Because they are devices, they cannot be kept there. Just hold it. Hold the bar. Now, the same balloon which we used to deliver the drug to circumflex, we are taking there to finally do a kiss. And now we are not concerned because we have already given a drug there. The recommendation from the company is to inflate it for a short time, that is 30 seconds.
Two 4 millimeter balloon are taken, right?
No, this is 3.5 into the circumflex and 4 into the, and I think you can go at somewhat low pressures, 6 only. We don't need high pressures here. That is just to set the crana. Please go ahead. Inflate both. Timer is on. Okay. Sir. I think deflect. That's enough.
What pressure it is gone, Vijay?
6 only.
Both 6.
6 only. Because I'm not having a luxury of having a stent inside, and I don't want to injure anything which I don't think I can repair. So now I take a shot after this. Center kariye please. Push karke center kariye. So that's what it is.
Superb.
I think we should follow it up with an imaging. We should do an OCT.
We have to close the session. Can you show the imaging faster?
I can try to show you. Which vessel will you like me to get in? Because I can show you only one.
When you take the catheter inside, the imaging catheter inside, we'll just come for 10 seconds to see the last image.
Okay, no. Which vessel do you want me to visit?
I think, Akasaka, which vessel you want to see? Circumflex or LED? LED only.
Yeah.
For him,
LED. My wire,
very important.
because wire gotten out of the LED. Okay, then I'll take the circ bar into the, because that wire was beaten up, so I can take the.
No, he has taken the wire inside.
Yeah, I can take this wire.
Wire taking is a simple thing.
No, actually the wire in the LED got beaten up in the beginning only. So I was struggling not to waste one wire there. So, are the OCT ready?
OCT ready?
Ready? Okay. My catheter is going in. Be ready for the shot, OCT shot. Okay, come forward. Come forward quickly come forward. Come forward. Yeah, already on there. I think don't need to go very far. I think you will start from here. That's the area of interest. Let the guide go in so that the dye is not lost out anywhere else. Check for the dye going in. I think it's okay from here only. Okay from here. Are you ready? Okay.
Yes.
Show it.
Yeah, very good. Yes. Some tissue can be identified. Dissection, but it's okay.
Akasaka, can you be a little bit louder?
Yes. Yeah, we can identify some tissue because of the cutting balloon, but it is not flow limiting and area is enough. Yes, some tissue to the LCX site, but it might be okay, right?
So I agree with Dr. Akasaka. Actually, most of the time it is not the words, it's the way the words are expressed. He says it's okay. So I will also say it is okay. We would have loved to see a good lumen without too much of things inside the lumen to say that there is a tissue collapse, but this is what it is. I think we can probably stop the case here. What is the opinion of the House?
What do you think, Akasaka? It's a good result, right?
Yeah, good.
You want me to top it up with a stent here, or?
No. Akasaka is telling it is very good result and we can...
I think result is acceptable, right. Very good.
Okay then.
Thank
you so very much.
Yeah.
Thank you, Dr. Vijay Prakash. We are going. It's very good. Big hand. We'll go to Samir Dani.
Yeah.
Can you go to Samir Dani?
Hello.
Samir, you have...
Yeah, Pratap, can you hear us?
2 to 3 minutes and finish it off, please.
Okay.
You want to see the items?
Please tell us and finish
Let me
it off.
show what we are doing now.
Yeah.
Okay, that's what we are doing. The balloon is inflated, and this is a drug-coated balloon. It's a magic touch, 3 by 30. 3 by 30, and the lady is tolerating very well. 2 minutes. And what do you think, Samir?
Yeah,
we deflate?
2 minutes is fine. It's 2 minutes are over, so we'll deflate now. And proximally, Pratap, we have put a 3.5 16 millimeter stent, abluminous. We inflated the stent for 1 minute. And then we did the DCB, that is magic touch, sirolimus coated balloon, 3 by 30 at 14 atmosphere. We dilated for 2 minutes. She tolerated the inflation very well.
Yeah.
And now we'll take a picture for you and then do IVUS, if you will, and then talk about the distal part of the vessel.
So the plan is to check, please, to check where we are, and ready?
Samir, the interesting part is actually in the other side also they have used a regulating balloon which was a paclitaxel coated. Both are Indian companies. Ready? One is by Translumina, other one is actually by Concept. Very interesting. Eh? Two regulating balloon, two sides, opposite two companies, two different drugs.
Yeah. I think we have here all the space to discuss, in particular because my approach would be to just inflate the small balloon to the small branches where we are, because now with this very nice flow, the flow is actually favoring the PDA, as you can see. But also, I mean, we are losing some flow there. First of all, everything is under control. Pressure, ECG, everything is fine. The stent may be needing a little bit of help in terms of post-dilatation. We will look at that. But definitely the mid portion, where we use the DCB, looks perfect. It will heal. And
so you will avoid the stent, Luca? You will avoid the stent?
Yeah, definitely. No stenting. The mid portion is good. It will heal and it will give space for positive remodeling over time. So definitely, I'm not going to put any other stent there, unless doing this further ballooning for the small branch, it will create some disease, some problem. But I don't think so. So my approach, Samir, would be, let's see Hybiz, let's do the Hybiz, and then evaluate. But definitely, I would never put another stent. What do you think?
Yeah, I agree. After Hybiz, if required, I think we'll put a small balloon at the ostium of this branch where our wire is, and that's it. And that's it.
Thank you, Luca Testa and Samir Dani. We actually demonstrated no stent strategy for two live cases on either side. It was a wonderful display of how regulating balloon can do the work. Thank you, Samir and Luca Testa.
We are
leaving you.
welcome.
We are 6 minutes out of the schedule. Thank you very much.
Thank
we'll
you.
go to the next session fast.
Thank you.
Can we call upon Dr. Bernardo Kotasi, Nitish Chandra, Tarun Dave, Ramesh Kawar, Natesh, Thomas Alexander, Miraji Rao, Rituparna Baruwa, Hariraj Tomar, Ramesh Patel, Harsha Teja Pereya, Rajiv Rajput, Girish Kawakar. Anybody is there, please? Bernardo is there. We'll go to the first talk. Dr. Sanjeev Roy is coming in again. Sanjeev? Okay. If not there, we'll go to the next talk. That is why. Solomon is there. Okay. And Rajinikanth is also there. Everybody is there. 10 minutes only. No further big discussions. No discussion. No, you can have 1 minute. 1 minute. 1 minute. You have to wind up in 12:35. Please.
Good afternoon, everybody. And I'm going to discuss about the use of excimer laser in high thrombus burden. So excimer laser was actually developed in 1990s with an aim to modify the atherosclerotic plaque as an alternative to the plain balloon angioplasty, which caused a lot of dissections and flow-limiting dissections and restenosis. But however, down the line, with initial unfavorable results, advent of stent, expensive cost of the catheter, and no refinements in the development of catheters, its use became limited. Later on now, with better understanding of the technologies, refinement in the equipments, and the catheter technology, there has been a renewed interest in use of excimer laser for its best use in specific circumstances, more rather than not as an alternative, but as an adjunct to the PTCA. So what excimer laser is? Let's understand the science. Xenon molecule and a very diluted hydrogen chloride in a laser medium, when high voltage is added, they combine into a dimer, which is xenon chloride. And whenever this excitation is removed, it releases a photon. This photon generated is in the ultraviolet range of 308 nanometers. It excites the electron and produces two photons of the same length and phase. And there are a lot of mirrors inside which amplify this process, resulting in a formation of the laser beam. And this laser beam actually break the covalent bonds inside the molecule. And unlike the infrared ray, it has a less penetration into the tissues and absorbed only for less than 100 microns length, and thereby causing less of collateral damage. The duration of these pulses are nearly about 125 to 200 nanoseconds, and the output is about 30 to 80 millijoules, with the repetition of varying according to the specification that you want, from 25 to 80 pulses per second. And this is the way it works. In this 200 nanoseconds, there are photoablations followed by a period of rest, where in this animated cartoon you can see here the laser beam emitted causes the breaking of the bonds, which is called the photochemical pathway, and thereby generating some thermal energy and a kinetic energy, which actually finally breaks down all these particles into pieces which is less than 10 microns, which can be then absorbed by the system. So use of laser actually follows the principle of 5S, where we need to select our patients, we need to size the catheter, which should be less than 2/3 of the vessel diameter. We need to adjust the settings. We call it fluence and frequency. Fluence is the pressure with which you are hammering, and the frequency is how frequently you are delivering these energies. And then, most importantly, we need to use a saline flush, keep the system clear of the contrast, because contrast can actually result in high pressure energy delivery. And very importantly, we should advance the catheter very slowly. So this is the various catheter size. Most commonly we use a 0.9 and 1.4 catheter in the coronary, which are respectively 5 French and 7 French compatible. So these are the various indications. Mostly it is used in order of frequency and the relevance in balloon uncrossable lesion, underexpanded stents, diffuse in-stent restenosis, aortosteal lesion, moderately calcified lesions, large intracoronary or intragraft thrombus, and finally the saphenous vein grafts. And today I've been told to focus on the large intracoronary thrombus or intragraft thrombus. Now, what is the problem with large thrombus? It actually causes, if we look at in the STEMI situations, procedural complications with distal embolization, no reflow, microvascular dysfunctions, and hence greater myocardial damage. If we can reduce it, it improves the outcome. However, our attempts to do that with routine thrombectomy, routine manual aspiration has of an uncertain value, hasn't shown to be of any clinical benefit in most of the trials. On the other hand, the excimer laser, this directly targets and vaporizes the thrombus, has been found to be safe, effective as an adjunct therapy. And this photoablative mechanism of thrombus vaporizing may exceed the simple mechanical effect what we do with the thrombectomy devices. So let me take you to one case. This is a 45-year-old gentleman who presented with anterior STEMI. He had a prior intervention in 2019, but details were not known. Risk factors, he's a smoker, no other risk factors. So his bedside echo in the emergency room showed moderate LV dysfunction with akinetic LAD territory. So he was wheeled into the cath lab for a primary PCI. And if you look here, the LAD ostia was totally occluded. So what I did, I just passed the wire, and because there was a stent inside and I did not know exact location of the stent, although it was looking to be an osteoproximal from the cardiac sellout in the angiography. So did a quick run of an angiography. For the interest of time, I'll just run through. What you can see here is a highly thrombotic burden inside the stent. Not sure whether there was an intraplaque rupture or not. So just took a 0.9 millimeter excimer laser, passed it, and one run, and you can see in the middle how clear is this with normal TIMI flow, absolutely pristinely clear. However, there was some narrowing at the bifurcation. I used, and the ostia, I used a plaque modifying device in the form of Wolverine 3.10, 3.0 into 10 at both locations, and then used the stent to cover it up. And this was his final views. Absolutely revascularized artery with good perfusion. And these were in final the pictures in the Hybiz. You can see here the stent was very well expanded and absolutely pristinely clear of any thrombus residue. And these were the angiographic final images. So do we have data on this? Most of the data on laser dates back to 90s and early 2000s, before 2005 and 6. So let's look at here. There's a couple of studies. These are older studies. The Caramel multi-center trial, which again showed use of laser causing increase in TIMI flow, more gain in the MLD, and actually this decreased the target stenosis. This was another laser AMI trial, again older trial, published in 2007, where they found that the diameter stenosis decreased, TIMI flow increased. There was more of, however, the post-procedural myocardial blush and the final corrected TIMI frame count did not differ, but it was found to be safe and feasible. Recent studies, if you look at, again, this was a study from the Korean group. This was a laser vaporization of the thrombus. What was found that the baseline thrombolysis, if you look at the myocardial flow grade, was better, and ELCA effectively vaporized the intracoronary thrombus in STEMI patients, even after the use of thrombectomy devices. Again, further studies, it showed that the myocardial deviation enzyme and potential improvement of the systolic functions compared to the manual aspiration of the thrombus in patients of STEMI with use of laser. Very recent studies, again, it improved the myocardial infarction, if you look at the myocardial, the blush grade, and reduced the intraoperative slow flow or no flow phenomena in patients with STEMI, even who presented late, actually 12 to 72 hours after the onset of pain. It has been used in very few cases in acute MI situations with subtotal blocks, and all of these patients had a cardiogenic shock where it has been successfully used, but this is a very small number in single digits. What complications can occur in excimer laser? There can be sometimes major dissections, abrupt vessel closure and perforations, but with proper techniques and appropriate patient selections, and this can be reduced. So to conclude, in STEMI, ELCA is feasible, safe, and effective. It causes aggressive thrombus removal. And after the thrombus removal, we can better understand the morphology of the culprit vessels and decide on our therapeutic strategies. It can, once we remove the thrombus, we can always look at the geographical miss, because many times the pathological culprit lesion may not be at the site of the severely stenotic lesions. Distal embolization can happen during the insertion of the catheter, but it's usually very infrequent. Thank you.
Thank you, Dr. Sanjeev, for this also timely and very interesting relation. We have just one question, because we have the time for one single question. Okay, I will go for the question. We don't have so much laser in Europe so far. So which is the learning curve that you would suggest for a center that is starting his experience with this device?
Well, one is the patient selections you have to look at, and most often, if I look at this acute MI, is not the primary subset that we look for, but if I stick to years primary STEMI group, early wiring and use of 0.9 catheter as fast as possible, but most importantly, we should advance the catheter very, very slowly, because that slow movement gives you a wider lumen and more lysis of the thrombus in acute MI settings. Otherwise, we usually look at the standard protocols and work on it.
And what is the contraindication? I couldn't see that. Contraindications for the use of ELCA?
If you have an acute bend, if you have a small vessel size, those are the contraindication standard that we should not use it. Because those are the settings where you will likely end up with a perforation.
Okay, thank you.
Thank you.
I think we should move on to the next presenter, which will be Dr. Selvarmani, imaging in non-atherosclerotic ACS.
Good morning, everybody. So, get the laser, please. Yeah. So, non-atherosclerotic ACS or non-atherosclerotic coronary artery disease, OCT in that. So, probably I will show you a few interesting things. Most of us, we have been discussing on atherosclerotic by ACS. And now, look at this angiogram here. So, this patient had a stent here. And then almost around 6 months to 8 months later, he comes like this. So what do you think this is? So basically, most of us, when you look at the angiogram, you feel probably there is a ruptured plaque or there is a thrombus there or something is happening. But if you want to treat it, ideally, for such cases, better. He had a stent in the RCA also, which had a problem, which had occluded. You look at the OCT here, what it clearly is showing is there's a stent, and after that there are ectatic segments here, very clearly seen there, and then probably this is not a problem with the atherosclerosis. Probably this patient you can just imagine what it is, and this is the OCT here, and it's basically a polymer hypersensitivity. So but this is what the angio shows, as well as the OCT shows very clear ectatic areas. A similar case you see here, a stent looks like this, and then this is the Hybiz, which shows that there are ectatic areas there in that. And again, this is not a stent problem, it's an hypersensitivity reaction to the polymer. And a similar case here with such a big ectasia, you can clearly pick up on angiogram that it is an ectatic segment at the stented area having a problem. And here, this patient also had a huge aneurysm there near the stented segment. And this is again a polymer hypersensitivity here. This was treated with a covered stent. And probably this is how a covered stent looks on an OCT. You cannot see anything beyond the covered stent because there are layers there. And this is one. And apart from this, one important thing that we should remember is spontaneous coronary artery dissection, or SCAD. So it's a non-traumatic, non-iatrogenic separation of the coronary arterial wall, commonly in younger women. And there are so many reasons behind it, which we will discuss. And there are different types here. So one, it can just have some intraluminal defects. One is there can be a diffuse disease or a focal disease just mimicking atherosclerosis. So this is a very standard definition of an SCAD there. So look at this angiogram. So this patient has some long lesion in the LAD here. And when you do an imaging in such a patient here, what is it that you are seeing there? So very clear, you cannot make out in an angio what it is. You see here, it is an separate hematoma in the area between the media and the intima. And in this specific case, you see that intima is completely intact. There is no tear in the intima, but there is a separation between the intima and the hematoma. And in the media, that's because of intramural hematoma. You analyze the OCT, clearly it shows there is a separation. And this is producing an image as a diffuse disease on an angiogram, which is very important that you cannot take there. And most of these patients can be treated medically, and there is no need for stenting looking at the lesion like that. And this is a very important tool, especially OCT, to look at the spontaneous coronary artery disease. But you need not do a OCT in all SCADs if it is very proximal, or if there is a tear, you expect that you can extend the dissection. But in many cases, when there is a doubt, this is how it looks. And coming to the pathophysiology, it can be a tear in the intima and go into the media, or with the intact media, there can be microvascular ruptures which cause this spontaneous coronary artery disease. See here, there's a rupture, and the intima is intact, and then you get a lesion like this. And this is again a SCAD here, but you are seeing that there are intraluminal defects on an angio. Should we stent it or not? So you do an OCT, you see that there's a thrombus, and when you concentrate on this, there is a tear in the intima and there is an hematoma going inside. And you concentrate this segment, you can clearly see that there is a tear and there is an intima medial involvement there causing this picture. You look at this angiogram and, there is a very focal lesion there in this lady, which was directly stented. The moment you stent it like this, it's a very focal lesion. And then after the stenting, we were trying to dilate this lesion. See, what was happening is, once I dilate the distal part, the proximal part of the stent became stenosed. And once I dilate the proximal part, again, the distal part becomes stenosed. So what is happening is, I'm trying to dilate it with the NC balloon after stenting. The plaque is getting shifted. It is from above to down, down to above. So this was really a puzzle. Like actually, we did not do an imaging just before the stenting there in this case. And since we had this problem, the shifting plaque up and down, the moment you dilate here, again, it goes there. And I did a Hybiz. It clearly showed that there is a hematoma which is moving up and down there. Probably this was not a atherosclerotic lesion. Probably it was a SCAD that we have stented there. And this, again, look at this angiogram pictures. There are intraluminal defects. So it is a recanalized thrombus. So the difference between a SCAD and a recanalized thrombus is limited to the lumen. There is no break in the intima and there is no involvement of media. But in the SCAD, it's predominantly a layer between the intima and the media which gets involved. And here you get a lotus root appearance with multiple channels there. And this type of patients, you can decide whether to treat it or not. Probably many times the FFR is positive in such cases. Or you can look at the effective lumen area. You can measure all the lumens of all the recanalized thrombus, and you can look at what is the effective lumen area, and you can take a decision whether to stent it or not. So this is a thing. And other important things today is minioca, where you have a non-obstructive coronary artery disease or a normal coronary artery disease with findings where there are a lot of publications which shows that when you do an OCT in such minioca cases, the common causes are probably a SCAD or hematoma or a fissure and a ruptured plaque. This is what you see in all minioca cases. And this is also another interesting paper where they have said that in minioca, these were the OCT findings that they have seen there. And to remember today, when you are looking at it, when looking at an acute coronary syndrome, when you come across a classical angio, there is no problem. But when there is a non-obstructive coronary artery disease or the coronaries are normal, then probably the role of imaging is very, very important. You can pick up the exact reason for that. And along with OCT and Hybiz, today cardiac MRI also plays a great role in diagnosing cases where there is a controversy. This cardiac MRI can clearly make out whether it's an MI or is it a myocarditis or is it amyloidosis many times, which is mimicking coronary artery disease, or is it a DCM. And this differentiation is very much possible with cardiac MRI. And I'll conclude here saying that imaging is indispensable in coronary artery disease today. And most of the occursion, atherosclerosis is the cause, but it might be presenting in a different way, which you need to do imaging to make out. And non-atherosclerotic pathologies are not uncommon. You usually, probably, you come across them, and image guides in proper diagnosis and treatment. Thank you so much.
Yeah, thank you. Very nice lecture. We learned a lot. I think that imaging can help us in taking the right decision. But I have a specific question. You very fast mentioned that with SCAD, there is also the risk of worsening the SCAD itself with OCT. So can you suggest us, okay, obviously if we have a clear diagnosis by the angio, it's enough. But sometimes we have some doubts and we need imaging. So can you suggest us when we should use OCT and when not we should use OCT for the final diagnosis of SCAD?
See, the cases which I showed where typically by angiogram you really cannot diagnose that it is a SCAD. And there was no TIMI-3 flow reduction. That is, if there is a very good flow and if it's a lesion is very somewhere in the middle, and when you are not sure about the diagnosis, definitely you should do an OCT. When probably we should avoid is if there is a TIMI-3 flow reduction, like if it's a TIMI-2 flow, and you feel there is something on the angio itself producing a dissection in the proximal part, probably you should be a little bit careful when you do OCT. Hybiz also is useful, but the problem is it may not pick up dissections so clearly as in OCT. And these are very, very useful in young ladies or in people where the other vessels are completely normal. You have a very focal lesion and which you are thinking that probably it is not an atherosclerotic lesion. And many times these lesions were accidentally picked up. We did not think that it is a SCAD and did not do, since we do routine imaging before angioplasty in most of the cases, and since it was a diffuse disease, we picked it up accidentally on an OCT, showing that it's a SCAD, not an atherosclerosis.
We move on to
CT
the last
angiogram
presenter.
will not show SCAD. You cannot make out very clearly that whether it is a SCAD. And probably OCT is the investigation of choice here.
Okay, thank you. We move to the last presenter, which is Dr. Rajnikant, role of intracoronary imaging in stent stenosis. Well, it's easy. Raj, always.
Thank you, Bernardo. Thanks to the organizers for this invitation. My name is Rajnikant Rajagopal. I'm from Pondicherry. You see the picture on top here, and I work in Brunei at the moment. That's the picture at the bottom. I'll be talking about the role of intracoronary imaging in in-stent restenosis. All right. This graph shows the rates and trends of in-stent restenosis and other stent failures over the last 20, 30 years. You can see there is a big drop in the incidence of ISR when we moved from BMS to the first generation drug-eluting stents and then to the second generation drug-eluting stents. After that, the biggest drop in ISR was when we had imaging-guided PCI, and you can see that here. Sorry, let me get the laser pointer working. Okay, so there. So, and it's not surprising, we know from a lot of studies now, from long-term follow-up and large trials, that imaging-guided PCI in de novo disease improves outcomes by improving our vessel preparation, stent sizing, optimization. And if you think about ISR, all these mechanisms still work, but you literally have an extra layer. And that is the role of imaging in understanding the mechanism of failure, which will dictate our treatment. So that is what we're going to talk about for the next few minutes, how to identify the mechanism of stent failure by imaging to help us guide our treatment strategy and optimize treatment. The bottom line is the best time to do imaging is before you get ISR. So get it right the first time, but if you don't, we should get it right the second time. So this is the kind of thing we see with ISR on imaging. I won't go into too much detail, but broadly, if you look at the images, the OCT images on the left, starting from the first one, it can show us the calcium behind the stent struts that leads to underexpansion. It can show us stent fracture, where you see no stents on one side and the green lines are the stents, or two layers on the left side. And here you can see a well-expanded stent, but a lot of neointimal hyperplasia. So you have the OCT images in the cartoon depiction here. And here you have a well-expanded stent, but you have neoatheroma with lipid pools. And you see similar images on the right side with IVUS. For example, on the right extreme, you see neoatherosclerosis with calcium on the IVUS. But if you see these images on the angiogram, all you can see really is luminal stenosis. You will not be able to see the mechanism, and therefore we travel blindly when you do PCI with just balloons. And is there evidence to support imaging in ISR? Very little, actually. We do not have any large randomized controlled trials. Small studies like this, the RIPS-3 study, for example, in that about 38% of patients had IVUS, and in these patients you had a larger acute gain and a larger minimal lumen area at 9 months, but it did not reduce TLR at 3 years. In another study, the eye-open ISR, about 1,500 patients, IVUS was used in about 2/3 of the patients, and in these patients you had less MACE compared to angiographic guidance at 1 year. But again, they were similar at 2 or 3 years. There were limitations to these studies, mainly because imaging was used at the operator's discretion. There was no systemized protocol to use imaging or the PCI itself. So we have lots of classifications of ISR. This is probably the most relevant one clinically and the most recent one by Waxman. So he has a lot of the 5 different classes of ISR. I think the most important to understand would be the first 2. If you see ISR these days with imaging, we should look at it as either mechanical or biological. And mechanical includes underexpansion and stent fracture. A couple of other things will come to it. And there are biological problems. And once we identify the mechanism, you can choose the right treatment option. And in reality, though, quite often we see a mixed pattern, a bit of mechanical problem and a bit of biological problem. And once we identify it, we can choose the right combination of balloons stents or DCBs to treat them. So to understand what we see on OCT or Hybiz, we should understand the pathology. So first we look at mechanical factors. The most common by far is underexpansion. So during the initial index procedure, if the stent was not fully expanded, it leads to ISR in the future. And that could be either because of low deployment pressure when you deliver the stent on post-dilate, or because of calcium behind the stent struts, which has not been adequately prepared. The other causes could be undersizing a smaller stent in a big vessel, stent recoil, stent fracture, and geographical miss. And there are some illustrated pictures on the right where you can see the vessel is quite big and the stent is far, way away from the EEL, and therefore it's clearly underexpanded. The other slightly difficult and harder one to understand is the biological factors causing ISR. So broadly, we think about neointimal hyperplasia and neoatherosclerosis. Neointimal hyperplasia happens within the stent. So if you look at the picture here at the bottom, that is the plaque from the de novo artery before the stent was put in. The blue line is a stent. And neointimal hyperplasia is a completely separate pathology, not an extension of the original atheroma. It occurs after the skin's been put in reaction to various factors such as polymer and metal, and inflammation mainly. So what you have is tissue proliferation, a lot of vascular smooth muscle cells, and extracellular matrix. And this appears as neointimal hyperplasia. On top of that, if you have lipid pools, that usually starts with the arrival of foamy macrophages, which can lead to lipid pools and a necrotic core. That becomes neoatherosclerosis. And you can have just lipid pools, or you can have just calcification, or a combination. Anything other than simple tissue proliferation could be labeled as neoatherosclerosis. So you have a homogeneous neointimal hyperplasia, and if you have calcium or if you have lipids, it's neoatherosclerosis. That's a very basic way to understand the pathology and the OCT or the Hybiz interpretation. And here you can see histopathology comparison with OCT. The neointimal hyperplasia is homogeneous, bright, uniform layer, whereas neoatherosclerosis is heterogeneous, and you can see calcium and sometimes lipid pools. In stent underexpansion, again, you see the stent itself is not fully expanded, on top of which you have tissue proliferation, you have neoatherosclerosis as well. As compared to the two on the left, where the stent is good, but it has got tissue problems. So once you understand this, you put them together, and there are various algorithms to guide your treatment. This is what I practice in my everyday in the lab. So when I look at in-stent restenosis, do imaging first, and I call it either mechanical or biological. If it's mechanical, try to understand the mechanism on OCT. Underexpansion is the most common, or undersizing, maybe stent fracture. So if it's underexpansion, I start with an NC balloon. If it is not adequate, I go for an OPN balloon. If there is calcium behind the stent struts, we can use IVL. And similarly, for undersizing and stent fractures, an NC is usually an F. If the stent is really small, you just got to break it up with an OPN balloon, put a new stent in. Reassess, and then finish with a DCB whenever possible. Stents only if you have really exceeded the expansion limit of the previous stent, then you have to put a new stent in. For biological problems, a scoring or cutting balloon for neointimal hyperplasia. If it's neoatheroma, you look at if there is much calcium. If there's a lot of calcium, you have to think about cutting balloon, IVL, and rarely rotablation. Reassess with imaging or angio, and finish with the DEB mostly, but DES if there is significant residual stenosis or flow-limiting dissection. I have time, 2 minutes. I'll just do maybe one case example. Very simple, straightforward case. So this is a middle-aged man with NSCEMI who had PCI to circumflex in OM. He had bystander disease in RCA. He had previous stents about 10 years ago. He came back for stage PCI. We looked at the distal RCA lesion, which you can see here. That's to be absolutely sure is significant. We did RFR actually, that was positive significantly. So we proceeded to PCI. We did imaging first, and that showed a bit of both. So the biological problem here was neoatheroma. You can see initially there is a lot of bright plaque here that looks like the neointimal hyperplasia, but behind that you can see lipid pools And calcium is very mild, not much, but it almost looks like a tick fur here with a lot of macrophages and shadowing behind that. The mechanical problem, we could see, that if you look carefully in this OCT image, you can see two stent layers. And there's always going to be a problem because it's often the focus of ISR. So we did some PCI, 3.5 NC balloon, did further imaging, and the balloon was underexpanded. It was significant residual stenosis, and it was exactly at the point of the two stent layers. So we then used an OPN balloon to dilate that. We got a good inflation, and we got a good final result. Okay? So we identified the mechanical and biological problems, and we optimized the treatment to get a good result. We won't do the second case example. Instead, we'll just summarize a very interesting case, but another day. Okay, to summarize, I'm just going to put the algorithm back again because that really, we need to use imaging, and we need to tailor our treatment based on the imaging findings. So we do imaging, identify the mechanism, treat appropriately, and optimize the final result using imaging findings. Thank you very much. We've got some pictures here of Pondicherry, the right side, and Brunei. This is Brunei, so welcome to visit us in Brunei or Pondicherry when you get a chance. Thank you very much.
Thank you, Raj. Very, very elegant lecture. With the last slide is the best one, I have to say.
Thank you.
So, do we have time for a question? You're escaping? Don't escape. Just a small comment, because this is very important. You said that for ISR, we should always use imaging. That's okay. But a good message is also that people should take their time to interpret and understand what they are looking at. So you should waste a little bit more time to understand, because we already have a failure of a stent that we previously implanted. So let's try not to go in the same direction.
I completely agree. I've seen cases where they do IVUS and say, okay, this is the minimal lumen area. That's not enough with ISR. You have to go into the morphology and tailor your treatments. I completely agree with that. Thank you.
So it's over.
Thank you, Bernardo Couto, and all the team members. Actually, I should thank them. We will go to the last 3 sessions more left out. One is 2 live cases and master CD presentation and award presentation. Be with them, because the award presentation only in the last moment. So we want to keep minimum that 12 people in the hall. So we will go to the live cases. We will go to Chandigarh first and then go to Patna. The chair session, actually, already Rajiv came, Dr. Mantosh Panja, MB Girish, Ravikant Patil, Pankaj Jariwala, Hilal, Anurag Sharma, Rakesh Verma, Rajiv Agarwal, Ravi Kalra, Rajendra Deshmukh, Nirmal Kumar, Jagdish Babu, Harita, and Sambashiva Rao. The point is, we will have a lightning talk in between, and then we will go to the live cases directly. And from after 1 o'clock, you can have the lunch, but I will not recommend you to go for the lunch and come back. But after lunch break will all be 15 minutes. After that, we will be having a master CD presentation followed by award case presentation. Please go ahead. Rajesh.
Hi, good afternoon. Can you see us? Can you hear us?
Yes. Yes, Rajesh. Dr. Panja here.
Hi, sir. Good afternoon.
With me. Yeah.
So, welcome to the Department of Cardiology, PGI Chandigarh. It's a privilege and honor to have the live case there, the NIC, CSI. Thanks to the organizer and the Pratap for the favor. So this particular case, let me introduce my team. Dr. Basant is associate professor working with me, and Dr. Jai, senior resident, Dr. Thakur, and Dr. Tanuja is also there with me as the fellow of cardiology. I do have the Joseph as the technician, and Nikhil is there on the imaging. So can I have the PowerPoint presentation? Okay, Dr. Basant, next slide please.
So here is the case. 81-year-old hypertensive male presented with angina, rest angina a week back. The clinical examination was unremarkable, and ECG was showing, I can see here, RBBB, and TROP-T was positive. Creatinine was 1.14 milligram per deciliter, and EGFR was 62 ml per minute, 1.73 meter square. So see, he has a significant past history of PCI, distal RCA and proximal LCX was done in 2009 at another hospital, and the PCI to the proximal RCA and the distal LCX in 2016 in our hospital. Next slide, please. You can see the echocardiogram is a well-preserved LV and a concentric LVH, normal EF. Next slide, please. So here is the angiogram. You can see this view, the ostial LCX has a significant lesion, and the proximal mid LAD has also significant lesion. Next view, please. Yeah, the mid LAD has a significant calcified lesion starting from the proximal one. In the caudal view also, it is the same. Next view. So RCA patent was a stent. Next view. So PCI to RCA was done in 2016, next slide. Yeah. So PCI, the distal LC in 2016, where with the rota ablations, 1.5 mm burr and 3.38 Giants prime was implanted. Next, please. So the plan is the image-guided PCI to the ostial LCX and the LAD. Over to you.
So,
Can you show the plan?
Rajesh, this is
Yes.
Rajiv Johar from New York. So you would call this Medina class, what, 001 or 011?
It's a 011. This is.
You think the ostial LAD is involved?
See, it's around 70% disease across the LAD, and then we are not sure about, though the mid LAD do have a significant lesion. It's a trifurcation point over there. And can we have this is the first view or second view? Okay. And this is, you can very well see the bifurcation is bifurcation side of the left main, there is the lesion, and therefore it's 111. But then there is a need to assess the LAD, which is around 70%. Ostial LCS, of course, is very significant.
Okay, Rajesh, you are angiographically definitely saying the ostial lesion of these LAD and SARC. I believe you are a man of the Hybiz, so definitely I may extend possibly distal LMC as expected.
Okay.
The question is how we're going to proceed. Are you going to proceed with a two-stent strategy, which I assume you will? What is your plan? What is the panel?
So the plan is go to the previous view, first view. See over here. See, LAD doesn't seem to be so significant. If you see the proximal LAD, it's of course calcified, but the lesion is around 70%. Ostial LCX is of course significant. You do an proximal LCX and also the distal LCX. The stent is there, which of course is patent. So the plan is to have an assessment of the LAD, whether it is significant, and then to proceed accordingly. Of course, the LCX can also be assessed functionally and also with the image guidance to look for. We already do an proximal LCX stent, which has been deployed in 2009, and the distal LCX, of course, in 2016.
So Rajesh, you're going to do IFR or FFR of the proximal LAD?
Absolutely right. So let's have the functional assessment. Can we go to next view, please? So you can very well appreciate there is the calcification across the ostium to distal LAD. In this fluoroscopic view, we have a wire across the left circumflex, and this is the FFR wire in the aorta. Next view, please. And this is the FFR across the left circumflex. Can you demonstrate the FFR across the left circumflex, Nikhil? Baseline and post-adenosine. This is what post-adenosine and baseline. So we had an FFR across the left circumflex ostium 0.89, which dropped down to 0.77, 0.73 following the adenosine. So it's a significant ostial left circumflex lesion, which is there. Angiographically, sometimes it's very difficult to assess whether the LCX ostial lesion is significant or not, and therefore we went ahead and did the FFR across the LCX, and which turned out to be significant. Meanwhile, as we have taken the FFR for the LCX, we have taken the FFR of the LAD as well. So can you show the FFR of the LAD, which is baseline 0.90, and post-adenosine is 0.76. So this is about the FFR. Next view. Okay. Okay. So this is what the functional assessment, and which is very much suggestive that we are dealing with a significant LAD and also the left circumflex. Any comment?
You know, the one area where I'm always wrong when I do IFR or FFR is the LAD. For whatever reason, when I think something is going to be non-significant, this one I would have thought would be significant because it's long and diffuse, and just the length of it would probably make it significant. But I've had many situations where I thought a FFR would be negative and it was positive in the LAD.
Not only that, the FFR is more predictive, and in view of that, the FFR predict the maze and TLR better way than the IFR. Rajesh, do you believe or not? There is article is there.
Yes, yes. See, the sensitivity of the FFR basically the gold standard. In case you do have the IFR, which is say less than 0.86, it's fine. More than, in case it's in the gray zone, and that's the time one has to go ahead for the FFR. We have already done the FFR following intracoronary adenosine across both left circumflex and LAD, and it turned out to be significant.
Dr. Rajesh, Dr. Girish here.
Hi, Girish.
There are some technical aspects. What is the guide which you have chosen? And the words for...
Okay, this is what we have taken is it's a 7F femoral sheath, and it's a long sheath. When I did the LCX PCA in 2016, there were tortuosity and difficulty in cannulating the left corona. Therefore, we have taken the long sheath at that moment of time, and therefore at this moment also we have taken the long sheath. And this angiogram we have already assessed this around 3 days back, and next view. So okay. So this is the diagnostic angiogram which we did 3 days back, where we assessed both the LAD and the LCX, and today we have taken for the PCI.
I think Dr. Rajesh,
this is not the view at present. This is transradial 6F, and then we had an assessment of the left main bifurcation around 3 days back.
I think, Dr. Rajesh, I think you have long left main and LAD lesion which is very long, and LCX ostium lesion is very focal actually. So I think I expect that you will do a good job first for the LAD, and then I think we can decide about the upfront strategy for the ostial circumflex. What is your opinion on this?
Okay, so this is the first angiographic view today which we have taken. You can very well see the long sheath in the aorta, and then it's a EBU 7F guide across it. And before that, we have already done the OCT across both LCX and the LAD. So can you show the OCT across the left circumflex? So this is the, can you display the OCT? Big screen, please. Okay, so this is the OCT across the left circumflex, and you can very well appreciate distally the stent is okay. Proximally the stent is underexpanded. It's a 3 millimeter stent which is having the dimension of 2.5. Nikhil, how much is the dimension over here? 2.4. So it's basically underexpanded stent which was deployed in 2009. And then this is the ostial, which is very significant. Ostial LCX having the area of 1.65 millimeter square. Nikhil, what is the distance between the ostium of the LCX and the stent across the proximal LCX?
It's 10 millimeters maybe?
So it's a 3 points. Yes, please.
Yes, there is both mechanical and biological factor responsible for the ostial restenosis.
Absolutely right. Yes. See, the distance between the stent edge in the proximal LCX and the ostium is 3 millimeter. So it's a part of, say, in-segment restenosis, I would say, but definitely there is a disease which is focal at the ostium of the left circumflex. And this is the left main, which is calcified. You can very well appreciate some calcified plaque across the left main. Can you again demonstrate the left main? We do on the left. So these are the left main. See, you see the calcified nodule over there at the left main.
Yeah, there's about 4 o'clock, 4 or 5 o'clock.
Absolutely right, 4 o'clock, and the left main, which is again calcified. Left main dimension over here is 4.5. The proximal LCX is 3 millimeter. Ostium again is 3 millimeter in dimension. Can you show the LED OCT run as well?
The calcified nodules of LMCA, whether eruptive or non-eruptive, can you predict on the OCT basis?
Yes, it can be very well predicted, and here it is a non-eruptive calcified nodule in the left main, and this is about the OCT run across the LED.
Rajesh, in the interest of time, because we have to go to another case also, what is your strategy now?
My strategy is to go ahead and put the stent across, say, left main to LED crossover. Focal LCX lesion can be taken care by, say, balloon dilatation, and thereafter let me see what the result is across the left circumflex, and then to decide whether to put the stent or what next.
So you would do just a regular non-compliant balloon into the circumflex, not a DCB or cutting balloon.
Let's go ahead and discuss it out, how to proceed further. Meanwhile, as it is calcified lesion across the LED, 360-degree arc of calcification is there, which can be very well appreciated. Minimal luminal area. Can you demonstrate, Nikhil, what's the minimal luminal area? It's a 1.95 in the mid LED. Approximately, it's the LED which is very much calcified with the area which is on the lower side. And of course the left main which is diseased. So my plan is to go ahead left main to LED, cross our stenting and see about how to proceed further for a focal lesion across the ostial left circumflex.
What is the expected length of the LED lesion from the ostium?
Nikhil, how much is the length? Can you demonstrate ostial left main to mid LED? This is going to be around 60 millimeter. 55.
The mid LED is what size again?
Sorry?
The mid LED, the MLA is what?
Mid LED MLA, can you show the minimal 1.95?
Okay. Very significant.
Yeah, by the definition criteria, I think, will it fit into upfront two stent strategy?
See, with the focal, simple bifurcation left main, this can be taken care by the one stent strategy. And you do an in-stent restenosis or rather in-segment restenosis of the ostial LCX, so that can be treated with regulating balloon.
I think what we feel is maybe upfront cutting balloon to the circumflex ostia and maybe DEB later on after the stent.
See here if you see the OCT across the left circumflex, there is no calcium. Of course, there is the calcium across the LED and also the left main. So let me see how the result is going to be after balloon dilatation, and if required, we can go ahead and do the cutting balloon across the ostial LCX as well.
But Rajesh, your strategy though is a provisional single stent strategy right now.
Absolutely right.
And you may change, but right now. Because having a plan obviously is very important, and so you'll stent, you'll first double wire, you'll balloon the circumflex, then you'll stent the LED, and then provisionally deal with the circumflex again. Is that true?
Absolutely right. So you can proceed for another case, and meanwhile I do some work over here, and then you can revert me back.
Rajesh, I believe that it will be better. We have to preparation of the ostium also by the cutting balloon, prior to the provisional stenting LED.
Okay.
Otherwise, great difficulty will be arise later on.
Right. We do an 360 arc of calcification across the LED. Any comment about other than cutting balloon rotablation?
There were some calcium specks in the mid and proximal LED, so that you can have a look again carefully and then take a decision.
You know, I think I would. I always, if I think rotablator or orbital, I always do it because I think the regret is very painful. So I would argue that you should probably debulk it with a rotational atherectomy of the LED. But you know, in the interest of time, I'm going to go to the next case, next center, and then we'll come back to you in a few minutes.
Please.
Pramod, switch over to partner. Dr. Pramod, please.
Yeah, good morning.
Okay, good evening.
Can you hear us? Can you see us?
We can see and hear you.
Okay, see you and well audible and visible. And here
Okay,
with
we
me,
can't
Dr.
see any one
and
of you.
Others.
Let me introduce my team. I am Pramod, and right next to me is Dr. Shamshad, and next to him is Dr. Pawan, and then we have our team. Can you just pan the camera to our technicians, Manish, Sundar, and then we have our chief nurse, Robin, with us. So we are more than halfway through because we thought that we must start at 12:30. So this is a 71-year. Shamshad, can you quickly tell them the clinical history, please?
Yeah, actually, this is a 72-year-old male who had atrial MI almost 2 weeks back. So he presented to us with decompensated heart failure. We stabilized him. He was in AKI at that time. And after stabilization, we did an angiogram. Angiogram revealed a left main trifurcation lesion.
Can you show the angiogram, please?
Next. The right coronary was not significant. Next.
Unfortunately, large vessel.
Yeah, it's a large vessel, and some collaterals are being
to the distal LAD. Yeah, just to distal LAD.
Next. And this is the left-sided angiogram. We can see.
So the next one. Yeah, show this one. Just hold on. So this is a 1-1-1 left main bifurcation stenosis. And as you can see here, there is a large diagonal or ramus, whatever you call it. And that has about 90%, LAD proximal, osteoproximal is about 90%, and distal left main is about 70-80%. So the plan was to go for provisional stenting, strongly believe in the EBC main results and the strategy. So we decided to wire all the three. We have taken, this is a radial route, we have taken that 6 to 7 glider sheath. If you can show it here, this is the sheath, and we have taken a 7 French jail guiding, and then we have put 3 wires in the main circumflex, in the ramus, and in the LAD. LAD was a little difficult, so we had to use a whisper wire, otherwise the other two are BMW wires. So the strategy was to dilate LAD, left main to LAD, and the ramus. With first we do,
How was the distal LAD? I didn't see any flow in the distal LAD in your first angiographic picture.
No, the distal LAD is flowing. Distal LAD is flowing. You know, because he has, his creatinine is about 1.7, eGFR is 43, so we are very particular about using the amount of dye. Distal LAD is flowing. The distalmost part of LAD is about CTO, and it is filling very well with from the right side.
Now,
so
you said he had a large MI.
We are not chasing that.
You said he had a large MI 2 weeks ago.
Not exactly large MI. His ejection fraction is about 40%. Basically, the apical is severely hypokinetic. Rest of the LAD area is hypokinetic, but it's moving. It's better than what it was.
Did you image this LAD?
You want to see the LAD?
No, the imaging.
Yeah,
yes, we did the imaging. We did the Hybiz run on LAD. And can you show the first one?
What is eGFR? eGFR and the creatinine. You told that.
eGFR is 48.
48, okay.
Yeah. So this is, can you see the Hybiz images?
Show it on the screen.
Yeah. So the Hybiz images shows a very mostly fibrotic, fatty rich plaque in the majority of the LAD. Near the ostium, there is calcium. At one point, there is about 270 degrees. Then there is another point which is about 360, but the 360 is deep calcium. And the area at that point is quite good. The mean diameter, luminal diameter is about 3.
But his calcium score is high, right? The depth looks significant. The length is more than 5, and you have concentric calcification.
Yeah, so we have been able to achieve good lumen size after doing cutting balloon in both LAD, and in LAD we went up to 2.5 cutting balloon, and in the ramus we did with 2, and we plan to just stent it from the left main, mid left main to the LAD, and do a deb to the circumflex, to the ramus. If there is a problem, we'll do a tap. This is what the plan is.
Okay.
So we did a post post-dilatation IVUS also, which shows a good luminal area, and the calcium is definitely, it gave way at many places. So we're not contemplating any rota or IVL. Rota not for the simple reason that, it may close the ramus, which is a very significant artery. And IVL, there is a standby IVL, but we still feel that we should be able to get a good lumen size with the...
I think your angles are very, very helpful for a TAP possibility.
Yes.
And I think the TAP is a great idea. I agree. I would not do DK crush here. I would probably
No.
do
The crush will actually close the
it would
circumflex.
close the ramus.
The circumflex.
Or the circumflex,
So
whichever way you go.
Yeah, so we don't want to do that at all. So we will definitely trust our TAP if it is needed. But we will, for the time being, we are still in the provisional strategy, and we have done the dilatations with 2.5. We have done the 315 dilatation to the left main distal, and now we are going ahead with our stenting program.
What stent are you using?
We are using an Onyx 3. The size, I think, will be 38, so that we have enough length to do a pot in the left main.
So a 3.0 by 38?
3.0 by 38, yeah.
Yeah, I like the Onyx choice because for the side branch access, I think it's beneficial.
Yes. We will just take a AP cranial view to see the extent of the length of the stent we need for the distal LED. Can we go do a injection in the AP cranial?
What was the size of LED?
LED is 3. LED is 3. Yeah.
Okay. So you're using the two stent, distally 3 and proximally from the LMCA to proximal LED.
No. We'll dilate the same one. If need be, maybe I'll take a 3.5 because the left main size is about 4.5. Okay. So I will take a 3.5, under deploy it, and then do a proximal pot with 4.5.
Okay.
I still have a feeling that the distal LED can still be probed, and I think you require a stent there too.
No, it's far too distal. There is a very good collateral from the right, so I don't want to touch that. There is a big diagonal, so I would like to preserve that. Take a picture, please. So see that? Yeah, I would not like to touch that distal LED at all.
I'm still concerned about that calcium. I mean, even on angiogram, you see a significant amount of calcium.
But the lumen gain is quite significant, quite satisfactory at this point of time. If you would like to see the previous angio, it was just a thread.
That's okay.
Just a thread.
So we'll let you get the stent in, and then we'll probably move back to the other lab, or maybe do the lightning talk.
Yes, sure. Absolutely. Thank you very much.
Rahul is coming?
Right.
So he'll talk the lightning talk.
Rahul.
Dr. Rahul is coming to give the lightning talk for 4 minutes.
Can we go to the...
Pramod, did the stent go down?
No, I'm not just... I'm sure it'll go down.
Okay.
So let's get the stent.
Okay, so I think we moved over to Rajesh. Rajesh, what did you do? And then we'll do the lightning talk and then come back to you. What did you do while we were gone?
Okay, just a minute. Negative.
Oh, I think he's talking. Yeah, he's talking.
Okay, can you show the previous snare from where we left?
So on the panel, what did the people think down the hall over here?
Dr. Nirmal Kumar, what is your thought? Dr. Nirmal Kumar, what is your thought of the case?
I think first we should do the good work for the circumflex ostium. First we should do the good work for the circumflex ostium. Use the cutting
can we go to the...
then, if it is possible, drug-coated balloon, and then do the stenting across the LMC, because LMC is also a critical lesion in one view. So you can go across the LMC to the circumflex.
Next.
So Raj, what did you do?
Okay, next. So from here we started, we extend the rotafloppy wire across the distal LED and did the rota ablation with the 1.5 bar. Next. And this is after the rotablation. Next. There is one major branch diagonal, the first one, and then the other one is the disease distally and also the proximally. Next, we did wire that particular branch, the proximal one, which is a bigger one, with another wire and also a wire across the left circumflex following the rotablation. Next. And here this is 2.520 NC balloon across the distal LAD where the calcium is less than 180 degree. Next.
You know, I love the fact that you did the ballooning after the roto.
Absolutely right.
A lot of my colleagues will just roto and then try to stent it, and even then they can't get full expansion, and then it causes a huge mess. So always balloon before you stent.
Rota balloon or rota cut, this is very ideal indication.
Okay. So it's a 2.5 distally. Next you please. And these are the same balloon 2.5 across the D1, which is a big branch. We went up to 8 atmosphere, a slow inflation and the deflation. Don't want to have a dissection across the ostium of the D1. Next. So this is what good flow across all the two branches, D1 and D2, and of course the LAD. Next. And then this is the cutting balloon, 3 millimeter. Our proximal LAD is of 3.5. Here we have taken the 3 millimeter cutting balloon. That's from the Boston, Wolverine from the Boston. Next view. Next view. This is proximal LAD cutting balloon. Next view. Next view. Left main to LAD cutting balloon. So here is what we have achieved after having the cutting balloon across the left main to the LAD. Next view, we dilated the left circumflex ostium with a 2.5 balloon. Next view. And this is the 3 millimeter NC balloon across the left circumflex, been inflated at 18 atmosphere. Good dilatation, you can very well appreciate there is no residual ostial stenosis of the left circumflex. Next.
Did you do any cutting balloon to the left circumflex?
No, we did not. We did not, as there was no calcium across the ostium of the left circumflex. It's a tight fibrotic stenosis, and therefore we didn't go ahead for the cutting balloon dilatation across the ostial L6.
LAD distal part, there is some lesion. I think it is not dilated. Do you like to put the stent at the adjacent to the D1? Adjacent to the D1 there is.
So distal to the balloon dilatation, there is some disease. Next view. And this is what the ostial L6 flow after having the balloon dilatation. Next view. And after the NTG, there is an improvement in the distal LAD flow. And you can very well appreciate there is a lesion which is after the origin of the D1 and D2, extending up to say 20 or 24 millimeter. Next. And this is 328 as the distal reference diameter was a 3 millimeter, 328 giant alpine across mid to distal LAD. We just took care of that to cover both the D1 and D2 with a single stent without any overlapping with the second stent which we are intended to put from left main to LAD. So this is what 328 across mid to distal LAD. Next. And the residual length is around 28.
Raj, did you think
Yes,
maybe doing OCT here versus Hybiz because there's so much calcium?
No, here we have not done any imaging at this moment of time because we were aware of what the size of vessel, how much calcium is. We have done the debulking with the rotablation followed by the cutting balloon, and therefore we thought let's go ahead and put the stent and then do the post-stenting imaging to look for what result we have achieved about.
Dr. Rajesh,
Yes,
you are managing 3 wires now, and now you are putting stent across the left main to LAD. Would you like to see that first bifurcation, and you want to remove the diagonal wire because you are trying to jail 2 wires? So because how you are managing these 3 wires, that also is very important.
Absolutely.
Or prior to that, you can treat the D1 if possible.
A good point to discuss over here, whenever there is a calcified lesion and you have a jailed wire which is of so a great length, there can be a problem in removing it. So next view. So now we just position the left main to the LED stand. Next view, and here if you see, we have removed the diagonal wire before putting the stand from left main to LED. As the flow across the D1 was good, we could safely remove the wire and then went ahead with the stanting of left main to LED. Next view, please. And this is 3.533 Giants Alpine stand from the left main to the LED. We have a LED reference diameter which is 3.5 proximally, and also the ostium left main is of 4.5. And this is what the result is. Overlapping is there just proximal to the D1 origin. There is a good flow across D1 and D2, and of course the LED. There was some lesion which
Rajesh,
got
are you going to
improved.
image now the ostial LED and the left main, or are you going to wait?
Sorry?
Are you going to image the left main and the LED?
No, we have already put the stand from left main to LED at this point of time, and this is post-stenting.
Right, but my point is that in my practice, I will image 100% of patients who have a left main because I'm never sure if I've expanded that stent completely. It looks underexpanded in the distal left main. I'm just wondering if it would be better to image it and make sure.
Okay, we already...
some narrowing is there in the middle of the sapped up the stent.
Absolutely.
And I think LCX should be imagined before going for the angioplasty stent across the LMCA. Because after that, LCX imaging is difficult because still some haziness is there in the ostium.
You know, I was talking more about the LAD into the left main imaging, and not the circumflex. The ostial circumflex is always very difficult to get a good result with just a balloon. It's more fibrotic than you think, and I just think you're going to have to either do a cutting balloon or something else there. But in the meantime, we're going to go to our lightning talk, and we'll come back to you in about 4 minutes.
Yeah, this point about the circumflex ostium, the concern is that it has been addressed with only an NC balloon and not with a cutting balloon.
That's what I mean.
Suppose it closes off after the pot. So I think initially it should have been addressed with a cutting balloon or at least a scoring balloon. What do you?
100%.
I think, Dr. Rajesh, what you can do is you can rewire the circumflex and take a OCT picture from LMCA to LED to LMCA and circumflex to LMCA, and then take appropriate selection.
See, this result, what you are seeing over there is just after putting the stent across left main to LED and the mid LED. So can you go to the next view? Next view. And here is the post dilatation of the LED with the 3 mm NC distally. Next. And this is 3.5, and then we had a port with 4.5 across the left main. Next. Next. And this is what is there after having a dilatation of left main to LED with 3 distally, 3.5 proximally, and 4.5 in the left main as a port. Next view. And then we rewire the left circumflex. Next, dilated with 2.5 mm balloon. Next, and this is 3 into 20 magic touch drug-eluting balloon, which in the two session, 30 seconds each, we have inflated across the ostium of the left circumflex. Next. And this is what the result is at present, and now we have to proceed further.
Okay, so
I think imaging would help you now.
Yeah. So now it's the imaging time. Let me go ahead and do the imaging across both left main to LED and also left main to LCX and see how much is the result across the ostium LCX.
Raj, I think we'll come back to you. We're going to do our lightning talk, and then we'll come back to you after you go back to promote, okay? We'll see you in a few minutes. Can we get the talk, please?
Rahul, please talk.
Slide, please.
Slides, please, yes.
Audiovisual, please. Slide, please.
Good afternoon, one and all. I am Dr. Sisi from Jagjivanram Railway Hospital, Mumbai. I will go with a case presentation, then I will go. 55-year male presented to with me inferior MI, left system normal, right system shows diffuse lesion from the ostium the RCA till the mid to distal. So going ahead, pre-dilatation 2.75 to 15. Then I put a stent that is 348 suboptimally. Then I little bit pull the stent balloon, post-dilated optimally, then ostial flaring, then post-dilatation 312, and you can see there is a dissection. So there is a stent and edge dissection. So then what next? I thought, let me have one more stent, that is 2.616, but that was not negotiating. So there is entangled between the ostium of the RC and the second stent, and in between that, when I've done some inadvertently, so there occurs the balloon of the stent came out little bit. So now I'm not in a position to deploy the stent there, neither I can take the stent in between. And at that point of time, my patient started having pain because distal there is dissection, proximally there is occlusion. And what next? I'm not able to take one more wire to cross the stent there, neither I'm taking the stent in or taking the stent out. In between what happened, I can saw there is crumbling of the stent, and at that point of time, my snare also didn't work, what was available normally. So the second stent, now it hanging in aorta, and there is no stent balloon inside also, and there is a little bit support from the wire also. So what happened, I changed my mind from a radial to femoral, went to the femoral, and the femoral approach. At that point of time, I thought, what happened to my RCS? So I was not negotiating. Going ahead, serial balloon dilation 1.50, I got some result, and it's flowing. So in between what happened, so now I took a one more radial, I could notice the second stent is hanging in the aorta, neither it is supporting, no guide support, no wire, no balloon. So I don't know how it is hanging and by which support. So let me have something, what is happening to my hanging stent and what happened to my RCA. Now you can see the uniformity of the stent is no more there. In one side there is 2 layers of stent, and the other side there is no stent. So I thought the uniformity what I deployed stent is no more there. So what is next? Patient having pain, and whether I will fix my RCA or I will take the snare out. But I thought there is some support for which my crumble stump is hanging in the aorta. If I fix my RCA, then I may fix the support of the stent, what is getting it from the wall of the RCA. So I may not, in the second stage, I may not keep the snaring out. So at that point of time, if I didn't snare, so it can migrate anywhere. So looking ahead, I thought, let me have snaring up out. So I made the indigenous snare, and with the help of that, I was able to take the snare out, and the diploid stent and the second stent came out as piggybacking of the stent. You can see the crumbling of the stent, and the whole stent, the 348 stem, came out as a piggybacking. So this is piggybacking of stent. Finally, then I went ahead and I deployed the distal stent, pre-dilatation, further one more stent, and post-dilatation, flaring up. Then I go there. Then the question comes to me, what wrong went at the distal abdomen? Why I got it as stent edge dissection? So poor bed preparation, yes. I landed the stent in a significant plaque area, eccentric calcium, there is no. So it was the attenuated plaque or calcified plaque and overstretching of the vessel that could lead to mine. So when I go into literature, so stent edge dissection is defined, it is unintentional tearing of the vessel or adjacent to the stent, either the 5 mm proximal or distal to the stent. After the stent under expansion, so this is stent edge dissection is one of the most critical part of the stent. So angioplasty, nothing, it is a stretching of the vessel or distributed plaque. So far as DS leading to stent dissection is concerned, it can vary from 19 to 38 or even 45, so far as OCT. So let me analyze, when we are doing some imaging, what is the depth of stent dissection, what is the angle, what is the area what is left to, after the stent dissection, and what is the length of. So you can see this is the angle, so this is the depth, this is the length. So the stent dissection can be intimal, medial, or some or extramedial, or in medial we can have that intramural dissection. So you can see this dissection limited to intima, some go to media or intramural hematoma, the type. So the data, there is a adaptation IVUS stent. They also find the M was the prevalence or morphology of the dissection, then what is the outcome if we left that stent dissection alone, or what is the criteria. So they have done more about 2,500 cases, and they found the overall stent dissection is 6.6 in IVUS. And they found the predictor of the proximal stent dissection is if there is a plaque. whether it's calcified or it is attenuated, and the overstretching. Don't overstretch. Anyway, better is always good, enemy of the good. So proximal end expansion or distal end expansion, overstretching leads to stent dissection, and proximally calcified plaque or distally attenuated plaque. And 1 year follow-up, they found that TLR is more when there is a stent dissection, and if the minimal lumen area is less than 1.5, it is more likely. So they conclude greater expansion or calcified plaque is the predictor, and subsequently we can found the clinical presentation. We can have a STEMI is one predictor, and plaque type, and if you landed in a stent more than 50 plaque, or morphology if you are having ascendancy of calcium, or if you are high pressure overdilatation. So what is the criteria?
Okay, we're going to have to.
Okay, just so more than 200 millimicron, then medially angle more than 60, or length is what is the lumen area available more than less than 4, or length is more than 3. So they are predictors. So this is some example, intramural hematoma. So the intramural hematoma you can lead, you can either stenting, so dissection you can have a stenting or DV, or minor dissection you can leave it. And intramural hematoma I can have ballooning or some sort of cutting balloon or a stenting. So take-home message will stent dissection is a procedural complication, but it may lead to malignant course, and imaging plays a greater role. Stick to the basic and never overstretch, and because better is enemy of good. And if you fail to, this is the last line we need to have with your mind, if you fail to prepare, be prepared to fail. Thank you.
Interesting. Thank you very much. I think 2 things from your talk is that the stripping of the stent was more interesting than the stent dissection. Yes. Number 1. Number 2, imaging is so important because if you put a stent into a significant amount of plaque or calcified plaque, that's where the dissections occur.
So we need to prepare the bed.
We have to prepare. Can we go back to
Pramod? So come back to Pramod, Patna, please.
Yes. So we have stented from left main. Can you get another balloon, please? Give me an balloon. So we have stented from left main to LAD. We were able to cross 3.5 into 3.8 from left main to LAD. We have dilated it. Both the ramas and circs are flowing well. Can you just show the last shot, please? Yeah. Can you see that? Yes. यहाँ दिखाना है ना, वहाँ कहाँ दिखा रहे हैं? वहाँ यहाँ दिखाने को. Oh, can you see it? Okay, sorry. So we have done that. I'm recrossing we lost the wire actually to the ramus, so I'll have to recross that. We were able to recross that, and then I'll do a depth to. Should you not
fix the LED first? LED looks very underexpanded.
We have fixed the LED. Yeah, LED is looking good.
But it still looks like underexpanded stent there.
Yeah, we are doing that. We are taking care of that. Give me a three stent, please. And let me get me the LAO caudal.
Pramod, we have limited time. Can you tell us what your plans are now?
No, we just want to fix the LAD with a 3 millimeter balloon, and then run an IVUS and do a depth to the circ, to the ramus.
So your plan is sequential dilatation, ramus, as well as followed by the LAD once again.
Yes.
That is the plan.
Yes.
We have already dilated the ramus.
Yeah, we have dilated the ramus
with 2.25
cutting. So we will do a kissing here, and then we will do a deb and finish it. Can you give me a little die?
So I think in the interest of time, Pramod, we're going to have to leave you here.
Oh, sure. Please go ahead.
But you crossed into the ramus. That was a challenge, so that's great. And I agree with your plan of IVUSing or imaging the LED because I think it's still underexpanded.
Yeah, we will do that.
Okay. Pramod, thank you very much, and
thank you.
A nice round of applause. That was a terrific job.
Thank you.
Can we go to to Chandigarh, please?
Rajesh?
Yes.
Yes, now.
So
what have you done now?
I think you're planning for a tap.
Okay, so we have done the OCT. Can you show the OCT then, please? First for the LCX. Can you have a big screen for the OCT? yeah. Okay, so this is the OCT run across left circumflex, Nikhil, left circumflex. So this is after, say, 3 millimeter NC balloon followed by a drug-eluting balloon, and we do have a residual ostial stenosis, which is having the minimum area of 1.82, despite angiographically it's looking nice, but then there is a residual stenosis. Left main stent is
it deployed up from DCB, no?
Yes, this is after the drug-eluting balloon, magic touch, which is 3 millimeter for 60 seconds in total. And can you show the OCT on the LED as well?
At which atmospheric pressure? 6?
It's around 10 atmospheric pressure.
Raj, we have about a minute left maximum.
Okay, fine. So let me finish it off completely. Okay, so can you see the OCT run? Kindly display the OCT run of the LED. Yes. 8, 10. Kitna? 12. Very nice. Inflict. Negative. Inflict. 18.
I think you can show us the live what you are doing. We can see the OCT.
Okay. Just a minute. So what, even after having a balloon dilatation with a drug-eluting balloon of 3 millimeter, we didn't have a favorable acceptable result across the ostial LCX, and therefore decided to go ahead and do the tap stenting. And then we choose as the OCT, we didn't do the kissing balloon at this moment of time before doing the OCT, and therefore we decided to go ahead and put a 3.5 18 millimeter stent across the ostial LCX as a tap technique. And then it's a 4 millimeter balloon, as the size of the ostial to proximal LED is around 3.87, so it's a 4 millimeter balloon dilatation, and this is what we do have the result across.
Can we have the live pictures now, please?
Yes. So
very good.
We have removed the stent balloon, and 4 millimeter balloon is there across the left main to LED. Let me take the 3.5 NC balloon and the final kissing followed by pot. So that's the plan. And this is the angiogram before doing the kissing balloon, after putting a stent across the ostial LCX. So
it goes back to Raj, it goes back to my original point. The ostium of the circumflex is so hard to just balloon. It never looks right. I appreciate the fact that you Hybiz did or imaged it. OCT did, sorry. And that you saw that the MLA was really low and you put a stent in. So that's a great point. I think we're going to have to end it here. Do you agree, sir?
Yes, actually some narrowing on near the angle is small.
What we are going to do is 3.5 NC across the LCX, and 4 millimeter is already there in C2. So kissing balloon dilatation 18 individual followed by 12 atmosphere, and to be followed by pot with say 4.5 or 5 millimeter depending on the dimension of the left main. So that's what, and to be followed by the final OCT across both LED and LCX.
Okay, very acceptable result.
So according to your OCT right now, so what is the size you would be using for pot, left main pot?
Nikhil, can you show the size of the left main? How much is the size?
Is it 4.5 or 5?
Let us reassess it. It's 4.5, so it's going to be say 4.5 pot. And this is 3.5 balloon across the LCA. So let me go ahead and inflate it. 12, 14, 18,
okay.
Negative. So negative. And then it's the LED, inflate.
Can we do an NC balloon after a depth, sir? I need to.
18. So
the question
negative.
Is after depth NC.
After the DSA, you are inflating the NC balloon, or it is another drug-eluting balloon? Because
No,
all
it's
drug
an
will
NC
lost.
balloon. 12. See, now the question is, we have already put a drug-eluting stent over there. 12. So this is the kissing balloon with the 4 across the LED, 3.5 across the LCX, negative. And now we are going to do the port with 4.5, the final port across the left main. Any comment?
Till now, I think it's looking good. I think we would be interested to see the OCT after the port.
Okay.
Another 2 minutes to you, Dr. Rajesh.
Fine. So 4.58 balloon for the port, please.
Any comments from the panelists?
We have dedicated pod balloons nowadays available, and we are
Rajesh,
using plain non-compliant balloons most of the time for pod. Do you have any experience of using this dedicated pod versus what non-compliant balloon? Is that make any difference as such? We don't have it.
No, you are right. There are certain dedicated port balloon, but as in routine, we are using it from the Abbott and Boston with the satisfactory result. And as we have already covered the left main ostium, I don't feel like there is any problem in case our balloon is going to hang in the aorta. That's all.
So this side
Rajesh,
of the room,
you have deployed, actually you have done the kissing balloon, SARC and the LED after the DB implantation. But question of that, effect of the drug will be lost in the circumflex.
See, now the question is, we thought angiographically it's a good result, but then there is a residual stenosis across the ostial LCX, which was very significant, and therefore we have went ahead and put a drug-eluting stent. So now there is a question that you have put sirolimus drug over there with the magic touch, and now it's everolimus drug from the drug-eluting stent. So is it going to have some problem in the future with the two drugs which are the NC2 at the ostium of the LCX? I am not sure how this patient is going to behave on follow-up with the two drugs being there at the ostium of the LCX.
we were just wondering whether a two-stent strategy upfront would have been a good choice here, because I do think this ostial circumflex needs to be addressed, and would have been easier to address it right at the beginning. You could do a culotte or a mini culotte, and that might have been a better strategy, because many cases we've done like this, left suboptimal circumflex and ended up 6 months later with 90% ostial circumflex symptomatic.
Yeah, no, again, I would go with him. I would agree with that. And culotte versus decay crush. Why did you prefer culotte?
This is not culotte. This is tap technique. Okay.
So we are discussing with the panelists.
Yes.
Okay. Sorry.
Tap is not a good result compared to the culotte.
But a mini culotte would give you minimum of double layering in the left main. So keep very little, 1 or 2 strands in the left main from the. So if the first one was left main to circumflex, and keep minimal length in the left main, and I think because of that angulation, there's very little chance that you will not be able to address the LED afterwards.
I think you
that would be one strategy, but DK crush is good.
No, you're correct.
I think that if you look at the data, though, right, the DK crush is probably, if you're going to do a two-stent strategy in this scenario, I would argue that DK crush is probably the best option. Provisional, we could argue provisional, but this is a large circumflex, so I don't think so. But anyway, in the interest of time, I think we're now way over. I think we'll end the.
So, if you do have the time, let me go ahead and put the OCT across left main to LCX, and later on the LED. So you just have a look on the run for the left main to LCX and.
Raj, I think we're going to have to leave.
Okay, fine.
Time is over.
So it looks very nice. Terrific job. And I love the fact that you had a plan and a backup plan at the same time. So the plan was, whatever it was, and then it didn't really work, and you did the tap, and I think that was a great, great idea. So congratulations and a great job.
Thank you.
So,
Thank you
Rajesh,
very
I'm very thankful to you and to your teams. As a whole, they have done a wonderful job done by us. And both the operator, both Patna and also Chandigarh were excellent. Thank you very much indeed.
Thank you very much. Thank you very much. My pleasure.
Okay. So we have to select those. No, no. Master seat. You can sit here next session also. You are always share.
And I think the last 2-3 days have been quite hectic, and we are at the end of this meeting. So I'll be rather quick so that nobody is delayed and the sessions run on time. So I'm just going to present to you 2-3 very short cases, but certainly they were long for us in terms of planning and everything, because this is all structural heart cases which I'm going to show you. And this is a patient, who was 56 years old, and he presented to us with a previous history of DVR, where a mitral and aortic valve has been replaced earlier, and this time the degeneration has happened in both the mitral and the aortic valves. Now, the mitral valve was more significantly diseased, severe MS, and the aortic valve was also, kind of getting degenerated with AR and AS both. So the plan was to treat both these. So the patient was referred to surgery first. The surgeons declined because his chest was actually, his cardiac, the CT is done in all these patients. CT showed that there was no space between the sternum and the wall of the heart. So in these cases, then, we started thinking of whether we should replace both the valves together, whether one by one or maybe none. So finally we decided that yes, it is possible to let us start with the first valve. If it goes well, we'll do the second also at the same time. So we did the CT scan measurements, and as you can see here, these are the findings from the CT scan for the aortic root. The same CT aortogram which we do for a aortic valve routine replacement is okay for this one also, only the measurements change. So this was a perimount valve, as you can see here, one in the aortic position and the second in the mitral position, and the measurements showed that it is a 23 size valve, and the access sites were okay, although the access have to be different both for the mitral and aortic. For mitral it is venous, and for aortic it is femoral artery, but both the accesses were looking all right. So we did the mitral root measurements, and we saw that this was it was actually a 33 size valve actually. And you can see that the neo LVOT was assessed. The neo LVOT size was very good. So it was above 150, and generally if it is above 200, it is very good. In this case, it was 330. So, and then we measured it with two valve sizes, 27.5 and also with 29, whichever. And then also we checked whether it can take it or not. So it showed that the ample size, even we can go with a 30.5. So you can see that, first of course we have to understand how the sizing of the valve has to be done in the valve-in-valve cases. So this is the app through which it showed that the aortic valve is a 23 size valve, and the true ID is only 21. And the mitral was 29, and the true ID is only 27. So based on this, we took this decision, and you can see that first we went with the mitral because we had to, puncture the septum, and we do not want to give all full heparin and then do aortic and then reverse the heparin. So we did the mitral first, and mitral was stenotic, significantly stenotic. So we did that, and you can see that, this once we are through with this edgeless sheath, we crossed it. And this is the safari wire across this, dilated the septum, the septal dilatation, and with a 14 millimeter. So this was a 14 millimeter dilatation because the valve size was very big. And then we took this 29 size mitral valve, which was on the safari wire, not a big problem at all. And once that was done, you can see that the valve is in position, looked quite all right. Patient was very stable. So at the same time, we then crossed this aortic valve from the aortic approach on the other side, left femoral artery. And once that was done, we crossed this valve again with another valve, which was a 23 size. And you can see that we are dilating it, no interactions. And soon after that, we checked. There was no leak, no gradients. And the final result was very good. The patient was discharged the very next day. So you can see how we were able to actually deal with this complex situation, and the patient's outcome was quite nice and predictable. So the planning was one of the very important things here. Discussion with the heart team, and then of course doing the TMVR first and followed by TAVR. So this helped us. Similar, we were just relaxing. Suddenly we had another case which had a mitral valve degeneration and tricuspid valve degeneration both. And these two valves were bioprosthetic. So here you can see that the gradients had gone up in the tricuspid valve 5 millimeters, and also and also severe mitral regurgitation. And this patient was then taken up. CT scan was done to assess the new LVOT size. The size of the valves again reconfirmed on CT. And here it was a bigger size valve, 33 size, and the tricuspid valve was also a perimount valve. So both these valves were degenerating. So we decided to replace these valves, and here is the perimount 33, which is then this took a 30.5 my valve, because my valve has a size which is beyond 29. Although in the app it will show 29 only because Sapien XT only comes up to 29 size. So we took a 30.5 first septal puncture, did the dilatations, and then once the dilatations were done, we crossed this through a edgeless sheath, and of course once the wire was in across, it was not very difficult to take the valve inside, although it is a bigger valve, and then we were able to position it there and change it. So this was the first valve was the mitral, and then the second valve was which we took was a tricuspid valve. And the tricuspid, we thought we will be able to do it from the right side only, but we could not cross because it was a very tilted valve. So we went from the jugular approach because the neckline was there. So we went from the jugular approach, and then it was very easy to cross this valve. So you can see a 30.5 here through the tricuspid. And again, this patient was, since it was a venous procedure, the patient was discharged the very next day. So these two valves were replaced together. The hemodynamics was very good, and the gradients were far below the levels. And the third quick case, which I am going to show you, is a tricuspid. So then we were just, another recovery was happening, and then we had this patient who was in the liver transplant unit waiting for a transplant for 3 months. And every time he was being rejected because he had severe torrential tricuspid regurgitation. And rest everything was okay, RV functions were still okay. So we said, okay, we should try. And here we had to plan a clip. And tri-clip is still not available in India. So we then decided to go with a mitra clip in tricuspid position. And this is a mitra clip, which is a G4 clip. And we went from the left femoral approach, because in here, in contrast to mitra clip, we go from the left side and we do some adjustments in the knobs. And then we were able to hold, the first holding was happening to the septal and anterior leaflets. And then the second holding again, little bit medially. And we were able to hold these two, leaking these cusps. You can see that the second one is being captured here. And then after that, we measured the echo gradients. The gradients were quite good. The mean PG was only 2. So we were quite happy with this. And then we checked this was the TR before, and this is the TR after. So it was quite a significant improvement in tricuspid regurgitation. So basically, the patient was again discharged, and this patient underwent a liver transplant soon after that, in 2 weeks. And he is now recovering very well. So thank you very much. Just wanted to show you these 3 quick structural heart cases as to how we can handle these situations, because these are new to us, but careful planning, discussion will be able to handle these situations. Thank you very much.
Great cases, very great cases, excellent cases. Let us take panel's comments. Any comment?
Fantastic cases. I think this is a very clear demonstration about the how these procedures are being the first option today in this kind of patient. But again, as you underlined, I think planning, knowledge about the patient and surgical procedure is essential for the success in this patient. Thank you for sharing. Thank you.
Thank you.
I think first is the last case. You used the mitra clip. How effective is this? Because hardly used people, it is not available tricuspid clip. dedicated tri clip. Mitral clip, I don't know how much it is effective, because that's one question. Second thing is, when you're crossing the septum and going to the LV, you always use Agilis, I think.
Agilis.
And one of the trick is also after crossing the, doing the septal dilatation, just put the balloon into the mitral valve. Don't dilate. This just to make sure that your device is going. Sometimes it may be difficult. So that is one thing I think I wanted to add, because it makes more confident that the valve can track. Or else these two cases were fantastic. And planning, as you told, planning, that's most important things.
So as far as your question about the mitral clip in tricuspid valve, so the dedicated device is the tri-clip. But actually tri-clip is the same thing as the mitral clip with the knobs moving in different directions. So here we have to learn how to move these knobs because they are meant for mitral position. So, but there is a very, nice paper which has been already published, and various series are available where mitral clip has been used for tricuspid positions very effectively.
Sir, wonderful cases. I think you are setting the trend for multivalvular implantation, just like a multi-vessel stenting, simultaneously doing mitral, tricuspid, and aortic valves. So, do you consider coaptation distance just like a mitral valve? When you are doing the tricuspid valve, the leaflet separation, 6 to 8 mm, is it the same criteria is applicable, or?
I mean, these are slightly different here because in tricuspid valve there are 3 cusps, and in the mitral there are only 2. So here we have to measure the distance between the length of the cusps, both the anterior leaflet, posterior leaflet, and the septal leaflet. And the most important is the septal leaflet here, because unless until we catch the septal and anterior, it will only be effective with that. If you do anterior posterior, there is no effect on the reduction of tricuspid regurgitation.
Any follow-up? How long follow-up is there?
Yeah, I mean there are follow-ups now available, and these patients do well. And unless until they have bad anatomy along with that, like they have a huge RA, etc., and then it will be basically dependent on those anatomical features and RV dysfunction also.
Great case. Your time is over. So
thank you.
Thank you very much. We can invite the next Dr. George Joseph.
Good afternoon. I'll be presenting a case that we did about a month ago. And it is a patient, a 63-year-old male patient who came to us with hoarseness of voice. And his CT angiogram showed this aneurysm of the arch, which was involving pretty much the whole arch from the distal margin of the innominate to beyond the subclavian. So if we were to do a endovascular repair for this procedure, the graft would have to start in the ascending aorta. There is no landing zone beyond the innominate or the carotid to get a good seal. So we planned a total arch fenestrated repair, which we have been doing in the past. So we did some measurements and we found that the ascending aorta is 39 millimeters in diameter. So we would need a graft that is about 10-15% bigger than this, so at least 42 millimeters in diameter. And we also plan to start in the ascending 6 centimeters ahead or proximal to the innominate artery. So these are the measurements we took, and this is to show that the ascending aorta was in fact even 40 millimeters in the axial sections. So we decided we would take a 42 millimeter device, and then this is how we do the planning. We look at the superior aspect of the aorta perpendicularly, and we shave off the 3 arch vessels, and so we mark them with blue circles, and we see the distance between them, and also with respect to that red line, which is the 12 o'clock or the superior position along the arch of the aorta. And then we transpose this relationship onto a graft. And we chose the Valiant Captivia 42-42-217. So you can see how the same relationship is transposed onto the graft, and we have 6 centimeters of graft ahead of the innominate fenestration. There are a few other things to note. One is that the subclavian fenestration has a mini cuff attached to it. This is to improve the sealing because the subclavian is bang on the aneurysm. Then there is also a looped guide wire. Here's a Roadrunner 018 guide wire, which comes from the bottom of the delivery system through the graft, loops around from the carotid to the subclavian fenestration, and goes back the same way. And then we have this radiopaque marker. It's like a figure of 8, which is attached to one of the struts in the 12 o'clock position. And when we resheath this graft, we make sure that this marker is right up on the surface. And then we orient this superiorly as we are taking the delivery system in so that we know our clock position is correct. So that was the planning, but the problem was this, that his external iliac arteries were just 6 millimeters in diameter on both sides. And this system that we're going to use is a 25 French delivery system, which is 8.33 millimeters. So that would not fit in a 6 millimeter external iliac, and if you were to try and force it through, you would run the risk of avulsing that artery. Of course, there is an option here where you surgically create a conduit onto the common iliac artery, and then through that conduit you introduce the system. But over the last few years, we have seen a lot of TAVI procedures being done using a transcaval approach, and so we decided we will use the transcaval approach for this case. And then this is the CT scan showing the IVC relationship with the aorta. So there is a 14-degree angulation there between the IVC and the aorta, and essentially you have to puncture the wall of the IVC and the aorta and traverse that gap from IVC to aorta. So the point we selected should be free of calcium, so we marked that in with a red arrow. It's between 2 bits of calcium on the aorta, and it is roughly in the middle of the infrarenal abdominal aorta. So we want to be clear of the renals, we want to be clear of the aortic bifurcation, because we may have to actually put a covered stent there to close the hole that we're going to make, although that is the bailout option. Usually we use what is recommended is a plug. All right, so this is the aortogram. The aorta is reasonably free of atherosclerotic plaque, but there are those calcific lumps there, and the point we selected, you can see there's some calcium above and below it that's marked in the red arrow. So this patient had a renal artery stenosis, so the first thing we did was to fix that. We put a stent, and then this is how we do the puncture from the IVC to the aorta. So we have this is an Agilis sheath, and through that we have a CXI catheter, inside which we have a microcatheter, and inside which we have a 014 astato wire, and that's the soft tip of that wire. And we advance that wire towards the aorta, and we mark our target with a snare, and we look at it in orthogonal views. And in the lateral view, you should be aiming for the middle of that loop. So that's the view on the right side. So we don't just use force, we actually connect this system to an electrosurgery pencil, so that wire is attached to this electrosurgery pencil and on the outside, and we have a circuit established. So when we switch this on, we can very gently and accurately advance the wire, and it will burn its way through the wall of the IVC and the aorta and reach the lumen of the aorta. So this is that actual process going on. We are advancing the wire, so it is done very gently and slowly, and you have to be sure that you are reaching the target. And then on the other side, you can do a test shot and make sure that the wire is entered the lumen of the aorta. Once you're sure it's there, you close the snare loop, and then we actually push it up rather than pull it out. So as we push it up, we are feeding the wire also from the venous side, and the loop goes right up to the aortic arch, or high up in the descending aorta. And then over this wire, we advance the microcatheter and then the CXI catheter. And then once the CXI catheter is well in, we remove the wire and the microcatheter and switch over to a stiff wire. And so that's the stiff wire is in, and now we are trying to advance an Agilis sheath, a 7 French sheath, through the wall of the aorta. And you can see that you do have to use a little bit of manipulation to get through. And then subsequently we put a 14 French dilator. And then there is a theory that the pressure in the retroperitoneum is lower than the pressure in the IVC. So if you have a hole from the IVC to the aorta, the bleeding will occur into the IVC. It will not spread in the retroperitoneum. So that's the theory. We wanted to put that into a test. So we did an angiogram after making a 14 French hole, and you can see that theory is correct. So the contrast moves directly from the aorta into the IVC, and it does not spread in the retroperitoneum. So that's a remarkably fortunate quirk of physiology, because this helps us a lot, because when we are doing exchanges, we are not bleeding in the retroperitoneum. So as long as the IVC hole is patent, the blood will all just go into the IVC, and you have something like a AV fistula. So then we put a bigger sheath in, and then finally we brought the delivery system in, which was 25 French. And then we did everything else as usual. So here we have deployed the endograft in the arch, and then we have cannulated the innominate fenestration, and we have deployed, we created a wire loop from the brachial to the femoral, and over that we are deploying a fluency stent, which we are dilating with a balloon just to iron it out. Then we did the left common carotid, and then finally we did the left subclavian. So this is the left subclavian fenestration stent being balloon dilated. You can see that we have 3 wires going through the 3 fenestrations, and all 3 are exteriorized. And all these are hydrophilic O1, O35 Terumo wires. So they're not stiff wires, but you get the support because you have got control on both ends of these wires. So we have a 4 French sheath in both brachial arteries and the left carotid artery. So these 4 French sheaths don't create much trouble. At the end of the case, you just remove them and you get hemostasis. So you don't need closure devices. So here we have deployed all the 3 stents, and that's the end of the procedure. And so this was the final angiogram. You can see the aneurysm is excluded. The 3 arch vessels are flowing. The repair actually starts way down in the ascending. The free flow has actually reached the ST junction on the inner curve, and distally we are well past the aneurysm. So then we have to, what do we do with that aortocaval fistula that we have created? So it is recommended that you put a duct occluder. So through the Agilis sheath, we brought a duct occluder, which is slightly bigger than here it's, I think, a 10-8 duct occluder. But here we realized one thing, that when we were taking the delivery system of the aortic endograft out, we had failed to reunite the nose cone with the sheath. And the sheath actually reached the IVC before we realized that. So we had to pull the nose cone through, and the back end of the nose cone is not smooth. So it actually enlarged that orifice in the infrarenal aorta. And I left a wire there just to know where that orifice is. In case this whole thing falls out, I can go back in. And when we did an angiogram, you can actually see that that orifice is bigger than the plug that we're going to use. So we realized this plug is not going to work. So we went to a bailout option, which was putting a covered stent. And this is the covered stent. It's an endurant iliac limb, which is 8 centimeters, and it fitted perfectly in the infrarenal aorta. And you can see a little bit of blush of contrast through this, but that is graft porosity, which will settle down quickly. So that was the completion of the access closure. And so this is the comparison of the baseline to the end, and this would have otherwise required a surgical conduit, which is quite a procedure because the patient has to be operated on before and after, and it's quite a painful thing to have a conduit created. So this is, I think, a very exciting advance in TVAR, and which we hope to use more in the future. Thank you for your attention.
Superb case. Excellent case. Complete, actually, arch of aorta aneurysm completely repaired through this. And with that, fenestration to all the arch vessels. Superb. Excellent. Any?
Judge, very nice case. Transcaval approach has been described in many cases in TAVI cases. But I think it's not done with device for EVR, this approach. I think this is, as it described earlier in any of these cases.
Yeah, this is the standard approach. There is a review in JAC this January on how to do transcaval access by lead-early. And he recommends actually to start with a plug and see if that works. If that doesn't work, then bail out with a covered stent. But you should always have a covered stent ready as a bailout, because that's your way to go in case your plug doesn't work. If the plug works, that's great. Now, there are a few cases where they just left it open, and what happens is there is this fistula, but over time it just reduces in size and closes off. And it doesn't create too much of a hemodynamic problem. In very few cases, there is a little bit of hypotension, but patient generally remains stable even if you didn't close that rent.
Yeah, thank you.
Sir, extraordinary skills, masterly presentation.
Yes,
and I think aorta means I can see only Dr. George Joseph. No other man can match him. Really extraordinary skills. And masterly presentation, and that, see, meticulous planning, that's very important. So, patience in planning, impatience in carrying the work. So, he thoroughly, everybody should learn. See how nicely narrated about the planning of the procedure, and like a closure, we can't imagine aorta, such a big sheet going inside. Really commendable, sir. Congratulate you once again.
Absolutely.
You motivate and inspire all of us.
Thank you.
Thank you very much.
Excellent case. Master case. Never heard fenestrations before.
After the masterly work of Dr. George Joseph, luckily, one was a structural, second is an aortic. Natural, I don't know anything about these things, so it is a coronary work.
Coronary.
So only coronary I can present. This was actually a case which I have done for a workshop where the system and the facilities are not there. But I just went with the case was actually done in November 21. Young male, standing to a lady RCS circumflex done earlier, came with angina for more than 2 years, a smoker, a drug defaulter. That was the situation. This was the angiogram. Angiogram showing a complete occlusion of the LAD ostium. We actually thought we'll easily wire the vessel. Tried to take a balloon with a wire. Did not cross at all. I initially take with a normal single lumen microcatheter. Tried. There was some disease in the LMCA. The wire actually did not cross properly. Then I thought the second option is a retrograde approach. This was a retrograde approach. The wire I was trying to pass, multiple channels were there. I took the wire up. Without any difficulty, I took the wire up. But you can see that when wire enters there, it has to end into the stent. So I was rechecking, the wire is actually trying to enter inside. Once the wire enters, it is making a loop there. So I was trying to push the wire is not going there, and because a lot of angulation happening there. Then the wire is coming down. The best way to, when your wire is not going, you have to take the wire.
Can you adjust your mic? So,
when your wire is not going down, the two things you can do. Take the wire distally to LED, or the wire can be taken into a diagonal or another septal. That is what I have doing. The wire is taken into the septal, but the microcatheter is not moving at all. So the only way is actually change over to another septal artery. I tried to change another septal artery. This time also I took the second septal and again I went inside. Here the wire entered inside. You can actually see that I'm trying, the distal part is not correct, but luckily the wire went inside. I have taken the wire distally, as distal as possible, but distally it entered into another diagonal. After entering the microcatheter, I was trying to push the microcatheter. Microcatheter went inside. Then the next problem comes. After the microcatheter enters there, that I have to take a wire. The wire should go into the reverse end, not to the distal end. I was trying to take a wire. The microcatheter went inside because of the pressure I created and taken the wire into another septal down. So the microcatheter went inside. Once the microcatheter went inside, I am trying to take this wire is a cyan black. It will not cross, I know. I have taken a Gaia second wire. Is removed. This is a Gaia second wire. But the Gaia second wire, as I was thinking that Gaia second will only go to the distally, but somehow I tried to manage the Gaia second to go into the proximal part. The Gaia second wire actually gone into the proximal part. You can see that. Once the Gaia second wire gone proximally, probably some of the wire may be entered through some outside strut, which I don't know. But again, it making a curve. Once I make a curve, the only thing is if I take the microcatheter was coming down. So, but the wire I could push into the proximal part of the LED. But the entry point into the LED was actually a difficult situation. So it is not working out at all. Wire entered that part. Once the wire enters there, I have to take the microcatheter up, otherwise it will not happen. So the microcatheter was somehow not able to negotiate through the stent strut inside. Once it is not happening, the next choice is you have to take a balloon and dilate the balloon. So I decided to take a balloon. But unluckily, they gave me a 1.5 millimeter balloon, which was not even able to cross. If you can see that, the BP actually came down on that side because it is actually, I'm trying to trap it. In the negotiation, the wire came down. Once the wire came down, see the wire is bending. It is, you should actually initially that wire was a Gaia second. Now it is actually the cyan black wire that is bending down. Without blind way of bending, the wire is actually now distally is going down. Wire came down. With the microcatheter itself, I was trying to manipulate. That was not a good decision to do, but I just tried to do that. Subsequently, the microcatheter came again down. I was again trying to manipulate without even blindly I was doing that. This is actually a problem you create because we may be dissecting the vessel. Bending, I'm creating a problem. Why I actually showing this much? Because I'm actually wanted to show I create a complication there. See, this should not be done with these type of a wire. Actually, it is a UB3 wire. I was actually trying to push the wire. It is not possible. See, the wire is going there. I should not do that. I should actually take a cyan black wire again, to save the time whatever I have done like this. By this time, patient BP fall came. BP fall. There is a patient is actually struggling. I was not seeing the BP there. Then we did a check. When we did a check, we saw there is a lot of dissection inside the septal artery. Once you have a dissection in the septal artery, sometimes it will heal off by itself. But anyway, the antegrade entry is not possible. So I tried to take the fourth septal artery, which was actually having a direct connection. This actually went easily inside. So the wire actually gone. Then I shifted the wire and the microcatheter also gone inside. If you can watch very carefully, the microcatheter is coming up. So it will also gone up. The microcatheter gone up. Once the microcatheter gone up, the next is actually you have to change over to the tough wire. Microcatheter is easily going. It crossed the stent strut and then gone into the proximal part of the RCA, LAD. Once it is proximal part of the LAD, I took again a Gaia-second wire. Now the Gaia-second wire is easily crossing. I thought my work is finished, but it did not end there. Now I thought I have to take the microcatheter out into the proximal LAD part. Actually the catheter was I just keep outside because of the BP fall. Now you have to check the wire is in the proximally in the LMC or not. When I checked, the wire is actually outside the vessel. So you have to remove the wire, manipulate and take a shift to another wire. And it is actually coming through the stent strut. The ostial part is actually stent. It is not the normal vessel. So the wire I am trying to push, the wire is not entering inside. In the meantime, what really happened is the circumflex and the OM having a connection there, that actually created the problem. That is why when we are doing like these type of cases, you should have another wire into the circumflex. The wire I was trying to manipulate, wire is not going. So next is actually again a BP fall. The wire came down, there is a BP fall, the OM is actually closed. Then immediately I have to pass a wire. I'm making a lot of noise there, so I stopped the sound, that is why. Actually the wire has gone down, the wire is actually kept into the circumflex artery, balloon dilatation done. Then the patient went into bradycardia. By the time, whenever I dilated the balloon, what I did is actually, with this balloon dilatation, that actually created reverse cut. With the reverse cut, I pushed my wire into the antegrade wire into the catheter. So with the reverse cut, I pushed the catheter, because there is no BP, that is why I'm taking the wire microcatheter out. With that, my wire is actually going inside. Patient BP. Now I am dilating that part. After balloon dilatation, that time the BP is not there. When the balloon dilated, it's actually called reverse cut. So I'm taking the wire inside, the wire actually going inside. The balloon deflated, I'm taking the wire inside. Balloon inflated, wire gone inside. With this wire actually gone out of the aortic ostium, so then it is easy. You have to keep the catheter into the ostium and then withdraw the wire and get inside. So now my wire is inside. When the microcatheter is inside, I push the microcatheter. Through the microcatheter, I came down with another wire. Now it is RG3 wire. Through the RG3 wire, I took another microcatheter. By the time, again patient collapsed. I'm showing the wire coming down. Balloon dilatation. That the flow to the LED was not there. I have to dilate through that stent strut inside. I dilated. Balloon dilated. By the time there is a plaque shift or thrombus, which we don't know, the patient again in the problem. BP is not there. We have a balloon dilating. No, heart is not moving now. In between the cardiac massage, I am doing all these things. No flow. Putting a stent into the circumflex. That is a life-saving vessel with a lot of adrenaline given. Now the BP flow came down. Again balloon dilatation. No flow, cardiac massage. No flow to the circumflex. Then I give an apixaban immediately. With the cardiac massage, I have to pass the wire into the circumflex because it is actually just put a balloon stent, then do a DK crush. That was my plan. Shock, cardiac massage, all going on. With that, in between I have to pass the wire into the stent strut. I did a DK crush through that. Through the cardiac massage, I did all these 2 balloons, 2 stents, everything I had done. Balloon dilated. I'll show you the final result. I created a flow back, then a balloon dilator. I opened up the LED totally, created a flow down. This is the final shot created. Balloon dilator throughout and opened the LED. Total LED is opened up. We decided not to do anything further. This was the final result created. And actually the patient was intubated that day and next day patient was extubated. That was the story of this patient. We used, there are 2-3 points I want to just tell you. This patient actually had a chronic stable angina, LED was done. We used this many materials and patient had a cardiac massage. This was the problem. But I will tell you that these are the 3 different routes that take the wire into the side branch of distal vessel, change into a microcatheter, dilate the septal channel, anger balloon. These are the techniques can be used. No flow, we thought it is a dissection thrombus or combination. Problems in this case was an ostial CTO, angulation of the septal channel, difficulty of wire entry to LAD from the septal channel due to stent in the LAD, attempting the septal channel entry via Gaia wire not to be done, minimal lesion circumflex with a dissection of thrombus, not having a mechanical circulatory support, ostial lesion of MCA with RCA may be angiographically not significant, and not doing the imaging and not having small balloons and cutting balloon. MCS would have helped this case. Perseverance was the key to success in Indian financial setting. Most of the time, success of the complex case is actually in the hands of operator. Even in this case, it was teamwork. This case was done during a cardiac interventional workshop where 20 cardiologists were watching me. Thank you.
Great case. It's really master case. My question is, perseverance is okay, patience is okay, experience is okay, but perseverance, how much? When is the time to stop in these cases?
So actually the patient has no other way out. Basically the patient had already there is stent in the LAD, whether distal vessel is the only vessel left out. So we thought we can be coming out of that. But the LMCA disease, how much significant was not there, and putting 2 wires into the circ and OM could have done my job easier from the initial part, but at that I did not do. There are a lot of lessons I learned out of this case. That is why I'm showing this case.
Pratap is very complicated case, really did very well. Just wanted to know, when the patient had cardiac arrest and you started cardiac message, patient BP came up and all these things, that time, why you didn't put a IBP?
That is why I'm telling you, sir. It was a government hospital setup. I was doing a workshop there. So those things were not there. So I have to do something with the adrenaline subnorid support and then read the case. That was actually one of the choice. Even that is why I told MCS was not in this case. Mechanical circulatory support was not used in this case. This is why actually some of the Japanese will come and ask when seeing a complex case, what is you have an impella or IABP or something. They will not do that.
Yeah, I think when you are doing a complex case like this, retrograde and all these things, is at least you should have.
You should have an IABP backup there. Yeah, correct, sir.
I think it's a beautiful demonstration of stepwise. Every step is shown very beautifully, and you also encounter the problems, and at every step, how the problem can be solved, you demonstrated. Really beautifully demonstrated. And left main, the occlusion, is it because the subintimal dissection compromising the left circumflex? Because the you did dissection re-entry at the left main?
Basically, which I don't know, Sridhar, because we did not do an IVUS in this case, number one. Number two, the entry to the ostial LAD was very tight disease. When I passed the wire, probably I would have dissected vessel with my wire. There is no doubt about it, because initial wire entry was almost subintimal. So I could enter the wire even only with the balloon dilatation in the circumflex. That means I did a reverse cut in the LMCA. Once I do a reverse cut in the LMCA, probably I would have dissected the vessel without any support to the LAD, number one. But when I gave F6MAP, the patient came up.
Do you feel IVUS could have helped before doing the dissection?
100%.
Because previously we did one case, similar retrograde. We demonstrated OCT also from L6 to LM. It was subintimal. So when we thought it's through the true lumen only. When it dilated, suddenly L6 got closed and because subintimal entry.
Correct.
Yeah.
This is actually a tough situation when you pass the wire down, especially entry of the circ-ost LAD ostium to the LMC was very tough. It was through the stent start. That is why I have to, otherwise I usually take a cyan black to enter the externalization.
But everybody should learn. See, these are all master class presentations. Because every step they are showing very nicely, and youngsters can learn each other. Patience and the meticulous planning. Patience is not enough. The meticulous planning is very important. Before you execute, read the angiogram, study well, and how they planned so nicely, and every step is really very educated. I learned many things from your CT presentation. Thank you.
Pratap, very good case. And where did you do it? Which hospital?
In Delhi only, sir. One of the civil hospital I did.
Okay.
Actually, I go and do workshop everywhere.
You went there as a proctor.
I go everywhere to do proctorship.
You go proctoring everywhere, but you went as a proctor and you...
Some hospitals, when I do a CTO in every hospital, I tell the first sentence actually, you tell the relatives that patient can die on the table. And I will not be successful all the time. This is the message I tell. If somebody is telling not to accept a complication, please don't tell me to do a minimum CTO, that I tell.
Absolutely correct. I think very good case. So many skills required to do this case.
Sir, doing a Dicka cross in a cardiac arrest patient, do you advise?
No, I actually, no. Basically, I just wanted to pass the wire. I wanted to have a proper LMCA intervention because this patient's survival is big concern. DK crush, actually I crossed everything like that. I just put the wire, balloon dilatation, recrossed. When I take the wire back and again wire entered, luckily everything gone smooth, that is why.
Good case. Excellent.
Thank you, sir.
Thank you.
We will actually go to the last session of the day where
I think we had 3 presentations, Dr. Praveen Chand, Dr. Joseph and Dr. Pratap. All 3 cases absolutely super duper, are all masterly cases, required a proper planning and proper execution, and the skills required are very high. Lot to learn, but not to do these cases in all the labs and by everyone. You require an experienced operator to do this, who has done lot of work in this area and then can plan the complex cases like this and do a masterly presentation. This is the message that I would like to give. Thank you very much for for kind attention. Can we give big hand to all of them, please? Not close.
In the meantime, the presenters should be there. I think out of the 13, 5 already left to their houses, so only 8 cases. So we are actually giving 7 minutes plus 2 for the presentation. 7 plus 2. Can you make?
Small members. Brother, bring those members.
Gerald is not, Dagubit is not there. He is also there. So we have, Gerald, you can sit. Please. We want
Dr. Gerald Werner can join for this.
so that there is unbiased.
Ramesh Dugabati is there?
Not there.
Ramesh is not there. Actually, I will request Sudhir to come and...
Yeah, Sudhir, why don't you? Yeah, good idea. Yeah.
You can, okay.
Excellent.
One member.
And then Joseph, you could call.
Yeah, I'll go. I would like to request Dr. Jajov is not there. Dr. Praveen Chandra is there. Sir, you can come over to the dais. May I request the chairpersons to hand over the memento to all the speakers? Just stay there. And to make such a enriched academic curriculum, it's very, very difficult. I know how much struggle he faced to accommodate many speakers. So I was also forcing all the time because of the industry pressure and because of the friendship. So, but anyhow, we accommodate almost a majority of the faculty members. But to make it is very, very tough to cover extensively. There are many latest things are going on, and covering all aspects of the interventional cardiology, really tough task. That is like a 10-10, and even 1,000 CDs, selecting 350 CDs, a very tough task. But he really took that challenge, and for that task, I wanted to give him a special memento. I request everyone to give a big round of applause to Dr. Pratap Kumar.
Be 8 presenters only, not the 13. So out of the 13, Sridhar will give 3 lakhs, 2 lakhs and 1 lakh each for the 3 best presenters. Every presenter is very good, so he will be giving memento to all the people. So I think the first one is not there. We will go to the second presenter. Manoj will be presenting the first case, and you can take a 7+2. 7 minutes and then 2. We will be giving a paper. Can you just give the paper?
Marking papers and some support.
Pen is
not required, but marking support is required, and support is required.
This is not sufficient. It is 2 mark only, same thing. The printout is same.
I'll take one. Okay. So we start in numbers.
Numbers. Now we can start case number 2. No, one is not.
No, we should probably
first tell us
not to
who are
make,
present.
not to make confusion. We should start with
Okay.
1, 2, 3, 4,
Correct.
5, 6,
I will
7,
see that. You can go as number 1.
Yeah.
First presenter.
But we already have a list.
Yeah, but who are available?
No, case number 1.
Because we then get confused.
Where is the list?
Good afternoon. The first presenter is number 1.
Good afternoon, esteemed chairpersons. Delighted to be here in this August audience at the end of this exciting NIC 2023. And I'm presenting an enhanced chip PCI solutions for a failed PCI in an individual who had a stent failure, heavy residual calcium, left main bifurcation and instant restenosis. 73-year-old gentleman, industrialist, social worker with multiple risk factors, teetotaler, NSTEMI in 2015 with left dominant coronary system, calcified coronary artery disease, then multivessel CAD in circumflex, OM, LPDA, and LAD stenting was done. There was a mention that the DES in the proximal LAD was not well deployed, and he was on DAPD for 7 years without any MACE events till February 2022. Recurrence of class 3 angina, NSTEMI presentation with a normal LV function in March 2022. Angiogram was done elsewhere, showed a critical bifurcation, LM disease, instant restenosis with heavy calcification, distal left main, ostial proximal LAD, advised CABG surgery. He preferred a minimally invasive or robotic surgery or a repeat PCI, and 3 cardiothoracic surgeons were taken for CABG surgery. Did not consent once again for a CABG surgery. Went back. He wants to go back to the active life in 3 to 4 days' time. So he consented for a repeat chip PCI, understanding the scope of procedural challenges of a repeat PCI in an already failed PCI setting. So these are the baseline angiography. You could see an ostial circumflex, ostial LAD, and a significant amount of dense calcium all along the left main, extending into the LAD, which is seen in the zoomed frame, and also the mid-LAD stenosis, LPDA, and also the OM stenosis. So these are the segments involved in significant amount of calcific stenosis and the OM instant restenosis. A baseline OCT was done which showed a significant excentric calcific nodule, dense, thick in the left main, and also in the rest of the left main. There was 270% degree of arc of calcium in the LAD ostium. There was a deformed stent, underexpanded DES at the LAD ostium, and there was a calcific nodule in the proximal LAD, and the circumferential calcium of 360 degrees in the circumflex ostium. And this is the MSA of the previously underdeployed stent of 2.3 millimeter square in the LAD ostium. So chip PCI was done with an access from right radial artery, 6F EBO guide catheter, temporary pacing on standby, all-star wire in the LAD, whisper extra support guide wire in the circumflex, and then ostial circumflex and was dilated with a 2.5 NC balloon. Distal OM was prepared with the same 2.5 balloon, and then a magic touch sirolimus drug-eluting balloon was applied to the instant restenosis of the OM with a 3x25, and there was an optimal results of the instant restenosis of the distal OM instant restenosis. Subsequently, 2.5 pre-dilatation was done for the instant restenosis of the LPDA, and again a 2.5 magic touch balloon was done for the LPDA, and an optimal results was obtained for the instant restenosis of the LPDA, and this was the appropriately results after the circumflex as well as the LPDA and OM stenosis instant restenosis with the DEB PCI. And then I addressed the mid-LAD with a pre-dilatation of 2.25 into NC balloon, and then the same balloon was applied to the ostium. Because of the profile, I introduced it to the distal lesion preparation, and then the ostial LAD was also prepared with a 2.5 NC, and the drug-eluting balloon was given for 2.5 35 sirolimus magic touch to the mid-LAD, and then it was well optimally prepared. So now comes the preparation of the LM brachyfication. You could see a 3.5 12 shockwave lithotripsy was applied, and despite the 5 cycles of application, you could still see a waste remaining there, and that was a waste there after 5 cycles. The same 3 cycles of the shockwave 3.5 balloon was applied to the ostial circumflex, which was post-dilated with the OPN NC because the vessel was measuring 4 mm, and that was optimally dilated after the shockwave, the circumflex ostium. And then I took a 4x12 shockwave when the waste disappears at the LM as well as the LAD, which was a 4 mm, and more pulses will give us certainly a greater luminal gain with an appropriate modification of the dense calcification at the LM as well as ostium. And then you could see the multiple cycles were applied, and there was an appropriate preparation of the calcium. And this is the IVL application to the LM, and there was 1 cycle remaining. I got into the circumflex with a guide extension catheter, 4 mm, already opened a high-profile shockwave lithotripsy balloon, which was applied. And then you could see a well-prepared LM ostium as well as the circumflex ostium and LAD ostium stent. And then a culotte stenting was done with a 416 synergy from left main to circumflex, which was optimized, and then a 4x20 into the LM to LAD. First case was done, and then a pot was done, and then you could see an optimal results, which was well satisfying. And these are the images before and after. Very optimal results for a repeat revascularization, very complex scenario with an underexpanded stent. The post-LM PCI, these are the OCT images after 16 cycles of shockwave lithotripsy and a culotte stenting. LAD ostium MSA was 11.6 from 2.2, and the polygon of confluence, so you could see the circumflex in the figure of 8. The culotte circumflex MSA was 11.9. Culotte, post-culotte LM MSA was 12.5. So these are some of the literature's reviews of 70 patients in the coronary lithotripsy as a modality for treating underexpanded stents in a multi-center crunch registry, and Ziad Ali's intravascular lithotripsy treatment for underexpanded stent secondary to severe coronary calcification, and then the IVL Dragon registry, which was presenting 62 patients published in 2022 with intravascular lithotripsy for the treatment of stent under expansions. The analysis of all these show shockwave intravascular lithotripsy used to manage underexpanded stent IVL proved to be an effective bailout and safe option for facilitating optimal stent expansion and increasing the luminal gain. Ladies and gentlemen, enhanced PCI solutions for a failed PCI with the novel technologies like intravascular shockwave lithotripsy, multiple applications when necessary of shockwave lithotripsy along with a drug-coated balloon PCI can give a high procedural success for a repeat chip PCI solution for a previous stent failure and focal instant restenosis. Previous stent implant could buffer the sonic waves because of the metal interface and could reduce the impact of the shock on the underlying suboptimally prepared calcification. It will require additional long cycles of shockwave lithotripsy application to the select segments. Shockwave lithotripsy sometimes obviates the need for atherectomy in a previously underexpanded stent in the current scenario of technology involvement. Current advanced technologies enhance the success of chip PCI in many failed PCI scenarios, especially with increasing patient population choosing repeat PCI for a repeat revascularization. So interventional cardiologists I should say that need to be abreast with the various use of present techniques and tips of application of the novel technologies to provide the best satisfactory, successful outcome for repeat revascularization in a previously failed in-stent restenosis and also under-expanded stent, and also to match the patient's desire. Thank you for your attention.
Okay. Okay. So, Manoj, how about the option of OP and high pressure balloon? Open NC.
I think there was a significant dense calcification, and I'm not sure whether OP and NC with a stent underexpanded with an underlying unmodified thick calcium would be giving us such optimal results. And we certainly had to modify the compliance of the vessel there for doing left main PCI. So that was my thought process.
So, my question is very simple, that when you use IVL balloon and deliver your shocks, and you use OPN balloon, you go up to 50 bars. With this, how many bars up you go?
I think the shock wave is just for a moment. It applies 40 atmosphere. It's not a sustained pressure. In OP and NC, it's a sustained pressure. And the sustained pressure exerted by the IVL is just 4 atmospheres.
Okay.
Do you have access to laser in your lab? Laser. These are 2 instant severe instant restenosis. Why not lasering them first and then use the IVL to expand this unexpanded stent? Laser would have, that...
Laser? Yeah, I think laser is a consideration, but laser is unlikely to modify significantly to the extent that IVL can modify the heavy calcium. You might, there is a passage there, so you don't have to create a passage because of the laser, and the balloons could go through that, and therefore I didn't consider that as an option.
Question. How about the dual antiplatelet treatment for this patient? What did you advise to the patient, and for how long?
Since the patient presented with NSTEMI and there's multiple stents and repeat revascularization, this is about 15 months of follow-up. He's doing well, so he's still on DAPT, and now he's on 60 milligram BD of ticagrelor and aspirin. So he would need a longer period of extended period.
There's data to support if the bleeding risk is low.
Yes.
They can 2 years of dual antiplatelet is better in these patients. Thank you.
You applied IVL only to the LM bifurcation, even to the distal portion of the stent. I saw the pictures where you applied only NC followed by DCB. Am I right?
No, I think the DCB was only to the distal OM restenosis and LPDA restenosis. The proximal left main, LAD underexpanded stent, and circumflex ostium, which had a dense calcification, circumferential calcification, calcific nodule, the IVL were applied to
But there is one recent study. That is a ISAR-4. When you are doing the ISR, the distal portion always use the cutting balloon or angiosculp. The restenosis, once you apply the DEB, they compared NC versus angiosculp. The results are far, far better, almost 40% reduction in the MACE rate. So definitely I would prefer the distal portion should be treated with the angiosculp, primarily IVL. That's fine.
Thank you.
Thank you. We'll go to the next presenter, Dr. N.K. Mahesh.
Thank you, organizers, for this opportunity. This was a case I didn't expect would reach here. It's a 73-year-old lady who is a nurse working in the US as a cardiothoracic room attendant. So she refused CABG to begin with. So the chapter is closed there. This is the angio of the lady. She had a extremely dominant RCA, which she had already done. And this is the this is the left main. Left main had disease, proximal LAD had disease, ostial circumflex had disease, and all of them were heavily calcified. So my aim was to do first a rotablation, clear out the LAD, then do an IVL, open out the LAD circumflex, and then do stenting of the LAD, and then do stenting of the left main. So the planning was meticulous, the things were going well, till I found that even the microcatheter would only go up to the ostium of the LAD, it wouldn't go further. So keeping the microcatheter at the ostium of the LAD, I exchanged for the software to a rotor floppy. Okay, as you can see, the microcatheter is just not entering beyond that. So with that rotor floppy, I managed to get the rotor floppy wire in and decided to do the rotor ablation. This is a long run, just it's a 1.5 burr. It's the old rotor one which you do with the leg. A little bit of time to settle down and please wait for the rotor to start moving. It started moving, it gave me proximal, very jerky movement, very difficult movement. I was extremely cautious to just make sure that only the proximal part of the LM and the LAD was done in this run. Subsequent to that, I decided that now that proximal part has been done, I thought I'll go down into the LAD, do a run of the LAD, and then have a look at the circumflex, how that need to be tackled. So the LAD run started, it went off, it was 1.5 burr, it went off smooth, went down, I managed to reach mid-LAD, and the runs were smooth, till one eccentric run came in, and there was probably a calcified nodule in retrospect. There was a calcified nodule there, and that's where the rotor bar got stuck. So after the rotor bar got stuck, I was lucky. It was at the ostium of the circumflex, ostium of the trifurcation is where the rotor bar is now sitting. Luckily, there was just enough flow to keep her hemodynamically stable and give me some time. So there was a flow. I was relieved, at least the flow is maintained. So initially, I tried parallel wire. With the parallel wire, the attempt was to get a 1 millimeter balloon across with the parallel wire and see if I can dilate the area and come out. It didn't work. So after the balloon since didn't go through, what we did was we pulled back the rotor wire to the ostium of as far as can be pulled back. The rotor wire eventually, I know, will not come out of the bar won't come out because the rotor wire is thicker at the tip. So it is basically a mechanical extraction. So we pulled, we can see that the catheter the guide is getting bent at this stage. It's a fluoro safe, it's a long run, please bear with me. So the catheter is bent adequately, but luckily for us, it just slipped out of behind the calcific nodule, and the system came out. So once the system came out, everybody was relieved, but the problem was there is a significant dissection at the aorto-ostial junction and the distal left main. So I have no options but to put a stent and come out, otherwise she's going to crash sooner or later. The dissection was not spreading that much, so I took the liberty of going down with the balloon to the LAD. I dilated the LAD as much as I could. Then after that was done, this is the LAD dilatations. Following that, we took a 3 millimeter balloon and dilated the left main. But now we can see that the staining is becoming a little bigger. So we dilated with the 3 millimeter balloon and then took a 3x29 drug-eluting stent. No drug-eluting stent would go through that calcified left main into the LAD. So we had no options. We were thinking, then we took the IVL balloon. We took a 3x19 IVL balloon, went into I could just enter the LAD with the balloon, give half the pulses there, brought back into the left main, and then gave the rest of the pulses in the left main. So once the IVL was delivered, then I could find movement much easier. I took a balloon, we went and dilated the ostium of the circumflex. Then after doing that, we dilated the LMCA better, and then I could stent the LMCA with a 3x29 drug-eluting stent, and then post-dilated with a 4.5 for the ostium of for the LMCA part of it. This is the post-dilatation balloon. So eventually we got good flows. The dissection was sealed, and the patient was hemodynamically stable. I had told her that in case she gets angina, chest pain, come back. It was done in July 1st, 2022. Last review, yearly review, she is doing extremely well. So I've kept her on this, keeping my fingers crossed. Thank you.
I think Manoj, you escaped, but you used 6 or 7F catheter?
7F, sir.
7F. See, many times when you have a stock valve like this, what you have, and it was difficult to pull it out. And usually it will be very difficult to put a wire and balloons through the same way. Immediately what you should do is go to the other side, puncture the femoral artery, put one more guide catheter and try to cross a wire and balloon and inflate. Then it comes out, because sometimes it can be catastrophic.
Yes.
Other technique is you can cut the ear of the rota system, put a guide liner and then pull out.
So I had steps 1, 2, 3, 4, 5 in my mind, sir.
First step is when you have the stock, first is puncture the other side.
Yes, I did that because she was hemodynamically stable.
So how many runs you took of the rota?
The first run was good in the proximal. The second run went distal, and that's where I got stuck. Second run.
Okay. In second run you got. So that was polishing run, basically.
Yeah.
Okay.
Not exactly polishing. First run I only did the proximal part. The second was for the up to the mid LAD. So I was...
Because I was of the opinion that I would have stopped after the first run and I would have checked it. Because if you had a doubt of having a calcific nodule there...
I didn't have a doubt. I didn't see it.
But how did you make the diagnosis of calcific nodule?
Retrospectively, hindsight, intelligence, we went back and checked and found that in the angiogram we could
with
see.
Imaging? With imaging?
No, without imaging. Sir.
Without imaging.
Even the angio, it's very clear there's a nodule there.
That's a nodule. Okay, but I could not appreciate. I could not appreciate that.
I also didn't, sir. That's why... through the IVL balloon wouldn't have gone through.
Okay.
Okay, thank you.
Yeah, thank you.
I think we have to go for next.
We can... next is Praveen GL.
Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity.
I do tell that.
This is a story of a 59-year-old male who is hypertensive and diabetic for more than 12 years. Came to us with unstable angina and echo showing good ejection fraction. But the creatinine levels were 1.3 with an eGFR of 56.5. We proceeded with an ultra-low contrast angiography. We took only 3 projections without panning, with no magnification. We showed distal LM bifurcation lesion, Medina 111, and mid-RCA there was a thrombotic total occlusion. We initially treated the mid-RCA with 2 DUS, and we used only 50 ml of contrast, so that qualifies for a ultra-low contrast PCI. Despite this ultra-low contrast PCI and periprocedural hydration, patient developed AKE and creat went up to 1.7, and the eGFR fell down to 41.5. So we planned for a zero contrast LMC bifurcation PCI after 3 weeks. Right femoral access, having a EBU 3.5 guiding catheter. We engaged the catheter, and it was confirmed by injecting saline and looking for ECG changes and wire and deconfirmation. So we wired the LCX to OM, keeping this reference image. Then we tried to wire the LED, but it was difficult. As we can see, there are a lot of branches coming out of that point. Then with the help of LCX, I was in the LCX, we could wire into the LED. Then we wired the septal branch because it is important to skeletonize the coronaries before doing a successful zero contrast angioplasty. We kept the wire in the distal septal, and then we took the first IVS run from LED. It showed diffuse fibrofatty plaque with spotty calcification. So we decided to use a cutting balloon, and we kept on saving fluoros, cine images in between, because that will serve as the core restoration. Coming to vessel diameter, distal it was 3 millimeters. At septal branch it was 3.6. At proximal LED it was 3.2. And distal LM it was 3.18. And proximal reference diameter was 4.5. So we plan to use a 3 millimeter stent distally from the septal branch. And from the ostial LMCA up to the septal branch, we thought of using a 3.5 millimeter stent. Coming to the length of lesion, from the ostium up to the septal branch it was 36 millimeters. So we plan to use a 38 millimeter stent so as to flare the ostium of LMCA. And from the septal branch up to the distal reference diameter was 25 millimeters. So we thought of using a 28 millimeter stent for the overlap. We preloaded the LED with 2.5 NC balloon followed by a 3 millimeter cutting balloon. Then we took a IOS run from LCX. Again showed a diffuse fibrofatty plaque. We thought of taking a cutting balloon. Coming to the diameters, distally it was 3.19. The tightest point was measuring 2.62 millimeters, and proximally it was 4.06 millimeters. We thought of using a 3 millimeter stent. Coming to the lesion length, it was measuring from the ostium up to the normal segment, it was 30 millimeters, and for the crushing we took a 33 millimeter stent. Preloaded the LCX with 2.5 followed by 3 millimeter cutting balloon, and we kept the stent, LCX stent, and a 3.5 millimeter balloon in the LED. And the LCX stent was deployed, and the side branch was optimized using the stent balloon, and the first crushing was done using the same balloon, and port crush was done using a 4 millimeter balloon. Then the first recrossing was done through a non-distal strut, then side branch ostium was opened, then first kissing balloon dilatation was done using 3.5 millimeter balloons in both vessels. Then we took out the circ wire and was kept in the aorta as a marker for the ostium of the LMCA. And the stent was positioned in LM from the ostium up to the septal wire marker, and stent was deployed. Then we fired the ostium using the stent balloon. The first port was done using a 4.5 millimeter balloon. Then the second stent was deployed with a 2 millimeter overlap. Then again recrossed through a non-distal strut. Serial dilatation of the ostium with 2 followed by 3 millimeter balloon. Then sequential kissing was done with 4 millimeter balloon in LED and 3.5 in LCX. And final port was done using a 4.5 balloon. The final IOS run from LED showed distal stent edge was perfect. Middle LED was measuring 5.25. Proximal LED was 7.62 millimeter square. Proximal LMC was 11.53, and the stent was well opposed and well expanded. From LCX, I was around showed distal LCX stent edge was showing no dissection. OCL LCX was measuring 5.71 millimeter square, and there was an area of malopposition in between, which we corrected with NC balloon. This is the final result. Patient did not have any symptoms during the procedure. No ECG changes. Serial echo during and post-procedure showed no effusion. And serial creatinine values range from 1.6 to 1.7 during hospital stay, post-discharge, and at 1 month of follow-up. So a CAN has a significant impact on long-term prognosis and is independently associated with higher mortality. In patients with high risk of developing CAN, zero contrast angioplasty with IOS guidance is safe, effective, renal protective, and it improves PCR results both short and long-term. With systemic analysis, IOS can replace most of the steps in contrast injections in PCI. The only thing worse than being blind is having sight but no vision. We were blind throughout the procedure, but we were having the vision to use this great tool and to make the life of a CKD patient better. Thank you.
What is the total contrast used?
2 ml, sir. for the check injection, final injection.
So I understand the story is that the baseline creatinine was 1.3, GFR 50, and then after 50 cc, the creatinine went up so high.
Yes, sir.
That is an unusual response if there is nothing other there, because you already took care. Did you do liberal fluid substitution?
Yes, sir. Post-procedure, we were hydrating the patient.
And still you have, after 2 cc, an increase of creatinine from 1.6 to 1.7?
Yes, sir. It went up to 1.7 from 1.
Any blood loss was there? What could be the reason for?
Maybe
any other reason for any
maybe
hemorrhagic
the patient
loss?
had any hypotension during the index event. Maybe
No access bleedings, no hematomas.
No access bleedings.
So what you will do if patient will have angina? After you have stented, after you have your Hybiz, patient will start having angina. What will you do?
Then we will be forced to do check injections.
Good, nicely presented. We'll move on to the next presenter.
Next one is Dr. Dayashankar Lal Baswani.
Good evening, respected chairpersons and the attendees. So we are going to discuss about a patient which was 64 years old male, known case of hypertension, post CABG Lima to LAD, SVG to OM and SVG to RCA more than 12 years back, and after that post PTCA stent to SVG to RCA twice. Patient already presented with exertional angina with inducible ischemia and RCA territory on stress nuclear scan outside. So CAG was suggestive of instant restenosis of SVG to RCA with native RCA CTO and patent Lima to LAD and SVG to OM grafts. Patient had an attempt PTCA to RCA CTO antegradely outside and it failed. So as a bailout, POBA to SVG to RCA DES was done for symptomatic relief. But patient within 6 months of this POBA again presented with exertional symptoms. So this was his initial angiogram. Antegradely AL1 guide was used to hook the native RCA, and we can see SVG to RCA, there is a good retrogradely fill from SVG to RCA graft. MPA1 guide was used. Here we can see that there is a pseudo-aneurysm formed which was not there before the previously attempted antegrade PTCA to native RCA attempt. So initially, because of high tip load wires and failed attempted antegrade PTCA, a pseudo-aneurysm had formed, maybe because there was a subintimal hematoma and damage, and that was directly exposed to the aortic pressure, leading to a formation of a pseudo-aneurysm in this place. So initially, we first wired the proximal SA nodal branch. Here we can appreciate the aneurysm in the proximal RCA, just proximal to the CTO. And before that, we have an SA nodal branch here. So we put a workhorse wire over it with an anchoring balloon to increase the proximal side branch support. So as wiring strategy, as we all know, our first attempt is always to go antegrade first. But in view of lacking support, we had kept a very low threshold for going retrograde in this case. So the challenges in this case were there is a pseudo-aneurysm at the proximal cap. So because of which we will have reduced antegrade wire navigability, and there's a short window there. And short proximal coronary before the CTO for reverse cart. So that is why antegrade balloon for guide support can be used as a solution, and extended reverse cart with a short balloon. So what could be the wiring strategy to exclude the aneurysm? Here we have to cross a native RCA CTO as well as exclude the aneurysm from the main lumen. So strategy A, first strategy was to go antegrade dissection and re-entry. This is the side branch, this is the pseudo-aneurysm, this is a CTO segment. So to go antegrade somewhere at point A and go subintimally and enter the true lumen distal to the CTO segment somewhere at point B. That could be antegrade strategy. Or second option, if antegrade fails, second option is go retrograde. Retrograde intimal entry, but on this side of the lumen opposite to the pseudoaneurysm here, to lift the plaque here and try to exclude the pseudoaneurysm from the true lumen. Or option C, go retrograde subintimal, enter somewhere at point A, go subintimally from the wall opposite of the pseudoaneurysm, lift the flap here and to exclude the pseudoaneurysm, and then re-enter proximal to the CTO segment somewhere at point B. So after initially we saw that there is not enough support, guide support for antegrade puncture, we decided to go retrograde. We took retrograde microcatheter caravel injection to delineate the anatomy of the vessel course. And then retrograde wire escalation initially was done. Wire crossing to the distal cap with the caravel support was done, but wire here we can see is entering from the same side as that of the pseudoaneurysm here. And it is also seen from the antegrade wire marking that both the antegrade and the retrograde wires, they are both entering on the same side of the pseudoaneurysm. So after that, retrograde wire was escalated to Gaia-3 directable wire and redirected towards the opposite wall of the pseudoaneurysm to cross subintimally, and then extended reverse cart was performed. Then retrograde wire was re-entered through the true lumen proximal to the pseudoaneurysm and externalized. This caravel retrograde catheter was pushed through the CTO segment with the help of the balloon into the side branch. So from the proximal SA node branch proximal to the CTO segment, an Hybiz turn was performed to confirm the retrograde wire course. So, and wire, here we can see there is a wire and this is the pseudoaneurysm, and we can clearly see that the wire is entering from the opposite side of the pseudoaneurysm. And gradually the wire entering the true lumen, and now it is seen externalizing from the guide. So the relation of the retrograde wire to pseudoaneurysm was defined, with the wire being exactly on the opposite side of the pseudoaneurysm as we actually intended to. And from the proximal side branch Hybiz, we could also confirm the subintimal entry of the wire at the area of the pseudoaneurysm. So retrograde Gaia wire along with caravel microcatheter was externalized, and Gaia wire was then exchanged to workhorse wire and externalized into the antegrade AL1 guide with the help of a dual lumen catheter. Hybiz after predilatation. Here, after predilatation, we did with 2 mm and 3 mm balloons. This is the true lumen, this is the pseudoaneurysm, and here we can see the intimal flap which is raised against the pseudoaneurysm to exclude it. And here we can see the guide wire on the opposite side. This is the guide wire, this is the pseudoaneurysm, so on the opposite side. So then the remaining procedure was completed antegradely. We can see a good final result with distal to mid RCA stented with 3 into 38 and mid to proximal RCA stented with 3.5 into 28 des. And we can see that there is no filling to the pseudoaneurysm anymore. The pseudoaneurysm has been excluded from the true lumen. So this is the final Hybiz, distal stent edge with good apposition and no dissection with areas of 6. This is the proximal stent edge with good apposition and no dissection with the proximal areas of more than 8 mm square, and pseudoaneurysm excluded from the true lumen as evident from the bright speckling compared to the true lumen. So learning points from this case are that injudicious use of high tip load CTO wires can lead to pseudoaneurysm when the space is directly connected to the aortic pressure, which is common in proximal CTOs. And in cases like this, wiring strategy is impacted by the pseudoaneurysm location. Plaque flap lift and shift can be done either retrograde or antegrade techniques. Thank you.
I think that SPG graft was working, isn't it? That SPG graft to the right coronary was working.
So they had done POBA. After that, also patient had exertional symptoms and there was still inducible ischemia on stress nuclear scan. This is after 6 months of the initial POBA done, sir.
POBA to what?
POBA to SVG to RCA stent was done, sir. Because they had failed native RCA CTO PCI.
And patient still had chest pain, that is why you did it. And it was inducible in the RCA territory.
Yes, sir.
And this pseudo-aneurysm was not appreciated well in the angio. Intravascular ultrasound showed, but I think angiographically we couldn't appreciate much.
So what do you mean by pseudo-aneurysm in this setting? What happened in the first procedure which led to pseudo-aneurysm? It's just a dissection. It's like a subintimal space. And when you take an angiogram, you can see a dissection. It's just a deep dissection, and the dye staining and dye hanging around. It's like a big medial hematoma and subintimal space, and the wire was not distally. So that is what pseudoaneurysm is. So I know you were lucky to go before the pseudoaneurysm, but I don't think you can predict retrograde wire entries. It was a straightforward, very well done reverse cart procedure. And once you do reverse cart, then all these subintimal spaces, they get excluded by the stent anyway. I don't know what Gerard thinks about it.
But really showed a very nice demonstration of a big pseudoaneurysm just at the site of the very critical stenosis, tight stenosis. And definitely when the aneurysm is there, when you put the wire, most of the time it tends to coil. Only thing Hybiz helps in redirecting the wire. So without Hybiz guidance, but nicely demonstrated, because you can see very clearly aneurysm, and that's other side very tight narrowing of the CTO segment redirecting. And anterior also, suppose if you are doing the balloon, Hybiz guided entry also you can try in such cases. But I think support is not there. Support is not there. That's all.
We'll go to the next case. Dr. Vineet Shankla.
Good afternoon, everybody. First of all, I'd like to thank NIC organizers and judges for selecting this case for this session. So mine is not very exotic interventional case. It is basically how to assess the side branch, so-called optical side branch pinching in a provisional stent strategy. So how should we react for this pinching? So mine is a 52 years old gentleman, and in fact he came with acute enterovolumi cardiogenic shock, and he was in cardiorespiratory arrest with ventricular arrhythmias. So he was intubated, and initially thrombosection was done, and he was put on IBP, and then he was shifted to coronary care unit, and this procedure was done after 48 hours. So he was on GP2B, and then he was taken for the procedure again. And this was the angio on the repeat procedure after 48 hours. So patient was on IBP, and this is the angio, which shows a significant distal LM, which is extending the lesion into proximal mid-LAD, and a circumflex, which is dominant circumflex. The RC was non-dominant. So this was the angio, and so we decided we'll go with image-guided LMCA to LAD stenting, and we did initially a 2 millimeter balloon dilatation, and we did a OCT, and so this was the OCT, the pullback of the OCT. The LAD was, it was mainly a fibrolipidic plaque, and distal LAD was almost around 3. The proximal LAD was around 3.5. The LM was around 4, and the tightest lesion was around 1.5 millimeter. It was a fibrolipidic plaque with some amount of white thrombus here. So initially we took a distal stent, and the stent was around 3 into 38 Zions Alpine Des. So this was the distal stent, and the proximal stent was 3.5 into 23. That was from ostial LMCA to LAD, overlapping with the distal stent. And this is the angio when we took after implanting these two stents, starting from LM to LAD. And this is the circumflex, ostial circumflex. It looks optically definitely pinched. So how do we react now? Shall we go ahead and convert into dual stent strategy, or we should do something for this ostial, so-called ostial circumflex pinching? So we decided the patient was hemodynamically stable by the time he was fully conscious, and there was no hemodynamic compromise with this ostial LCX pinching. So we decided we'll initially assess this LCX, but before that we just post-dilated the distal LAD stent with 3 mm NC, and the proximal LAD stent with 3.5 NC. And we did a pot, and then we we put a physiology wire. We did a RFR, and this was the RFR. It was, in fact, non-significant. The RFR was 0.96. But the contrast FFR was also done. That was around 0.94. The limit, the cutoff limit is 0.83 for contrast FFR. And then we did a pullback OCT from LAD to LM and also from LCX also. So the stent was, there was minor malapposition. There was no stent edge problems. There was no geographic miss. So there was some minor malapposition. Otherwise, the stent was okay. But definitely there was some hanging struts in the front of the LCX ostium, which was seen in the pullback from the LAD. And since this was a dominant circumflex, and visually definitely it was looking significant. So what we decided that we opened the strut with 2 mm balloon, and then we did a kissing balloon with 3 in circumflex and 3.5 in LAD. And we did a pot again. And then we checked the OCT pullback from the LAD as well as circumflex. So this was the OCT pullback. And this was the 3D navigation mode, as well as we also saw the 3D reconstruction. And on this 3D navigation and fly-through mode, we could see that there was no struts hanging on the LCX ostium. And in fact, so this was the post-kissing balloon dilatation and pot. After pot, we can see that the L6 carina was free, and there was the L6 carina ostium was free of the struts, and we can see roughly a figure of 8 in front of at the position of the carina. And then we pull back, we did a OCT pull back from the circumflex also, and we can see that the L6 ostium, we in fact measured the L6 ostium, it was around 5.5 to 6 millimeters square MSA at the ostium of the circumflex, and there was no significant. There was definitely some disease after the ostial circumflex, which was around 2.64 MSA. But since it was physiologically insignificant, we decided we'll not go forward with any of the complex strategies. And patient was hemodynamically stable, so we just left it. And this was the ostium of the circumflex seen on this 3D fly-through mode as well as 3D navigation mode, where you can see the ostium of the circumflex having a good ostial MSA without a strut hanging in front of the ostial LCX. So this was the final picture. Definitely the ostial circumflex is looking better as what it was seen before. And this is the point we just stopped the procedure, and the patient was hemodynamically stable. He was shifted to CCU. So to conclude, in the provisional stent strategy, the side branch pinching, the so-called visual optical side branch pinching, it appears to be significant, but it could be because of shadow of the main branch stent. And whenever there is absence of TIMI3 flow, or whenever there is absence of dissection, we should always assess this, these so-called optically side branch pinched with a physiology and probably a combination of imaging. If this would have been a normal side branch, we would have just left it alone. We would have not dilated or did a kissing balloon. But since this was a dominant circumflex, we went ahead and did a side branch strut opening followed by a kissing balloon dilatation. The new modalities like imaging, especially the OCT-based imaging modalities like 3D reconstruction, 3D navigation, and fly-through mode are very, very useful, especially when we are doing a bifurcation stenting, or we want to see the side branch MSAs and our wire, whether it's passed from the proximal or distal stents. It's a very useful advanced techniques in OCT to assess, especially when we are doing a complex bifurcation or bifurcation techniques.
Actually,
thank you very much.
If you see the first run of the OCT, the left main, that is not minor. It's a major malapposition. It is more than 30% of the, if you take the area, even if you measure the distance between the stent struts and the wall, it will be more than 300 microns. If you leave that malapposition, what happens? When you do the next time procedure, or if you are passing the wires, most of the time wire can go subliminally. That lead to LSD. And this can lead to shortening of the stent. Once the shortening of the stent takes place, it's very, very difficult to pass the wires. You will have a very tough situation. That's the reason before doing anything, if you see that malapposition, good apposition with good size pot balloon is mandatory. There's a very significant malapposition. We cannot leave that kind of malapposition.
So we had done pot, in fact, before even passing the wire.
What I mean to say, the terminology, we should not label it as a minor. It's a major malapposition.
Okay, fine. Yeah, exactly. But we had done pots, sir. We had done pots 2 times. Sir. I agree with you, sir.
What is the size of this circumflex, you think, in the proximal part? It's quite big circumflex.
Yeah, it's a big circumflex. But yes.
And you dilated with a 2 millimeter balloon.
Initially, just opening the strut with 2
millimeter
followed by a kissing
balloon.
balloon.
And OCT showed that stent strut is totally opposed. Explain to me how it happened.
So initially we opened the strut.
You used larger balloon for kissing.
Yes, we do.
What is the balloon for kissing?
So it was 3 mm in circumflex and we used 3.5 in LED.
Yeah, still it is undersized.
Yes, exactly.
But you don't want to do one-to-one. Obviously, I think because the stents, you can't see the left circumflex ostium is about 5 millimeter, 4 or 5 millimeters. So, but there is a good opening. So I think a 3 millimeter balloon you used.
3 millimeter balloon or 2?
For kissing we did 3. Kissing we did 3 in circumflex and 3.5 in LED.
That explains it.
Yeah, yes, sir. But initially opening the struts, we initially used 2 mm.
Thank you. Recent data suggests when you do the kissing of the side branch with a significant block, always go with the DEB. That is a side branch, long lesions, diffuse lesions. These ISL is the ideal indications.
We'll call
the consisted.
Yes, sir.
Thank you. We'll go
Thank
to
you
the
very much.
next presenter, Dr. Alluri Ashok Raju.
Good afternoon, everyone. I am Dr. Ashok from Madras Medical Mission Center for Medical Excellence. I will be presenting my percutaneous pulmonary valve implantation in dysfunctional pyramidal RVOTs. Percutaneous pulmonary valve implantation is a landmark structural interventional advancement in the past decades, which had even started before Alien Krieber had first started TAVI, but it had a very slow takeoff. It is a well-established non-surgical alternative for correcting dysfunctional native RVOTs and conduits. Currently, we have only 2 FDA-approved valves. One is a Melody Medtronic valve and Edwards Sapien valves. And both these valves have individual limitations and do not cover the entire population. The limitations of these valves are, with a great due respect, we need to know them, limited available surgeries, large delivery is not suitable for short landing zones, and they have a huge economic burden on our Indian population, making them as unreached source grave for majority of the Indian population. We at TRIPLM have used my valve in aortic position for TAVI, which is very well established, and we have found that it has very good technical advantages such as larger size being 32, volume dependent expansion, short landing zones, intermittent size is available compared with the 14 fin sheath, and it has a very good hybrid cell design. Hence, we for the first time innovatively implanted this my valve at pulmonary position with 100% success. There are huge limitations. Our experience of PPA, we have done so over 50 cases. For the first time, we did Melody in 2017. Following that, we had done around 50 cases, out of which 10 were Melody, 15 were my valve, 25 were VNSP. Coming to the background of the RVOT morphology, it is a key determinant for device suitability in the patients for whom we are planning PPVA. And there are 5 types of morphologies that are being introduced, which is the type 2, which is actually cylindrical, is ideal for a PPVI as described by the Western world. But unfortunately, the most common, which is the pyramidal RVOT in a trough transallar patch, which constitutes more than 50%, were not being amenable for pyramidal RVOT PPVIs, that is pulmonary valve implantations. Hence, pyramidal RVOT, which is most common RVOT morphology, deemed unsuitable for PPVI and was written that they should be sent for surgery by the Western world. And hence, we innovatively present 2 cases of challenging successful MyValve PPVIs in pyramidal RVOTs in view of high risk redo cardiac surgery and the surgeon being scared that if these patients are taken for a surgery, it's very difficult for them to come out of the pump, and also even the patients are not willing for a redo cardiac surgery. This is the story of the first patient where we have for the first time tried. She is actually a 30-year-old female, trough and transallar patch at 4 years of age. Subsequently, she came with severe RV dysfunction and cardiac MRI was done, which was showing severe PR. Subsequently, we did a CT scan, which was showing severe RPA origin stenosis with pyramidal RVO tract. Although this is in pyramidal character in its morphology, the pyramidal RVOT is not aneurysmal. So we thought we can be able to place a MyValve in this patient. And this patient is also having an original stenosis of LPA. And subsequently, this patient was planned for a my valve implantation. This is the corresponding floor anatomy which was showing ostial stenosis of the LPA. We planned for an andraxle stent from the MPA to LPA and dilated with a 25x4 ZMET balloon and proximally also dilated with a larger balloon, and subsequently we could get a proximal RVOT of 28 mm. Hence, we decided for a 29 mm my valve by upsizing to around 1 mm. And subsequently, on a bright day, we have taken this case, and this is the first angio of implantation of this my valve. What we see is alarming, and the entire lab was in silence because the RPA got completely jailed with no absolute flow in the RPA. And subsequently, we took over the challenge of this case because this open cell of the distal part of the valve was originally used for bailing out of a jailed coronary in a TAVI. So we used the same property and we entered through the distal open skirt of this valve and primarily opened up. And following this, there is a good amount of flows both in LPA and RPA with well-functioning valve. And this patient we learned a lot from this patient, and we learned that a jailed RPA can be bailed successfully following a pulmonary valve implantation in pyramidal RVOT. Subsequently, this is a second patient. This is also a 29-year-old male patient with a top transanular patch with free severe PR. CT scan was showing pyramidal RVOT with confluent branch pulmonary stenosis, aneurysmally dilated in proximal my valve, and the surgeon was not ready to take this patient for a surgical pulmonary valve implantation because of the severe RV dysfunction. Hence, we tried and planned for any possibility of my valve. This is a 3D reconstruction. Here we see the aneurysmally dilated proximal MPA with origin stenosis of the LPA, and there is a very, very theoretical plausibility of a short landing zone proximal to the brief irrigation point. So, going into the metrics and detailed analysis of the CT scan, when we saw it, there is a very small hope of pre-bifurcation short segment where we can land the proximal skirt of the my valve. And we went to the technical team, we found that the proximal closed cell of the my valve is only 1 centimeter. And in case, if there is a possibility, if there is a 1 centimeter landing zone, there is a possibility that we will be able to place this my valve. And subsequently, going into detailed CT measurements, and at a centimeter of 1 centimeter, proximal to the brief bifurcation point, the diameter is 26 mm. Hence, we concluded to take this patient if possible for a my valve. Subsequently, we kept the measurements on a schematic description, and we saw that the origin of the LPA is only 10 mm, and the pre-bifurcation point around 10 mm below the pre-bifurcation is a 26 mm, and we decided to keep the PET skirt exactly at this 10 mm, and we anticipated from the previous case that in case if the RPA gets jailed out, we will reopen through the distal open cell of the my valve and redilate it. And subsequently, we took over the case on a bright day, and we have passed, this is the pyramidal RVOT with origin stenosis of LPA. We passed at 18 French sheath with a 59 mm Jeffir stent on a 22x5 ZMET balloon, and we dilated the stent. And subsequently, because of the waste formation, we post-dilated with a tougher balloon 22x6 Atlas Gold, and finally the proximal part of the stent was flared with a reliant balloon for forming an adequate amount of landing zone. However, there is aneurysmally dilated main pulmonary artery, and the proximal end of the stent is just floating in the aneurysmally dilated main pulmonary artery. So, hence we decided to take a 27.5 my valve, but however, there is a significant challenge because valve faces the challenge of stent edge and the valve is not getting tracked, and subsequently we use the phenomena of removing of the guide wire vias, where the minute we remove the guide wire, the valve will get aligned to the MPA and we will be pushing. So pulling, pushing is the maneuver, and finally we are able to track the valve, and we have placed the proximal 1 centimeter of the my valve exactly at the pre-bifurcation point, and we decided to deploy it there. And finally, we took a chance and deployed the my valve, and subsequently there is a significant RPA jailing with diminutive folds, and we entered and through the open cell and again dilated with a 10x4 Mustang, after which there is a good amount of flows in the RPA, and subsequently we redilated again with a 12x4 Mustang, and finally this is the well-opened distal open cell of the my valve, and this is the last fluoro. And summarizing this patient is actually a my valve. This is actually pyramidal RVOT. We've stented from MPA to LPA and kept the my valve. Subsequently, because of the jailing of the RPA, we redilated the distal open cell of the my valve, following which we are able to get good adequate amount of pulsatile flows in both LPA and RPA, and we completed the procedure. Take home message: RVOT morphology is a major determinant of device suitability. Comprehensive imaging and careful planning is the key for success. My-wall, pulmonary wall implantation can be even done in pyramidal outflow tract, and jailing of the branch pulmonary artery is an anticipated complication and need to be tackled very well. And my-wall is even suitable when planned properly in a pyramidal RVOT in selected patients. And this is the first ever indigenous idea with an indigenous valve in our place, that is at Madras Medical Mission. It includes a huge amount of team discussions and execution by the entire team. I thank my teacher and the entire team of Madras Medical Mission. My teacher, Sivakumar sir, is the head of this entire unit, and he was the key brain behind this entire procedure. This has never been reported or even thought of neither in India or in the Western world. Thank you.
Extraordinary case, very well presented, and the planning also, meticulous planning. But have you observed any time outside, like dilating the stent
Actually,
studs,
sir,
any distortion of the valve? Have you seen?
Sir, actually, this question was raised by many of the people that the once we dilate the open cell of the my-wall, the wall gets distorted.
Yeah.
But in this case, we have no other chance.
No other option.
No other option, because they don't want to take for surgery, and patient is having severe RO dysfunction. We have no other option than to take a chance.
With the PA pressures, any residual gradient
No, sir,
across the MPA?
there is no absolute gradients. But actually, at the end, when we they are all under our regular follow-up for around 1 year. Both of them are doing well. When we did a lung scan, we had found that there is 30% flow in the right and 70% flow in the perfusion scan in the left. Actually, that is accepted.
That's good. Really wonderful case. Very nicely planned.
Thank you, sir.
I have one naive question from a coronary person. Why? Because the right is the bigger territory. Why is the valve positioned towards the left? Is it not possible to go to the right?
Yes, sir. Actually, there is the origin stenosis of the LPA, sir. In case if we stented from the MPA to the LPA, soon after stenting, it became aligned with the LPA. So actually, originally the origin of the RPA is very roomy, but after stenting and keeping the stent, and the RPA got narrowed and jailed. That is the reason for, yes, sir. It got completely altered after placing the valve. Thank you, sir.
Can we go to the next presentation, Rajiv Bharadwaj?
My patient was 70 years male, diabetic, hypertensive. In January 2014, he presented with complete heart block and dual chamber pacemaker was given. He came in April 2017, presented with syncope, and we found that he had ventricular lead fracture. New ventricular lead was implanted. In April 2019, during routine programming, he developed syncope. And when we programmed, we found that lead resistance was more than 3,000. Again found to have fracture of the new ventricular lead. He was put on TPI and planned for lead extraction and new ventricular lead implantation. So venography shows that there is total collaboration of right subclavian vein. So for extraction of the leads, we got the surgical team standby because it can cause complications and we have to be done urgent surgery. You can see there are two ventricular leads. One is tined lead and other is screw-in lead. So initially started, we cut the lead. Initially, all the leads have to be straightened and the tissue has to be removed from them and pocket has to be prepared. So we straightened it. It took almost 1.5 hours to prepare the leads. Then we got the locking device. So this is the locking device. We started with screw-in lead after unscrewing the lead. We are trying to extract the lead with this locking device, but as we are pulling the ventricle is also being pulled. So we tried many times, but we are not successful. So we are trying to extract the other ventricle lead with the locking device now. Lead could not be pulled beyond right atrium. So this lead with the locking device could be pulled up to the right atrium, but not beyond that. And during this procedure, while trying hard to pull it, the sleeve of the lead came out. And now the sleeve was out, and when we started pulling it, the wire started unfolding. So we went back to screwing lead. Now we took the tight rail cutting device. It was very difficult to push in the initial part at the ostium. And as there was difficulty, as we are pushing this device, cutting device, the atrial lead, which was also screwing, it was being also pushed. And we are pulling it back, and you can see that when we are pushing it, sometimes the temporary pacing lead was coming out or moving, and patient was having asystole. So we had to wait and then restart again. Ultimately, cutting device could be pushed up to the tip of the lead. And then successful removal of the screwing lead could be done. Then we went to the atrial lead. Locking device was taken. So this lead could come out only with the locking device. Now we are left with the lead, ventricle lead, which is in the RA or in the subclavian vein, and its sleeve has come out. Now we have we thought how to remove this lead, whether send it to the surgeons or do it. Then we did femoral vein puncture, and GR caster was pushed in, and we went up to the SVC. Then we put a snare through the GR caster, and we snared this lead through the IVC into the femoral vein. This is the cutting device, and this is the locking device. And you can see the amount of the tissue on the ventricle lead when it came from the subclavian vein. Amount of the tissue on the atrial lead. And these are all the three leads. One is which had been snared, and these two other leads. Final result, all three leads could be extracted successfully. Pocket closed. Next day, permanent pacemaker implantation was done from the left side. So, take home message. Too many leads in subclavian vein can cause venous occlusion. Lead extraction is a challenging procedure with inherent complications, and surgeon has to be standby. You may have to resort to various techniques, including locking device, cutting device, laser extraction, and nowadays IVL is also being used for this. In some cases, snaring may have to be done due to the broken leaf sleeves. Thank you.
I think you use a cutting device here.
Yeah.
And not laser. How do you decide this?
At that time, laser was not available with us. So, cutting device, laser is also some costly. Cutting device, initially we start with locking device. In few cases, we were successful just with the locking device. But here, because it was an old case, around 6-7 years old, there was too much fibrosis, subclavian was totally occluded. So locking device worked in one lead, but in the other lead it didn't work. So we had to use cutting device.
Oh, which one is more safe and effective among the three, like a laser or?
I think the locking device is safer, but laser is also safe, and cutting device is most dangerous. So you have to be very cautious in using the cutting device.
And did you have your surgeons at standby for this procedure?
Sure. There was no option. they were sitting in the cath lab because we were using the cutting device.
Very good. So I think these type of cases, obviously surgery should be standby,
Yes,
and you can have quite serious complications sometime. Thank you.
We will go to the last presentation of the day. Logesh MR will be coming.
Good afternoon, everyone. Today I'm going to present a case of residual type A aortic dissection. Our patient is a 49-year-old male, is a known hypertensive, diagnosed to have type A aortic dissection in 2010, for which he underwent surgical replacement of proximal ascending aorta. He was doing it for 10 years, and then he was investigated recently for persistent cough and left-sided severe chest pain. On evaluation, he was found to have aneurysmal enlargement of false lumen with features of contained rupture into the left pleural cavity. His baseline creatinine was 2.8 when he presented to us. This is a CT angiogram of our patient. So this is the ascending aortic surgical graft. We can see here the surgical graft was very short and it had a sharp kink to it. And this is the large true-false communication which was seen in the ascending aorta just distal to the surgical graft. And this is the true lumen. We can see that the true lumen is extremely squashed anteroposteriorly by this aneurysmal false lumen. This aortic dissection was extending up till the iliac bifurcation, and luckily all the three arch vessels were coming from the true lumen. And this is the axial cuts where we can see that this is the true lumen which was extremely squashed by the false lumen all around, and the size of the false lumen was quite large, was measuring 10 centimeters in diameter. And this is the contained rupture into the left pleural cavity. Citing various reasons, surgery was deferred for our patient at multiple centers, and he was referred to us for possibility of an endovascular repair. We had multiple challenges in this case. We can see the left main bronchus was compressed significantly, and we anticipated a difficulty in weaning him from the ventilator post-procedure. The second challenge was we saw that the true-false communication was in the ascending aorta, and to have a proper seal, our repair has to start as close as possible to the sinotubular junction. And we can also see that there is a sharp kink here in the surgical graft. Because of the sharp kink, we were unsure about the seal we would get at the end of the procedure. The third challenge was, we can see here, so this is the arch, and the true lumen was completely squashed here by the false lumen, and the true lumen is very narrow. Our fenestrated endograft has to come through this narrow true lumen. Planning in this case, it's going to be extremely challenging, and we had to be picture perfect to land a endograft. The last challenge was high baseline creatinine, 2.8. Contrast volume has to be as low as possible during the case. With all these challenges, we went ahead, we planned the case, we drew the 12 o'clock line, we transposed the plan onto the endograft, we took a Valiant Captivia 38-38-200, 3 circular fenestrations were made for 3 arch vessels. The innominate fenestration was 63 millimeters from the top end of the endograft, and this figure of 8 radiopaque markers were fixed to the superior aspect of the endograft, which marked the superior aspect of the endograft, and also gave us the rotational orientation for the endograft deployment. And this is the pre-angiogram, which was similar to what we saw on the CT. Then we marked the left carotid with a carotid femoral wire loop, and this wire loop gave us the axial orientation for the endograft deployment. RV pacing setup was done. Curved Lendequist wire was placed in the LV, and here comes the fenestrated endograft. With the help of this figure of 8 and carotid femoral wire loop, the axial as well as the rotational orientation of the fenestrations were confirmed. After confirming the position of the fenestrations, we set the pacing on, and the fenestrated endograft was deployed. The correct landing of the fenestrations were evidenced by systemic pressures, which we recorded from the right brachial as well as left carotid sheaths. We went ahead, we deployed the second endograft up till the lower DTA, following which we stented all the 3 arch branches through their respective fenestrations with self-expanding stents as well as with the bare metal stents. This is the result we got. After stenting, all the 3 arch vessels were flowing well. endograft expanded well, and we can see here there is a faint contrast opacification outside the endograft along the inner curve of the aortic arch, which we thought it could either be a type 1 endoleak or a type 4 endoleak due to graft porosity. And the middle picture is the DT angiogram, where we can see still their false lumen was filling from below because of multiple true-false communication in the abdominal aorta, and the pressure inside the false lumen was systemic. Hence, we decided to seal the false lumen filling with a candy plug. We don't have ready-made candy plugs in our country, hence we had to prepare our own candy plug. So we took a 3877 Zenith graft, we partially deployed it on the table, we constrained the middle part to 14 millimeters with 3 2-prolin ties. We resheathed it back, and then we deployed in the false lumen. The center part of the endograft was sealed with a AVP2 18 millimeter plug. Patient was extubated, he was shifted to ICU, and he was discharged on 8th postoperative day. We called him for an early follow-up. CT angiogram was done at 1 month, which showed type 1A endoleak. The endoleak was probably arising from the overlap segment of the surgical as well as our endograft. Because of the sharp kink in the surgical graft here, our endograft did not oppose well to the surgical graft, and we had this type 1A endoleak. Hence, we decided to flatten out this kink with a new strategy. Patient was posted for second procedure, left femoral axis was taken, and from the left femoral axis, we brought in a long 14 French 75 centimeter sheath, and it was placed in the ascending aorta. So there is this covered stent called Andromet. We took a 48 mm stent, we crimped it on a 32 mm Andra balloon, and then we brought the stent through the sheath. What happens next? Once the stent reaches this point, we are not able to track it further because of all these bends in the arch of aorta. Then we had to change our strategy. We took a percutaneous left axillary axis approach. From the left axillary axis, we brought in a 14 French 30 centimeter sheath. We can see the course of the sheath is little different from the course of the previous sheath. Through this, we were able to successfully deploy the Andromet stent. What happens next? The Andra balloon got stuck in the ascending aorta. This is a very bulky balloon, and it lost its profile post-deployment. When we are trying to retrieve it, we can see here, so it was coming and touching the carotid stent, and it was trying to dislodge the carotid stent. Hence, we decided to snare it out from the femoral approach. So we brought in a snare from the left femoral axis. We caught hold of the proximal end of the balloon. We slowly snared it into the descending thoracic aorta. Then we cut the shaft of the balloon, and then we snare it out from the left femoral sheath. Then we got this final result. We can see here, this is the Andromet stent, which has flattened out the kink in the surgical graft and no endoleak anymore. The left axillary axis was closed safely with a fluency covered stent. Our patient was doing extremely well. He came for follow-up at 1 year. We can see all the 3 arch vessels were flowing really well, and the thoracic part of the false lumen was completely excluded by our repair. There is still residual dissection in the abdominal part, which did not increase in size. Hence, we decided to keep him under follow-up. This is the false lumen, which is completely thrombosed, and this is the candy plug, which is in situ. Coming to the learning points from our case, residual type A dissections can be successfully treated by endovascular approach. Short kinked ascending aortic surgical grafts pose a challenge to arch TIVAR. Surgeons should be advised to replace as much of the ascending aorta as possible during the initial surgery and provide a landing zone for future arch TIVAR. This is the first case report of total arch fenestrated TIVAR in a short kinked ascending aortic surgical graft. Thank you.
Excellent case. First time I saw TIVAR in dissection, particularly surgical rejection. Surgically, it was not taken into consideration. Good case, very good case.
Thanks, sir.
Very nice case. Tell me how you are sure that fenestration is at the opening of the vessels.
So that is primarily from our planning, sir. We have a planning system. We study the CT properly, and then we go to the superior aspect of the CT. Once again, sir, I can show you. So, can you just display this image, please? So this is how, sir. So we go to the superior aspect. We draw a 12 o'clock line like this. So in the true lumen, we drew the 12 o'clock line. And we know that this is the 12 o'clock line. And then we cut with the radiant diacom, we cut the arteries. And then we take the center point. And then we mark a triangular relationship. And then we measure the distances. And then we transpose the same onto an endograph.
All this is planned on CT images?
Based on the CT, we plan it. And then we transpose it onto an endograft.
Okay. Excellent.
You get these, the fenestrations made by the stent manufacturers, or you do it yourself?
No, sir. This is physician modified. We do it on table.
Because now you can get a tailor-made where they involve 3D.
Yes, which takes 3 to 4 months.
It takes a long time, yeah.
Yeah, 3 to 4 months to get all those things.
Yeah.
Excellent case. Thank you very much.
Thanks, sir. Thanks.
In the meantime, I will request Dr. Sridhar Kasturi to felicitate all the 5 here. And please, I will request Wakar from the GIS also come in session and he'll facilitate all the 6. By the time, we will be coming out with the result. Yes, it is now the for only Sridhar. He did not visualize 4 days of scientific feast. I should thank all the people to come over here from different parts of the country. We could get people from Jammu and Kashmir, from the Srinagar people came, and at the same time people came from Guwahati. And I don't know anybody came from Kanyakumari. Definitely people came from Trivandrum. So all parts of the country was covered. From the west, from the east, from the north, and from the south. And we got people from other neighboring countries, definitely from Maldives, Nepal, and Bangladesh. We got many people, and we got this time we had an association with the GIS. It's represented by Wakar, is standing here, and we have an association with the Sky. You know that today morning session was that, and it was an excellent disposition of this. 1,008 CDs came. I could select 350 only. 90% of the CDs was presented, and from each division, so out of the 13 divisions, we selected 1 each. There are some of the situations I was in a real trouble situation, equal mark, how to select. That discretion actually taken by me, selecting 1 out of that. And it was a tight situation, 21 mark in 3 people, how to select 1. Some of the time I took a coin and then taken 1. That also happened in this session. So all the 13, you should not think that there were another 7 or 8 people missed only because of the coin and because of Pratap. So out of the 13, 8 people only could attend because they took the flight and gone away. So definitely I should thank all the people, including the industry. They were totally cooperative. Your attendance and your presence in this meeting was excellent. And your contribution made this conference wonderful. And I should thank all the people and nevertheless, actually the organizing secretary. He did a wonderful job. Yesterday evening program, everything. Actually, from the beginning to the end, he did a wonderful job. I don't know, actually, I finished my second year of NIC scientific chairman position. I'll be having one more session in the last December 2023 along with Dr. P.C. Rath. Some help and all may be required. How much the contribution I will be doing in that NIC CSI, in the CSI part of the meeting in December, I don't know. And this will be I should thank everybody, and I should thank, that is the only thing I can tell. I could do these things, and with the luck, with your participation, with everything, I should thank my wife tolerating for me for the last 45 days of heavy work for creating the scientific agenda. That's what. And Sridhar would have done more than that. Thank you all, and we will come back with the prizes. 1 minute. Let me call Sridhar to tell some words.
Sridhar,
May I request all presenters to come over the dais to take the mementos. I think all are winners. All presentations are praiseworthy, definitely worth watching. I think, but the only thing is we have 3 presentations, so we have to choose 3 winners. But I feel it's the opinion of every judge. All 12 presents are awesome, definitely praiseworthy. Please come over onto the dais to receive the mementos, and subsequently we'll announce 3 winners.
Wonderful job done by Dr. Pratap Kumar and Dr. Sridhar Kasturi. Please give them the big hand. That's my first thing today. Second, no doubt this selection of shortlisting the cases for award is also a very big job. And you have to be fair and correct in shortlisting the cases. That part also is very hard work and requires meticulous working. So everywhere I think a lot of effort was put, and these sessions of those cases which were presented for the award, they're really some of the very excellent cases that we have seen in the, so I think in the end, what ends well is superb. I mean, you can't have it more. So all kinds of cases of interventional cardiology that we have seen, the venous intervention, valve intervention, and the coronary, all of them we have seen, and it's an excellent session, I would say. And thank you very much for everything.
We'll call upon the President-elect, Dr. P.C. Tell one, sir. Sir, you have to tell a few words, you know. Now you will be the master for 1 year. After this, everything is yours.
Good afternoon. Dr. Pratap Kumar and Dr. Sridhar Kasturi made everything brilliant. And the meeting was perfect, well attended, and the cases were live cases, and all the cases that demonstrated was very good. These award session cases were selected in a very meticulous way. I know so many presentations were there sent, and to select the first 8 cases with a Herculean task. They have done it. Very excellent cases and really educative cases. And I congratulate now Pratap Kumar, Sridhar Kasturi, and all the people who presented today and for this excellent award ceremony. Thank you very much.
So I'll call upon Dr. Gerald Warner to tell a few words, sir, before concluding.
Well, as one of the international faculty, I think the international faculty was honored to be invited to this prestigious meeting. We all took something home, the huge amount of live case presentation, all meticulously done. Also the case presentations where I also took part, where enthusiastic young physicians are there. That is a good sign for the future of India, and of course soon to be the biggest PCI country in the world. So congratulations.
I'll request Dr. Imad Siban to tell. Sir, everybody should tell 1 or 2 words.
I have not that much to add for Gerald, what have said by Gerald, but I would confirm that I am really proud and enlightened to be here with you as international faculty. I have seen really fantastic cases, very high-level presentation, very good discussion. I'm going back home with something new for me also as well. Thank you and congratulations.
I will call our own person. Actually, no, I will call Wakar.
Thank you very much. I mean, everybody has said everything. I'm representing the Gulf Intervention Society, and I'd like to thank Pratap Kumar and the organizers for inviting us. This is the first time we are here. We were 3 people, and hopefully in coming years we will have more participation and we will be able to invite you all to our meeting. I learned a lot. The live cases and the case presentations were excellent. Attendance was excellent, and I did learn a lot of new things. So thank you all very much.
The last comment from Sudhir, our own friend, but in UK, but he speaks only in Hindi.
Yeah. Thank you very much. I think I would like to thank the leadership of CSI, Dr. Pratap Kumar, Dr. Sridhar Kasturi for organizing such a great meeting. And I attend several meetings, obviously focused meeting, broad meeting, but this meeting was a very high quality. Case presentations were excellent. And I would like to give an extra round of applause to Dr. Pratap Kumar for his timekeeping. Can everybody please? I think he should get a special award for this timekeeping and very well organizing this meeting. Thank you all.
1 or 2 comments from the crowd. If I wanted 1 or 2 comments from the crowd, because you can take the mic. Now we are standing, you can just take the mic. 1 or 2 comments, please. Can have an industry, can have a doctor. Manoj, we want to talk. Just 1 or 2 comments. Take the mic.
Hi.
Start. Mic is not working. Give the mic now.
Yeah, it's working.
Okay, working.
I thank the chair and the organizing secretary and especially Dr. Pratap for providing us with a wide array of cases and the variety of in every sectors of cardiology. And there is a sincere request. I wish all these videos are uploaded in the NIC website so that we can...
We will actually try and we will request the CSI Central Committee, then only we can do that. I think I will request, there are two great giants are sitting. With their permission, we can do that.
Thank you.
It will available in app. It is available in app.
Oh, okay, thank you.
Manoj, any industry guys wanted to talk, just come forward for 1 or 2 people, not more than that.
I think year by year, we have been significantly advancing the conduct of National Interventional Council. I've seen in the past 20 years where it was just confined to about 1.5 days, Saturday afternoon and then Sunday, and it was primarily a PTC registry. Now we have ramified ourselves into multidisciplinary presentations in various specialties of the interventional cardiology, and there's been ample scope for 4 days, including 1 day dedicated for the fellows, giving ample scope for them to learn and upgrade their skills. And it's wonderful effort from the scientific chairman, Dr. Pratap, and Dr. Sridhar Kasturi. I should say that he has made a splendid feast, like Hyderabad biryani. It's a splendid feast of academic as well as the arrangements here. And my wholehearted thanks to all of you who had organized this.
Thank you. We will go to the prize distribution. The third prize will be announced first. The 1 lakh rupee will go to none other than Dr. Alluri Ashok Raju, who presented the percutaneous myvalve pulmonary implantation, dysfunctional pyramidal right outflow tract. That will be given by none other than our president will give that. It will be cost. Rajiv Bharadwaj. He'll be getting 2 lakhs rupees. The grand finale, the first prize, 3 lakhs rupees. Can you predict who will get it? Lokesh MR. The wonderful aortic aneurysm case getting the first prize. The interesting part is actually no coronary guy got a prize. I was surprised. And when I got a prize in India Live, everybody was telling structural, peripheral, and other people take the award. Actually, I'm telling in this year I got a prize from India Live. That was for the coronary. But now you just look at the structural, aortic, and the EP took all the 3 prizes. And because these people are all coronary people, that is why they don't like coronary. Thank you very much. It was a wonderful day, and I think the last word will come from the organizing secretary and the host.
Yeah.
If everybody can
please move forward to take a group photograph.
A group photograph.
We request you to have a photograph.
Before leaving, one photo.
Please move forward. I don't know how to express my gratitude. I can say only in few words. I can express in only few words. That is a big thanks from my bottom of the heart. So I am also thankful to CSI President, Dr. Vijay Bong, Dr. Roy, Honorary Secretary, and President-elect, Dr. P.C. Rath, and Scientific Chairman, Dr. Pratap Kumar, and all the CSI executive members, national faculty, international faculty, and all the delegates, and all the top management and young executives from pharma and device industry. And not only these people, I'm also thankful to all ProMax for spectacular audiovisual arrangements, and even Pratap Jain for creating the podium and the hardware, and all the media, everybody, and even Hybiz people, even management consultant, Sandhya, Rajgopal, who helped me immensely. Before that, let me express my immense thanks to my team members. Please give a big round of applause. Dr. Pratap Gar, you have to give a big applause to my team members. Come. Chandrasekhar, where is Mani? Where is Mani? Where is Ravi? Ravi Kumar.
Money, odi.
Come, Mani. Come, all of you come. Kalyan. Come. Where is Ravi? Is there?
Come.
Come, Ravi. Come. So, Sai Baba, you can also come. So, particularly, especially I have to thank the Sun Pharma, Intas, Ares Life Sciences, almost all companies, including Relicis company, Boston, Thermo, Translimnia, name every company supported us. Really, I'm thankful to each and everyone. And because of your participation and contribution, I made it possible. Thank you, one and all. Any mistakes are there, any inconvenience there, please forgive me. I will try to rectify, give me feedback. Mistakes are happens, and this is common with humans. Because I'm a human, I'm bound to do mistakes. Please, but I am at the same time ready to rectify it. Thank you, one and all.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे